Good afternoon, sir, everybody. Arvind, sir.
Namaskar, madam.
Good afternoon, ma'am.
Good. Sir,
Arvind Chandru ಬಂದಿದ್ದಾರೆ.
sir,
ಅದೇ
yes,
ನೋಡ್ದೆ.
sir.
ಇನ್ನು 2 ನಿಮಿಷ ಇದೆ ಸರ್.
2 ನಿಮಿಷ ಇದೆ ಸರ್.
ಐ ಥಿಂಕ್ ಫಸ್ಟ್ ಸ್ಪೀಕರ್ ಜೊತೆ ಮಾತಾಡಿದಿರಾ ಚಂದ್ರು?
ಎಸ್ ಸರ್, ಎಸ್ ಸರ್, ರೆಡಿ ಇದ್ದಾರೆ ಸರ್.
ಓಕೆ.
Hello.
Sir.
Sonal, are you there? Still ilvalla Chandru avaru?
ಚಂದ್ರು ಚಂದ್ರಶೇಖರ್?
Let me call him.
ಎಸ್ ಸರ್. ಸರ್ ಕಾಲ್ ಮಾಡ್ತಾ ಇದೀವಿ ಸರ್ ಇನ್ನೊಂದ್ಸರಿ. ಲಾಗಿನ್ ಆಗುತ್ತೆ.
Yes.
ನಮಸ್ಕಾರ ಗೋಧಿ ಸರ್.
ನಮಸ್ಕಾರ.
ನಮಸ್ಕಾರ ಸರ್.
ಎಸ್ ಸರ್. Sir, he'll log in, sir. Just now contacted. He's getting.
Good evening, sir.
Good evening, sir.
Good evening.
Ramakrishna, sir.
Yeah, starting.
Yeah,
Hmm.
yes, sir. Just a minute.
Yeah.
Sir, 1 minute is there, sir.
Okay, okay. ಎಲ್ಲ ಚೆನ್ನಾಗಿ ರೆಡಿ ಆಗ್ತಾ ಇದೆ.
ಬಂದಿದ್ರೆ ಸ್ಟಾರ್ಟ್ ಮಾಡಿ.
Madla, sir. Good evening. I welcome all the delegates, chairperson, speakers for the first day of our conference, that is 40th Kscicon 2022. And I welcome our first speaker, that is on the way. Is taking 1 minute to get login, sir.
If he is not logged in, Chandru, kindly call the second speaker.
Second speaker.
Yeah, we have requested everybody to log in 15 to 30 minutes early. So kindly call the second speaker.
Second speaker.
He can come in later.
Oh, okay, sir.
Is Dr. Guru Shantappa there? If he's there, you call him. Chandru, the boys must call the speakers and urge them to log in well in advance.
Sir,
Kindly
actually,
make it a routine for all the talks. Kindly make it a routine.
sir, actually we called, sir. He told exactly will come at 3 o'clock.
No, that is, we said we need 15 to 30 minutes early. In fact, we have even written that
Yes,
they
sir,
have to
yes.
log in 30 minutes early.
Second speaker.
So call
I'm
call
not seeing Gushantappa also.
yeah. call Dr. Tanga, all of them must log in early. Otherwise, we'll have this kind of a hiccup.
Sir, meanwhile, I welcome all of you for the inaugural of a CSEP program at 4:30, sir, between 4:30 and 4:45. And 8:45, we'll have an inauguration ceremony at 8:45. And our Vice Chancellor of RGHS is attending. Today, he has taken a charge as a VC and is attending at 8:45. And is the first function of his after assuming a charge as a VC. Sir Bandra.
Sir,
Yes, come, sir. Come. Sonal, sir, I welcome you, sir. It's already time 3
Yeah,
minutes later. Please,
apologies.
Chandru,
Yes, sir.
please invite the chairpersons and they
Yes,
will
sir.
then
Yes, sir.
hand it over to Sonal. Thank you.
Chairperson. I welcome first session chairperson Dr. Anupama Pujar and Dr. Dayanand Noli. Please, sir. And the speaker Sonal Asthana from Bangalore. Madam,
Thank you,
over to you,
sir.
madam.
Thank you, sir,
Okay.
for this opportunity. And I invite Dr. Sonal Asthana to start his speak. Over to you, sir.
Yeah, good afternoon, and thank you so much to the office bearers and the dignitaries for this kind invitation. I sincerely apologize for being pulled into an emergency, as normally happens whenever we have to give a talk. We get sidetracked because of that. But I will stick to time, and apologies for the delay. So the topic today is an important one: arterial blood gas for surgeons. And I'd like to introduce our colleagues and perhaps some of our junior colleagues to what is really a very versatile test, which will actually tell us about the actual physiological state of a patient. And certainly nowadays, if I have to ask for one test, which will tell us how sick a particular patient is, then an ABG would be the first one. This has been a little bit unnecessarily complicated. So I shall talk about what it applies to the surgeons and perhaps avoid many of the complicated issues. Broadly speaking, as you all know, the pH is essentially the level of acidity of the body fluid, which is actually the log of the H ion concentration in the blood. The normal pH range is between 7.36 to 7.44. This is very, very important because a lot of the physiological functions, such as enzymatic functions, metabolic functions, actually function within a range of acidity and alkalinity. And for body's hemostasis, it's very important to maintain the pH at a particular point of time. And a pH of 7.4 corresponds to a hydrogen ion concentration of 40. The next slide, please. So broadly speaking, we have to do a little bit two things. One is acidemia. When the absolute pH, the first number that you read in an ABG is below 7.36, you know that the patient has got acidemia or acidosis. And the second thing is that the pH is above 7.44, which means alkalosis. So broadly speaking, the terms that we need to maintain or components that we need to measure are the measure of acidity or alkalinity, that's the pH, the partial pressure of the oxygen, which is ideally should be between 80 to 100 millimeters of mercury, the PCO2 or the carbon dioxide, which is roughly half that, between 35 and 45, the bicarbonate value, which is a calculated value, which is the amount of bicarbonate present in the blood. And the other important concept to understand is the base excess, which basically tells you whether the bicarbonate is insufficient or in excess. It normally ranges from -2 to +2. A negative value indicates that the bicarbonate is not sufficient, so it indicates acidosis. Next slide, please. So the body obviously has a lot of defenses against change in pH because it's such an important metabolic function. The first is obviously the acid-base buffer function, which reacts actually within fractions of seconds. And the other is the respiratory system. So for example, when a lot of carbon dioxide or lots of acid builds up in the blood, automatically the first response is to stimulate the respiratory center to hyperventilate, get rid of the carbon dioxide so that you are able to reduce the amount of acid in the blood, which is the respiratory compensation. So all of these work in slightly different ways. The acid-base buffer function, which involves a lot of the functioning circulating proteins as well, functions in reacts in seconds. The respiratory system reacts in minutes, and the kidneys, which take a little longer, are the most powerful buffers that we have against. They can eliminate excess acid abuse from the body, and this is actually the most powerful function we have. Next slide again, please. So broadly speaking, we're dealing with 4 broad acid-base disorders. I'm just going to limit myself to these 4 because to prevent it from becoming unnecessarily complex. Metabolic acidosis, which is a primary decrease in the bicarbonate. Metabolic alkalosis, which is a primary increase in the bicarbonate. Respiratory acidosis, which basically tells us whether the carbon dioxide is actually very high, and respiratory alkalosis, which is the opposite number. So the broad thing is that the body endeavors to maintain a constant ratio of the PCO2, as we know, which is between 35 and 45 on the bicarbonate. And that actually will tell us whether the pH is adequate or not at the extracellular level. Next slide, please. So, and again, we must know that the buffer moves in the opposite direction of the primary problem. So if the problem is metabolic acidosis, acid building up in the blood, then you know that the respiratory compensation will be alkalotic. So they will try to reduce the carbon dioxide. So next slide, please. So basically, that's what basically happens, that in your metabolic acidosis, if I highlight it here, the third point here, the bicarbonate goes down, but the PCO2 also goes down because the breathing increases and the body tries to get rid of carbon dioxide to reduce the acid level and bring the pH back and maintain the ratio as maintained above. Next slide, please. So when you get a blood gas in your hand, how do you approach it? Firstly, is it a normal blood gas? Is there a problem with the machine? Is it an arterial blood gas? Is it a venous blood gas? What is the primary pathology? So this is a 7-step way in which we will check how to read an ABG in a very, very easy fashion. The next slide, please. So the Henderson equation, please ignore the thing on the left. I've just put it up to for sort of reference sake. But you must understand that the pH and the H ion concentration actually has to match. Okay, so there are separate ways of calculating it, in which you actually calculate the H ion, which is not very difficult to do. The PCO2 divided by bicarbonate into 24, and then you get an idea of whether the pH and the H are matching. So basically, when your normal pH is there, the 7.4 level, your approximate higher H ion concentration is 40. Next slide again, please. So basically, we first do this, and then we do the calculation. And if this is valid, then you know that the ABG is actually working. The other bigger problem that we get sometimes is knowing whether it is an arterial blood gas or a venous blood gas. So essentially, as we had seen before, the PO2 is normally between 80 to 100, and the PSO2 is about half that. The VBG would actually have the PCO2, which is about twice the arterial PCO2. Okay. So if you have the ratio of the PO2 PCO2, that's actually a thumb rule to tell you whether your sample is arterial or venous. Next slide, please. So again, then the step 2 is acidosis or alkalosis. We've talked about it. So you know your primary problem, whether it's acidosis or alkalosis. Next slide again, please. The third thing, you want to know whether it's respiratory or metabolic. So that will be told you about the PCO2 level. So for example, if your pH is below 7.35, your acidosis, then basically your PaCO2 should rise. Okay, and if the pH is above 7.4, the PaCO2 should fall. Okay, So basically, if the problem is, just please go back to the previous slide. If the problem is respiratory, then the pH and the PaSO2 will move in opposite directions. That is a primary respiratory problem. Next slide, please. And again, the next step is to bicarbonate. If your pH and your bicarbonate are actually moving in the same direction, that means a low bicarbonate and a low pH, and often a low base deficit, then your primary problem is metabolic. Next slide again, please. So when we look at respiratory acidosis, often you have people who come to you with obstructed breathing because of a head injury, respiratory center depression, or because of medication. Then you have a PCO2 that is greater than 45, and you have a pH that is less than 7.35. So this, as decided, they're moving in opposite directions. So it is respiratory acidosis. Next slide again. And alkalosis is obviously the other way, where your PCO2 is low and the pH is greater than 7.5. Again, this is because of anxiety, often because of mechanical ventilation if there's hyperventilation, or sepsis. Next slide again, please. Acidosis, again, broadly speaking, if your bicarbonate level is less than 22, if your base excess is greater than or less than -2, and if your pH is less than 7.35, then we have metabolic acidosis. This is probably the most common thing one would encounter in patients of sepsis or in the post-op setting. Next slide, please. So again, metabolic alkalosis is a pH. As we mentioned, the two important things are bicarbonate and pH. And then, of course, a high bicarbonate and high pH would indicate metabolic alkalosis. And of course, the urinary chloride plays a very important role. Next slide again. Because if you measure the urinary chloride, you can get an idea of what is actually causing the metabolic alkalosis. Is it vomiting, in which case the chloride will be low, or is it mineralocorticoid excess, for example, in which the chloride is a little bit high? Next slide again, please. Okay, so now the next slide is, okay, now you have a problem, you have a acidosis alkalosis, whether it is respiratory or metabolic, you know that now. But now if you have a respiratory problem, then you have to figure out whether it has been there for a long time, okay? So essentially, if you have respiratory acidosis, there is a thumb rule by which you can see your PaSO2, if it increases by 10, your bicarb should increase by 1, okay? If it is chronic, then a PaSO2 increase of 10 does not elicit a similar or corresponding increase in bicarb, because there is compensation through other mechanisms, most important renal, okay? And then with alkalosis, it's a little bit opposite. So if your PaSO2 is decreasing, then your bicarb should also decrease by 2, and it decreases more if in cases of chronic respiratory alkalosis. Next slide again, please. So essentially, it goes up by 1 for 10 PaSO2 up in respiratory acidosis, 2 for 10 PaSO2 down in respiratory alkalosis, 3 for 10 PaSO2 up, etc., and 4 in chronic. Next slide, please. So yeah, so basically the calculation is quite simple. It's 1, 2, 3, and 4 as mentioned. Next slide again, please. Yeah, and metabolic acidosis, again, you must know a very simple way of looking at it is just if your PaCO2 corresponds to the last 2 digits of your pH, then you know that this is compensated. So if it's 7.40 and a PaCO2 is around 40, then you know that it's actually compensated. But if you have a PaCO2 of 60, then obviously it is not compensated. Next slide again, please. Okay, now the next question, I can see a question in the chat about the anion gap. Next slide again. So again, an anion gap basically is a difference in what is causing the metabolic acidosis. Is it a combination? Is it because of an accumulation of a loss of bicarbonate, which can happen sometimes, because of electrolyte abnormalities, or in some cases even because of diuretics, or because of an accumulation of non-volatile acids. So broadly speaking, you will get this. It's a very simple calculation of the serum sodium minus a sum of the chloride plus the bicarbonate, which is normally around 12. Next slide again, please. So basically, once you have the observed anion gap, you have to calculate the adjusted anion gap. Okay. Again, there's a small formula for this. Most of this is available on the web or in apps, so you don't really need to learn many of these formulas now. So if you see an anion gap, and you do the observed anion, it's 2.5 times 4 minus the serum albumin, because remember, we're looking at non-volatile acids. So not all of them will be present in the ionized form in the blood. Next slide again, please. Some of the causes, you can see that mud pilers is the mnemonic that you normally use for high anion gap metabolic acidosis. So diabetic ketoacidosis, high HE, uremia acidosis, ethanol, which is a very common reason, high acidosis. So a lot of the problems that we encounter very commonly in critical care are associated with a high anion gap. Next slide again, please. And a non-high AG metabolic acidosis. Again, if a uremia has happened very suddenly, a sudden AKI, then can cause that. Diarrhea can cause this. Renal tubular acidosis can cause this. Or if you have inadequately or inappropriately resuscitated somebody only with, say, saline infusions, with a non-balanced infusion, then you can get a non-anion gap metabolic acidosis. Next slide again, please. So basically, once the high anion gap acidosis is present, you have to calculate the delta gap. So basically, you're trying to see whether you are able to predict whether it's one problem you're dealing with or two. So the delta gap is basically the change in the anion gap. That is how the anion gap is different from what should be normal around 2 and the delta HCO3. So how different is it from 24? So again, if it's greater than 6, metabolic alkalosis, less than 6, it's non-AG metabolic acidosis. Next slide again, please. Again, please go ahead forward. So, I mean, do we have time, or are we? I can just talk about one case, suppose.
We are okay. We have time, Sonal. Please go ahead. Yeah.
Okay. So this is one sort of case that we might find. You have a patient who was brought to ER. He was lying with an anti-Lecker bottle. BP is fine. The heart rate is a bit tachycardic. Respiratory rate is perhaps slightly up. Is responsive. Pupils are all right. Now look at the pH, right? So we'll just run it through our sort of template, and then we'll see how we get. So you remember the pH is 7.1, PCO2 is 35, PO2 is 90, and these numbers are as below, the creatinine is a little bit high. The lactate is 1, which is always very good. Next slide again, please. Next slide, please. Yeah. So basically now we're looking at the H ion concentration. Basically we have the bicarb divided by the anion gap, the H ion, which is about 70, okay, and it corresponds to our pH, which is about 7.1 here. So it's approximately the same, 7.1 leads to about 79. Our calculated value is between 70 to 78 by different methods. So we know that the machine is working, and our calculations are okay. The next slide again, please. So of course, pH number 1, easy, it's acidemia. The pH and bicarb are both in the same direction, low pH and low bicarb. So it's metabolic acidosis. As you can see, ketones are negative, lactate is 1. Okay, so that gives you a few ideas about what might be going on, which I'll talk about after this case. Next slide. So step 4, of course, this is a primary metabolic disorder, so we're not looking at respiratory alkalosis. So 5 is we need to figure out what the PCO2 should be. So again, when we're looking at the PCO2, here you can see that the actual PCO2 is 35, and if it was uncompensated, so it would actually be, it would be around 26. So basically, that also tells you that the PCO2 is also coming down, this respiratory acidosis. And the anion gap, we've talked about it. It's high, so it's high anion gap metabolic acidosis. Next slide again, please. So we talked about the delta gap, which is the anion gap excess and the bicarb deficit. Bicarb was 12, anion gas excess calculated above 24. So it's greater than 6, right? So you have high anion gap metabolosis, you have respiratory acidosis and metabolic, actually that's the other way around, respiratory alkalosis and metabolic acidosis. So, I mean, I'm just going to stop a little bit on that case and talk about the 2 other things that we have not mentioned here. One is the serum lactate. So once you have acidosis, you have to also look at what might be driving it. So in surgical practice, there are 2 kinds of acidosis that sort of really bother us. Is the acidosis coming because of dehydration, dyselectrolytemia, sepsis, which perhaps means that our management is more critical care? Or is it coming from, say, the liver or the gut, which might indicate that we need to go in surgically? So if you have metabolic acidosis, that means a pH that is lower than 7.35, you have a base excess that is -4 or below, -2 or below, you have low bicarb, and you have a high lactate. That is a fairly worrying situation. So that means that you should also keep surgical problems in place, say, is there any dead bowel? Is there gangrene that is going on? So these are the patients that we need to watch very carefully from a surgical perspective to see whether or not they might need surgical intervention. While on if the lactate is normal, which was very reassuring in the first case, in this case, that fluid resuscitation might be the answer. So in this situation, you would actually perhaps leave it more to your critical care colleagues to manage while keeping an eye on the patient. So next slide, please. Okay, so now we have a patient with nausea, recurrent vomiting. She had taken a lot of tablets, aspirin for joint pain, and before she got this. So now you have the opposite problem, right? You have a pH of 7.56, a PCO2 of 32, and a bicarb of 33. Next slide again, please. So again, we do our calculation to check whether it's valid or not. We know, we find out when we look at our table that the H ion concentration matches our pH, which makes it valid. Actually, these numbers are there on most ABGs these days, so you don't need to do the math here. You know that it's above 7.345, it's alkalosis. The pH and the bicarb are actually in the same direction. The bicarb is 33 and the pH is 7.56, so it's metabolic. And then, of course, you are looking at the respiration. So that is actually also in the same direction. So it's metabolic acidosis as well as respiratory alkalosis. Okay. All right. So perhaps I'm just going to stop here for a minute because the other two cases are a little bit more critical care oriented. And I'll probably talk a little bit about some of the questions that have started to come in as well. Firstly, the role of bicarb infusion. Most critical care doctors will not like bicarb infusion because bicarb is basically correcting a symptom. You are treating the value rather than the cause. The important thing here is to figure out what is the cause, what is the driver of your metabolic problem, and try to address it. For example, if the driver is dehydration because of vomiting, as you've seen in one of the earlier cases, if that is what's driving it, or if it's because of fluid depletion because of shock, for example, in sepsis.
Sorry to interrupt, sir. We have 2 more minutes for the presentation and 5 minutes for the discussion we have.
Okay, so I'm going to stop my presentation now so that we have more time for discussion. Thank you so much, and I'm happy to take any questions right now.
There's another question, Sonal, in the chat box about the effect of RL infusion on acid-base balance. Yeah.
Sure. So essentially, it is a good question. RL infusion is probably preferred to just a normal saline infusion when it comes to correcting the acid-base balance. The only downside of an RL infusion sometimes is that it can falsely lead you to overestimate the serum lactate level. So it's important that if you're giving an RL infusion, you should stop for at least 10 to 15 minutes before you actually check your ABG. They are just to stop that confusion. As you know, lactate is metabolized very, very rapidly. But certainly the fluid of choice for a lot of resuscitation is actually RL in patients where the potassium is normal and near normal and where they do not have acute kidney injury. Talking about bicarbonate, we talked about metabolic acidosis. I mean, it is used, when we have an acute condition where we have very, very low pH in order to support the pH to a normal level. But more critical care doctors will sort of advise addressing the primary problem, which is actually driving the acidosis. And if it is fluid resuscitation with the adequate right amount of fluid, then that is what will actually solve the problem rather than just bicarbonate. The other problem with bicarbonate is, one is that there will be fluid overload because the amount of fluid you give is quite a lot. And secondly, the PCO2 might also increase. Next slide, please. I mean, that's. I hope I've answered those 2 questions.
Yeah. Could you say a few words about the importance of measuring serum electrolytes in concurrence with the ABG and how the 2 pan out?
Yes. No, thank you. That's a very good question. As you can see, a lot of these calculations, the reason I've skipped over these is because they are already calculated and printed on your ABG sheet. So a lot of the validations can be done in your mind when you're actually reading it off the sheet. So a lot of the ABG machines will give you the sodium and potassium. Of course, whether it's calibrated well or not is important. So certainly they will give you additional clues. For example, if you have a patient like the lady in question who presented after having aspirin. So she's had a lot of vomiting. No, so basically a low potassium is something that you would actually suspect, and checking the potassium in those situations would be very, very critical. Because if such a patient goes into into arrhythmias, at least you need to know what is the potential cause of what is actually driving those. So certainly these ABGs should be measured along with the electrolytes and the creatinine. Now, the only qualifier I would add is that what is more important than creatinine actually is the sodium and potassium, especially in the acute situation. Because sodium and potassium change rapidly, creatinine takes time to change. And as we have talked about, the main reason why we would be worried about the creatinine changing would be to know whether the renal buffer, which is an important buffer in the body, is compromised or not. So certainly, I think that when we do an ABG, we should interpret it in the context of electrolytes in the acute setting.
Sir, in post-operative phase, where exactly you advocate? I mean, indications for ABG. When we should go ahead with do the ABG?
No,
what are the clinical parameters?
Sure. So I think that it depends on what kind of surgery you have actually performed, and it depends a lot on the context of this. So have you operated on a very unstable patient who's critically ill on inotropes and ventilation? Then certainly ABG, checking ABG 2 or 3 times a day would be sensible, because you need to know the extent of resuscitation. You also need to see the improvement in sort of serial ABGs to see whether if you have actually changed your antibiotics or resuscitated with fluids, whether it made any difference at all. So I think that in the routine practice for an elective case, probably the indications are very, very few. What is very important for ABG is when you're dealing with a sick patient. So you may have a patient stay in the ward who's post-op day 4 after a bowel resection. The abdomen's a little distended. There's a little bit of tachycardia. You're not sure whether there's a leak, whether there's a sepsis or not. So the first test there, in my view, there to send would be an ABG. Because there, if you are seeing building up metabolic acidosis, you're seeing a high lactate, you're seeing a high base deficit, then you have an indicator of actually perhaps imaging that patient, at least making sure that the patient is managed in ICU, shifted back to ICU for management. So as a first indicator of a post-op patient who you think might be having some complications, an ABG is very valuable.
Thank you, sir.
One more question in the chat box, Dr. Lakshman.
Yeah. Sonal, do you want to take it, please?
Yeah.
It's about calcium infusion. Yeah.
Sure. I think that again with arrest, it really depends on the context of that. So calcium is given in several different contexts. If you have a rapid, say, a shock because of hemorrhage, you're giving massive blood transfusion, you would give calcium. Okay. Calcium is also given in cases of hyperkalemia, where you have sudden hyperkalemia and you have arrhythmias that you may need to sort of stabilize the cardiac membranes and prevent patients from going into an arrhythmia. So I think that it's very difficult to answer that question without addressing the context in which this calcium bicarbonate is given. It's certainly helpful in the cases that I mentioned right now.
Sir, I'm sorry to interrupt, but our time is up. With the permission of the chairpersons, may we conclude this session?
Yeah. Can the chairpersons please thank the speaker? And Sonal, a personal request, please stay on for a bit and see if there are any more questions on the chat box. Kindly answer them. Would be very grateful. Thank you. Yeah.
Sir, it was a wonderful talk. Very nice. But unfortunately, you don't have much time here to discuss the exhaustive topic. Anyway, thank you, sir, on the behalf of our association. We'll go ahead with the second topic now.
Thank you for having me. Thank you, sir.
I would like to thank Dr. Anupama and Dr. Dayanand Noli for chairing this session. Thank you, Dr. Sonal, for this wonderful presentation. I would now like to call Dr. Gurushantappa to enlighten us about the topic, minimally invasive parathyroid surgery. Sir?
Yeah, good afternoon. I am there. Yeah.
Thank you, sir.
Sorry to interrupt, sir. Chairpersons are on for the next 2 talks as well. Screen managers, please note that. Chairpersons are on for the next 2 talks as well. So don't.
Yes, sir. Sorry for the confusion, sir.
Sorry. Please look at these things carefully. Gurushantappa, sir.
Yes, sir. Sir, at the outset, I thank the chairman and the secretary of KCSI, and Dr. Lakshman, the chairman scientific committee, for having given this opportunity of giving a talk on minimal invasive surgery on parathyroid glands. Good afternoon, everyone. With the permission of the chairpersons, I'll be starting my topic. I bring greetings from our institute, KIMS Hubli. Before I go into the operative part of on parathyroid surgeries, I'll be giving a few slides with the information on parathyroid glands anatomy, which is really important for doing surgeries and finding out the disease. And second, I'll be mentioning few tests what are required. Then I'll be mentioning 3 videos to show what exactly the minimal invasive surgery is done on parathyroid glands. Coming to the little bit of anatomy on parathyroid glands, the superior parathyroid glands, in 95% of the cases, the position is fixed, that is in topic position. And in 5% of the cases, the position will be in a different area, that is ectopic position. Compared to the inferior parathyroid glands, which 90% of them have got a topic fixed position and 10% will be in a different areas. Of the cases, and upper and lower parathyroid glands, both the glands, most of the times they are supplied by inferior thyroid arteries. And they are identified by their appearance like golden yellow in color and surrounded by typically fat globule. And 85% of the inferior parathyroid glands are found at the junction. If you draw a circle between the inferior thyroid artery branch, recurrent laryngeal nerve, and parathyroid gland, it will be 1 centimeter circle. So the identification for the inferior parathyroid gland, that is a point. Next slide, please. Again, to repeat, blood supply. Yeah, I said all the 4 glands are supplied by branches from the inferior thyroid artery. Sometimes this inferior thyroid artery can be absent. It is more common on the left side, the absence of inferior parathyroid artery. In such a situation, we may have a non-recurrent laryngeal nerve. And 20 to 40% of the superior parathyroid blood supply may be from the superior thyroid artery itself. Next slide, please. As I mentioned, there can be different positions in spite of having a 95% in a fixed position. The superior parathyroid gland can be behind the cricothyroid at the junction of the cricothyroid and the thyroid cartilage. It can be behind the thyroid gland, or it can be retropharyngeal position. Compared to the inferior parathyroid, ideally they are at the lower pole, or it can be in the mediastinum, in the thymic area, or it can be behind the trachea. Next slide. Just a few words about why exactly we should be in what conditions we will be doing minimal invasive surgery on parathyroid glands. Most often the surgery is being done for adenomas. These adenomas, invariably, they will have associated hyperparathyroidism or hypercalcemia, which needs to be treated in 90% of the cases. These adenomas can be single most often, but it can be multiple involving more than a gland in 5% of the cases. It can be 4-gland hyperplasia in 10% of the cases, where entirely it is a different issue to deal with. And 1% of the hypercalcemia could be because of carcinomas. And the remaining are 5% are hereditary syndromes. And patient can have a normal calcium level with hyperparathyroidism. Next slide, please. To confirm that the patient has got hyperparathyroidism or hypercalcemia, these minimum tests are required. Invariably, these patients will have an increased calcium level. Anything above 1 milligrams of percentage of the calcium is considered as hypercalcemia and needs to be evaluated further to find out whether this hypercalcemia is because of increased parathyroid gland activity by estimating parathyroid hormone. And they will have associated hypophosphatemia because of the renal involvement. And even the 24 hours urinary calcium may be increased in such situations. Next slide, please. To localize the tumor, we need to, when we treat by surgical means, we need to know, since there are 4 glands normally, or maybe more than 4 glands, so we should find out where exactly is the pathology. That gland, we call it as a culprit gland. So to find out the culprit gland in hyperparathyroidism or hypercalcemia, there are few investigations which are really required so that we can target our treatment. The first and the simple investigation is a USG neck. If you add Doppler to that, probably it will give more information so that we can find out the culprit gland. The system EV nuclear scan is a subtraction scan where initially both the thyroid and parathyroid will take up the nuclear agent. Then after a few hours, the thyroid will be washed out and parathyroid will be made out with this scan. CT, MRI, PET scans are not very often used. They have their own indications. And I have put a questionable mark for USG guide FNAC may not be required in all the cases. Next slide. Next slide, please. To give a few the photographs, this is sonography showing a hypoechoic nodule behind the thyroid, which can be really made out, and it will have a more vascularity that will confirm on sonography. Since it is it depends on the person who does ultrasound, but if it is done by expertise, but definitely it is going to give the diagnosis. Next slide. Like I mentioned, system may be skin. Yeah, initially both the thyroid and parathyroid will take up, and after 2.5 hours, parathyroid will be made out. It is more so in an ectopic position. Definitely, this is one of the investigation which is very important for the diagnosis. Combination of sonography and system AV scan will give 90% of the cases. It will give where exactly is the gland, which is the culprit gland. Next slide. Like I mentioned, CT, MRI, and PET scan not very often. They have got a limited indications in case of persistent or recurrent hypercalcemia, where earlier person has been treated surgically, but still develops either the recurrent hypercalcemia remains. In such a situation, definitely this will help. And in a suspected or approved case of parathyroid carcinomas, to know the extensive metastatic disease, definitely, and an ectopic parathyroid tissue in the form of in the chest, it will give more information. Next slide. Angiography earlier, it used to be one of the important investigation, but nowadays, again, it is for the recurrent or persistent hypercalcemia. This is the investigation. And this investigation is still being done whenever our plan is to get a venous sampling for parathyroid hormone assay. Next slide. There is one more on table, that is intraoperative localization also is important. If you have a problems in a four gland hyperplasia, this is definitely, it is going to help. Getting parathyroid hormones just before surgery, 5 minutes, 10 minutes after surgery, and there has to be a 50% decrease in baseline levels, indicates that yes, we have removed the culprit gland. There is an entity called radio-guided parathyroidectomy, in which the system injection is given 2 to 4 hours, technetium system is given 2 to 4 hours before surgery. Then the handheld gamma probe is placed over the neck to find out where exactly is the gland, and that gland can be removed. This is on table localization of culprit parathyroid gland. Next slide. Next slide, please. This is just a photograph showing how exactly this is a small incision taken over the neck, which I'm going to show you a video. Next slide. Can you play the video, please? These videos I have downloaded from the internet, showing how exactly this is the sonography showing the adenoma. This is a system AB scan showing the gland there. This is done under cervical block. That is a line, vertical line is along the sternocleidomastoid. That is a cricoid incision is at the mid or way off between the sternocleidomastoid and these are the routine instruments what are required for minimally invasive. I think you are fast forwarding. Just if you can play the video, it will be nice. These are the subplatysmal flaps with a 2 or 2.5 centimeter incision. The flaps are retracted. Then the area between the sternocleidomastoid laterally and the strap muscles medially. That is a plane we need to go. So medially we'll be retracting strap muscles and the thyroid gland all together. Then we will be on parathyroid gland. For this surgery, the localization, pre-op localization is really important. Is it a superior gland or the inferior parathyroid or right side or left side? Depending on that, this is the gland adenoma which is being removed. Next slide. This is the transaxillary endoscopic parathyroidectomy, where the incision is taken in the axillary fold. Sir, you can audio can be on for this video. There is an audio for this. It is in the subcutaneous plane. where the pectoralis major is lower down and a skin with a subcutaneous fat superiorly. This being dissected till the clavicle, till we go over the clavicle into the neck. Then that is upper one is the clavicular head of the sternocleidomastoid, pectoralis sternocleidomastoid. The retractor is placed underneath and lifted up. Then the dissection is done over the homoid between the thyroid medially and the carotid and interjugular vein laterally. There is a parathyroid gland in the lower part of it, and the recurrent laryngeal nerve is seen medial to parathyroid gland. Once we dissect out parathyroid adenoma, there will be a single leash of blood vessel which is going into the gland, which is cauterized with harmonic, and the gland is removed. Even on table with a nerve identification, nerve stimulator, recurrent laryngeal nerve can be identified. Next slide, please. This is one more method, that is transcervical endoscopic parathyroidectomy for parathyroid adenomas. The small incision is made in the suprasternal area to create a working space. So the advantage of transcervical is you can go on either side from the midline. So if a patient has got both two gland adenomas, so they can be approached with a single entity, unlike in the transaxillary where we have to be sure on each side where to go. This is inferior belly of the omoid. Then extra, the operating hand ports are placed under vision. Because of magnification, definitely we'll have the better view. So the gland is being identified and dissected. Even though it is a small leash of blood vessel supplying, they are given importance and attended nicely with coagulation. Next slide. If previous slide, please. If the gland is, next slide, please. If the gland is in an ectopic position, adenoma is in ectopic position, which has been demonstrated preoperatively. Earlier was the thoracotomy or a mediastenotomy removing, but nowadays it is being done with a thoracoscopic approach. Next slide. Injection of methylene blue in the preoperative period will identify the gland, and the thoracoscopic excision of mediastinal parathyroid adenoma is a known procedure and very helpful procedure. Next slide. So whenever we have diagnosed the adenoma as a culprit gland, one of the glands, we have to confirm that patient has got hypercalcemia and hyperparathyroidism with the investigation. Then we have to localize the gland, which is the gland which has got harboring the disease by means of these investigations. Then we have to confirm either on table or post-operative period that yes, what surgery we have done is the correct one, like in the form of removing the culprit gland. Interoperatively in the form of doing a parathyroid hormone assay or doing radio-guided parathyroidectomy. In the post-operative period, again assessing parathyroid hormones and serum calcium levels and assessing radioactivity of the excised gland, which should give at least 50 to 80% of the radioactivity if it is a correct gland. So this is how the confirmation and identification of parathyroid gland is done. Next slide. So confirmation of the surgical treatment, the activity of the removed parathyroid is checked with gamma probe to confirm the cure. The excised adenoma emits radioactivity at least 20% and often 50% in excess of the post-excision background. Finally, the post-excision radioactivity in all four quadrants of the neck should equalize. Next slide. Like the earlier, the traditional method was before we could identify where exactly which is the culprit gland. All 4 glands used to be explored initially with a big neck incision, and we used to remove all 3.5 gland, or remove all 4 and implant part of the gland in the sternocleidomastoid. Now, and general anesthesia was required, and intra-frozen section used to be done earlier, and patient used to get admitted for a few days. Nowadays, with the minimal invasive procedures, the affected gland, unilateral neck exploration is the rule, and a regional or local anesthesia or a cervical block, these procedures can be done. And a culprit gland, isolated culprit gland excision is a definite procedure, and the preoperative localization, definitely with the investigation, we can go ahead, and it is an ambulatory patient. Means patient can daycare surgery, he can go by uni. Next slide. Revision or remedial parathyroidectomy, it is for persistent hyperparathyroidism, that is called hypercalcemia within 6 months of surgery. That is called persistent, secondary to the left behind, or we have removed probably the uninvolved gland. Recurrent hyperparathyroidism, the person develops hypercalcemia after 6 months of the previous surgery. The causes for this probably were missed out in the first operation, or hyperplasia in autotransplanted gland, or probably the patient has developed adenoma in the remaining glands, or probably there is a carcinoma. Next slide. Next slide. There is an entity called parathyromatosis. If there is a seedling of this parathyroid tissue during procedure, it can grow there like an endometrial tissue. So that also may cause recurrent hyperparathyroidism. The complications pertaining to this procedure, persistent hypercalcemia, which can be in 1 to 20% of the patients, and a permanent hypocalcemia if the procedure is 4-gland exploration procedure, that is also around 20%. Injury to the recurrent laryngeal nerve, that is more common than external laryngeal nerve, around 1 to 10%, and there can be some amount of bleeding. Next slide. Once again, I thank for having given this opportunity in this forum. I thank the team of KSE-ASI. Thank you.
Sir, this minimal invasive surgery for thyroid, am I audible, sir?
Yeah, audible, sir.
The different routes are there, as you have mentioned, transaxillary and even in the external notch like that. The problem with thyroid surgery is the working space there. Amongst these different routes, which you would like to prefer, sir? Transaxillary or what is the method of this one?
This
entry.
Even we have a transoral and a transpectoral. Over the chest also it can be. If it is quite away from the targeted organ, probably will be more comfortable because we are experienced with our laparoscopic surgical procedures. A little bit away from the targeted gland. So over the pectoral areas. So probably that will be the best place to approach thyroid and parathyroid entities. But over transcervical and transaxillary, and if you are operating on a selected on one side, probably transaxillary will be a better option. If you want to see on either side, probably the transcervical will be a better option.
Are there any defined pressures to be maintained in the neck, sir?
There is nothing. In transaxillary, it is an open space there actually. It is a retractor which helps rather than the Nemo. But in transcervical, definitely, it is like around 15 to 18, the same pressure. It is there is nothing more than that.
And localization, there was a question by Dr. Godhi sir also about the cysta, maybe this nucleus, nucleus side and the MRI. Is it available, sir? This cysta maybe?
Cysta maybe scan is done routinely by nuclear medicine people.
Okay, so that the localization is done by them, and then we have to go to take incision, small incision, and go ahead and remove. That's what you want to say.
Exactly, exactly.
Okay, sir.
So
Nice talk, sir. Thank you.
Thank you, sir, for a nice talk. So what is your take on, like, opinion on transoral parathyroidectomy?
Definitely, I mentioned that. Yeah, it is nowadays it is being done routinely for thyroid surgeries by many endoscopic surgeons. Their claim is because they are going from above downwards, their approach will be better than dissection also will be less. Once it is they are crossing the floor method, they are into the neck. So that is their claim, and there is no incision outside. See, the oral incisions initially they look because of edema look horrible, but later everything will be normal and absolutely there won't be any extra incision. That is the greatest advantage of transoral.
Only thing is no, the anatomical looking at anatomy in a different
Yeah,
way.
reverse.
Reverse.
Yeah, it will be upside down.
Yeah. Thank you, sir. Thank you for nice talk.
Any other questions in the chat box I need to answer, Dr. Nuli?
No, sir. No, as of now. Any other questions anyone wants to ask, they can go ahead.
So Dr. Gode had asked about the sensitivity of system AB in comparison to MRI. Between the two, how do they compare in localizing the parathyroids? Yeah.
System AB is the best, sir. It is around 90 to 95%, sir. MRI may not be the investigation of choice for localizing primary adenomas. MRI and CT will be of more beneficial when we have a recurrent disease. So around 90 to 95% with system AB and sonography.
Sir, how often is the incidence, sir, this parathyroid adenomas? 90%
Yeah, we
of
do
them are
come
adenomas.
across once we have a suspicion of adenoma in the form of when we have a patient like what Bailey writes, like stones, bones, abdominal groans. So if we have a symptoms suggestive of that, where we have diagnosed as a pancreatitis, we have demonstrated there are multiple renal stones and get a calcium, very high calcium levels, and we get a parathyroid hormone very high. So that gives a clue, and then we start finding out parathyroid adenomas. Because we are detecting this disease nowadays, probably the procedures have increased.
So clinically symptoms wise, you will suggest this. If they are these symptoms, you go ahead and suspect parathyroid adenomas or something to do with parathyroid glands.
Correct, correct. Even they may go to psychiatrist. I had in the beginning of my practice, I had one young lady who was treated by psychiatrist and later found to have parathyroid adenoma.
Okay. So if I may come in, the diagnosis of hyperparathyroidism has taken a big leap after these biochemistry panels. Most of them, in fact, are asymptomatic. But in the panel, whether you want it or not, they give you 16 or 18 or 22 parameters. And then they discover hypercalcemia, and then they start the workup, as Professor Guru Shantappa mentioned. And that has been one of the commonest ways in which hyperparathyroidism is detected. And there are many papers which talk about when you should intervene when there is an asymptomatic hypercalcemia. Persistent hypercalcemia for a few months, even if it's asymptomatic, has to be attended to if it's hyperparathyroidism because of its end organ damage eventually. Thank you.
Yes. Thank you, Chairman, and thank you, Chairman and Secretary of KCSI and Dr. Lakshman, Scientific Committee Chairman. Thank you, one and all.
Thank you so much, sir. Guru Shantappa, sir.
Thank you. Thank you.
I would like to call Dr. Sharath Tanga, sir, to talk about the next session is early retirement, an option for surgeons. Sharath, sir.
Yes, please. Very good evening. Shall I start? Shall I start?
Yes, sir. Go ahead.
Can you get his? Yeah. Please get his PPT up.
Good evening, everyone. Chairpersons, Dr. Diana Nuli, Dr. Anupama Pujar, fellow ASI members, postgraduate students, and undergraduate students if they are. At the outset, let me thank the Karnataka State Chapter for having given me this opportunity to speak on a topic which has an air of taboo around it, whether early retirement is an option for a surgeon. Next slide, please. When I retired sometime in August 2020, young surgeons and colleagues together would express, hope I wish to follow your footsteps, wish I would opt for decisions like you. We feel we should also take a call like this. These were the random expressions when I retired and made it public. There is a definite undercurrent, which is aspirational in nature, to seek early retirement. An unexamined life is not worth living. This topic is addressed to a small niche group of professional surgeons. It is not for surgeons who belong to the top 5 to 10 percentile of surgeons who have made choices. They are happy with it and it's working with them. At the opposite spectrum, we have a group of people, that is the majority, 75%, who feel that thinking is craziness. They just fit in the peer group and go along with the majority of the peer group. This leaves behind a small group of people between 75 to 90%, that is about 15%. These are the group of surgeons who, for some reason, have a potential, leadership potential much beyond what they are doing now. But they are struggling to fit in the peer group. These are the people who keep struggling. A situation arises where conflicts keep increasing, and it is something like it takes a slow form of suicide or otherwise. This group is a minority group. So in sum and substance, this thought process is not going to be a mainstream thought process. It will cater to give a window of thought for people who are aspiring, who within their heart feel that at some point of time, they should be seeking to do something which is different from what they're doing now. The spectrum of early retirement will be defined, and it does not necessarily mean just retirement and do nothing. Next slide, please. Like any paradoxes of life, I'm confronted with a situation where I'm talking about early retirement to young postgraduates in the audience. But let me assure you that each group in the audience will be able to get something out of this topic, which will enable them in the decision process. Next slide, please. Let me make it very clear. When I talk about early retirement, there should not be any iota of doubt with respect to the glory of surgical profession. Even today, surgery is a branch of medicine wherein it stands high in the hierarchy with respect to the different modalities of treatment. Only when other modalities of treatment are not amenable, ineffective, they land up with surgeon. Next slide, please. Next slide, please. Now, our profession per se is bestowed with or empowered with the ability to make a change directly to the patient, not only in extirpating his disease, but also elevating his agony. Next slide, please. Next slide, please. Now, this is a clinical situation which each one of you will be familiar with. There is a patient who is malnourished with bone and skin, the chest rib being drawn. He comes to you with chronic pain abdomen, some things with signs and symptoms suggest you have chronic obstruction. You diagnose it most commonly a sort of tubercular abdomen, and then operatively it turns out to be a chronic perforation with dense adhesions. You do an appropriate surgery to this patient, and within 8 weeks' time, you see a radical transformation from the state he comes 8 weeks ago and from what he is today. This type of gratification can never be obtained elsewhere. That is the glory of surgical profession. Next slide, please. In an era where most of the life or professions at large have impurities which are increasing, but still we should be happy that surgery or medicine per se is still the most trusted profession across the world. Next slide, please. Next slide. Now we have just a depiction of how extreme and passion towards the profession can be. They value the profession so much that someone opts for to become medicine. A lifelong ambition to become a doctor happens at 56 years. A doctor who goes much beyond the structure of his regular treatment process. Next slide, please. This is not a very uncommon situation where we hear expressions like a 70-year-old surgeon saying, I plan to die treating patients. Contrasting that, a surgeon retires at 55 years by avoiding the normal traps. The bottom line in this instance would be that for each their own. Everyone is right according to their experiences, according to their situations. It is for you to determine what are your personal goals. And if there is a need, at least to give a thought process, get a perspective, get a food for thought, whether there are any other options which would enable me to have the complete manifestations of my capabilities. Next slide, please. Now, when I talk about early retirement, I did say that I don't mean early retirement is do nothing, retire and do nothing. That is not the meaning of early retirement. What it means basically is to get freedom, to seek freedom from something which is very much bounded to you. When we talk about early retirement, it could be an option for alternate medical careers. It could be an option for mid-course change of lane, something from a fast lane to mid lane or a slower lane, depending on what suits you. Voluntary retirement from malaligned positions, switch in profession, and something which is the ultimate is seeking freedom and independence. And time is a most essential element out of this. If you are able to get time, most of your issues are solved. Next slide, please. Now, when we talk about a topic which is like this, not a very uncommon topic, unconventional topic, we look for what are the situations across the globe. Are there any papers published on this? We hardly find scientific papers on this topic of early retirement across the globe. You have a lot of literature about early retirement in doctors, surgeons, multiple forums, but scientific literature somehow seems to be lacking. Recently in BMJ, in the year 2021, there was an article which published and which was titled like doctors seek early retire. The number of doctors seeking early retirement has tripled since 2008. Somewhere around that same time, probably acknowledging the ground situation, the president of the Royal College of Surgeons did express as an open letter expressing concern regarding early retirement figures. Next slide, please. So what makes surgeons to seek early retirement? Many options. They are personalized based on this. I just try to categorize a few of them. No longer surgical practice per se is a solo practice. It is not a small enterprise that it was earlier. We have seen a radical change with respect to group practice and, more importantly, corporate practice. That what I mean is a hospital which is run in the structure of corporate. You are now managed by the hospital management group. You are given assigned targets. You need to market. You become a commodity. The regulations don't seem to abate. They keep increasing. Our defensive practice is again ever increasing. It is always medical legal based angled practice which we are compelled to practice. Stress in surgeons, a known entity, early burnout, and low morale, which leads to emotional illness, in few instances suicides. Recently, we got a letter from our ASI president, Dr. Siddesh, talking about menace of middlemen in medicine. That is nothing but the manifestation of surgeons becoming a commodity. We are losing our pivotal position and the strength and the honor which was associated with the profession. Slowly, it is waning away. All of these are occurring not acutely, not over immediate, rather in immediate aftermath. They are taking place slowly, but the situation seems to get acute in recent times. Next slide, please. Now we talk about stress, that is the inability of an individual to adjust to the prevailing situation. We talk only more often with respect to what happens to the individual who has the stress. What are the behavioral responses it can give rise to? But at the same point, we also would realize that the stress in the surgeon gives rise to outcome effects as well. There is intellectual impairment, poor concentration, lack of judgment, lack of creativity, and complication rates are high. Next slide, please. Now, all this time, again, conventional teaching has been, we shall do a balancing act. But let us try to realize that in the present situation where accessibility of patient to doctor is very high, where we have become commodities, every specialty, every branch of stream of profession has its own requirement. It has its own tenets of practice. They are not compromisable. For example, we take conventional teaching of competency, compassion, and credibility, the three pillars of practice. When this imbalance starts happening, that is the area where you see there is a rise in conflict. These are not going to change because the patient is going to be a human. The diseases almost are same. What is changing? Only the treating doctor. So it is a psychological play. So are we able to really balance? And the other point of is, even if you struggle balancing, I've seen that you almost land up negating all the goodwill which you have created over the last 20-25 years by practicing at will. So these are the points which should make us ponder whether really is there any scope for so-called balancing act. Next slide, please. We take our job seriously. So whenever I was the unit chief, from the time I became unit chief, we had some sort of a loose protocol, put on pen on paper, communicated to the post guy as well of what is expected in the unit. Next slide, please. Now, coming to the why this is a topic which becomes, or this is an issue which becomes difficult to treat and difficult to make a choice. Now, often we talk about surgical audit, medical audit. We never talk about self-audit. We don't have time or space for self-audit. Unlike earlier, we have plenty of opportunities. Like earlier, our vision was a tunnel vision. Medicine, you start practice, more often you start your practice at the place where you want to settle, and you practice for the whole span of 30-35 years or whatever duration is. This is a very stereotype one that no longer is there. Migration is common, shift in the professions are common. When other professions can shift, why not medicine or surgeons can shift? The most important thing is doctors who switch or retire early often meet with scorn. There's sort of social expectation from people. There are discussions about ethicalness of retiring early. And since because of the tunnel vision, somehow they have not made an attempt to see that their other skills, other blessings are not upgraded, and there's little career planning. Next slide, please. Now, this is a slide which shows we have heard something called as Maslow's theory of needs. It's a hierarchy. It's a different levels which a individual human being would like to get satisfied or fulfilled in his lifetime. We have made a choice somewhere which was right judgmentally at that point of time, but over time, the popularity and fulfillment from the surgeon's perspective also follows a cyclical pattern. It is not bound to be status quo. So, and our thinking is restricted only to the basal level of being satisfied with our requirements. We are not growing beyond to the higher layers of motivation, higher layers of thought process, and etc. Next slide, please. Now, having said this, we are somewhere here. I think most of them realize may not be open, but there's an undercurrent. Most often, somewhere think something is amiss. They may not be able to pinpoint, but something is amiss. So we have come to a stage where something is, we are accepting it. We feel that there's a window to explore something. We need to take it further and bring it to a responding mode. Next slide, please. It is not by default things happen. It is only by design. Formal action is needed. Now, from the institutional perspective, I have 2 points to communicate. One, we as an individual, we are blessed with various intelligences. Howard talks about, Gardner talks about 9 intelligences. It is not that we are blessed with only one compassion, skill, knowledge-based workers. We are having many blessings as such. Each one of us are having different blessings. We have no opportunity for them to manifest in our traditional way of practice. That is where there is a role for electives. No longer, earlier we never had these electives. Now in undergraduation, we hear about electives being talked about. In Western world, electives are an option. It is not that you restrict to one area only. There are integrations of other streams so that you can explore that occasion whenever it happens. So it's a multidisciplinary outlook. Now, when we talk about this one, as a professional associations, now we talk about stress so much. When Western world, for example, GMC in Britain and AMA in American Medical Association have recognized that stress is a very valid point with respect to the medical profession. There is a working pattern for all the consultants and doctors there. No one works more than 8 hours per day. With us, if you are an operating doctor or a doctor per se, you are 24/7, 365 days responsible for that patient. This is where our associations can come and create a sort of group pressure group, from a pressure group to see that some modifications take place. Most of our NMCs and NMC, earlier MCI, were only restricted to formulating the admission process. They are very less concentrated on the concerns about the doctor. What we need to look at is, we need to have a food for thought, choose one unique path towards freedom, be courageous, and dare to act. Next slide, please. Next slide. Now, what are the other options? Let me not go into the details of it. Entrepreneurship, enterprises. Rather than wanting to or landing up in a situation where you need to work in a corporate structure governed by the management trainees or management group, why don't doctors themselves together come and start, and one person can take the lead of managing an enterprise? So a doctor is very much comfortable working in another doctor rather than the corporate sector. Medical legal is one thing which is small area, niche, not much. Startups, industries, they are taking a big leap. We know many people among ourselves, some of them are tech savvy guys, some people are coders. Why? They also, actually, when we had a conference at Bagalkot last time, we had IIT guys coming and looking for options where they want to collaborate with surgeons so that some innovation could come up, startups could come up. Rajiv Gandhi University also had an occasion to start some innovation hub in its premises. So something like that should start that should give an opportunity for people to explore. Next slide, please. What are the consequences of early retirement? One important thing, please remember that just financial freedom and early retirement is not a solution for everything. One should be very clear of what is that he wants to do after retirement. If I talk about early retirement, there are various other options which I will not ponder now. But they should be thinking what is that specifically they want to do so that things will start becoming easier. If they have issues which are beyond that, they need to be addressed earlier rather than seeking early retirement first. Have a trial of it. Try to find out whether things suit you or not. Otherwise, what will happen is you are likely to get bored, you're not likely to be happy, and then you start having self-doubts about yourself. Please remember, small things which are always compromises, sacrifices are bound to be there. People will keep talking whether you are a misfit or etc. Or sometimes also there will be dilution in your professional identity per se. Next slide, please. Next slide, please. Now, when I talk about these things, I just want to highlight 2 or 3 quotes which will enable you to think. One should have a clear idea how much time do I want to become a leader in the specialty. As I said, these are the group of people, 5 to 10%. They are in the top percentile. They are blessed. They will do things which is working with them. Is it that you belong to that group? How much time do you want to devote to other domains of your life apart from profession? When do you want to start? Success which costs you too much must be considered to be failure. Success is being able to spend one's life your own way. There will always be a conflict whether to listen to reason or follow one's passion and make personal goals a priority. Next slide, please. Now, we come to a situation where there is a maxim. A surgeon should know when not to operate, more importantly than know when to operate. If you extrapolate it here, a surgeon should know when to stop operating. The 2 important points which I want to tell you is when once patient starts developing unusual complications after an ordinary procedure and losing temper frequently during the procedure are clear indications that something is amiss and you should be contemplating whether you are the right guy to seek retirement early. Next slide, please. Next slide. Now, in conclusion, let me tell that early retirement is not a sort of an illusion. It is a very feasible mission which just needs a good amount of planning, some personal sacrifices, and keeping the personal goals as a priority. Thank you, one and all.
Sir, thank you. We'll go for question and answer session, sir.
Yes, please.
Some chat box, you can see Professor Godi is asking, in the West, the maximum surgeons are retiring to avoid medical malpractices. What is the incidence of in India, he's asking?
Sir, is it with respect to the number of instances where malpractices cases are filed?
No, they are afraid of malpractices. That's why they are early retiring in Western world. What about India, he's asking?
In India, there is no literature. If you log in the keyword of retirement in any surgical scientific literature, you do not find a single literature talking about early retirement. We have no study with respect to the Indian figures. For that matter, even the Western world also.
And Dr. Ramkrishna wants to ask, can you please give some anecdotes of surgeons who retired and doing what are they doing now? Some examples. I think you should tell about yourself, sir.
Now, let me, okay.
Yeah.
It is a personal choice. I tell you, many people would realize that if you form groups which are beyond, for example, now, my 3 pillars as of now are making myself a better version, having spiritual pursuits, literary interests. Third one is equity investment. Roughly, this will also include the traveling and the backpacking part. But if these are my areas which I have my focus, my most whole of my day revolves around this. You will be surprised that when you form focus groups of these entities which you are interested in, some could have photography, some could have trekking, high mountaineering, etc. You will find doctor forums, which are, you will not get these people amidst yourself. You are going to be a sort of path breaker. But you will, if you take examples, doctor groups, trekkers, you will have plenty of them. who are CS trekkers. You have doctors who are equity. It is overflooded. Equity forums where it is exclusive for doctors. You will be surprised. Many people would not come open. Some of them are in the anonymous group, but they are actually involved in trading process. So likewise, depending on what makes you comfortable, what makes you more happier is what you need to opt for. I don't think we will be looking for anecdotes or examples per se. That is what I can tell. But probably I should start making a list of people who have made similar decisions.
And what about private practitioners, sir? Dr. Naj wants to ask. A private setup is there. What is the option for them for the early retirement?
And Dr. Naz, you should decide. You are a very creative, poetic lady. You should decide of what makes you, what is your purpose, and what makes you, what will make you happier to get involved or give more amount of time. So that is what I can tell you.
Any other question?
So when do you think you should plan retirement? Is at what stage in your active career should you start planning your retirement?
So this depends roughly on what is the reason for your retirement. Is it that you are seeking a different option? Is it you are looking for an alternate medical profession? Are you looking for a startup enterprise sort of thing? This is what will retirement. For example, which is more often directed here, if you are looking at just so-called only early retirement, it is at the age of 55 to 60. All those people who start to retire around 55 to 60 years are the age group, are the ones, someone who have fulfilled their wishes, professional wishes, who have had an exalted career by their own standards, and then they are looking for something else. It is sort of a mature decision. But at every age group of 30, 35, 40, 45, there are different reasons why you should opt for. For example, if you are looking for a startup, obviously you would like to start a career much earlier, sometime in the 40s. And Dr. Lakshman, I would wish that you put in few words, because I know you are a technological guy, technical guy, tech guy, and then you are somehow, you have interest of startups. Have you come across, I have come across people who, engineer friends and otherwise, say that, why don't you join us, let us start having a startup, something related to the medical fraternity. What is your view on this?
Certainly, if you have the financial backup for that, if you have the financial security, having anything related to medicine but a private entrepreneurship, I think is most welcome. I will be a devil's advocate and put you in a spot deliberately with no bad intention. One view should be that surgeons are highly skilled, and you don't have, even though there are many surgeons around, but you have your own skill and you can really contribute to society. So if you retire early to pursue your private interests, are you not depriving society of your specialized skills?
Yes and no. Yes, your point of argument narrative was right. That is what is the conventional teaching. When an engineer is also a highly skilled person, he is graduated from IIT, he is graduated from IIM. When he joins, he has a startup which is not related to engineering. When he ventures into management, which is not his focus area of engineering per se, when he can enter politics, when he can do things which beyond much earlier. Why this taboo only with medicine people? We are self-drawn.
Yeah, fair enough.
Dr. Gurshantappa, last question, sir.
Arvind Patel here.
Yes, please, sir.
Sir,
I'm very happy because someone is there with me. In fact, at the age of 58, I announced that I'm phasing out.
Okay.
Of course, Corona has helped me to take that decision. Anyway, thank you. And this particular thing, if you at least early, take out that early retirement, whatever it may be. Early means somebody might question why early. So otherwise, retirement for surgeon or doctor I still feel it's required and it's a good food for thought. Thank you.
Thank you very
Dr.
much.
Gurshantapa, sir,
Nuli,
quickly.
sir.
Yeah, please.
Sir, in continuation with Dr. Lakshman's opinion about early retirement, if a good surgeon, society will be deprived of. Same thing, I think if a surgeon is a good teacher who can teach many, not joining a teaching institute and exclusively submitting themselves for a private practice. And at the age of 50, 55, thinking that they want to teach medical students. Probably if they would have started joining institutes in the early age, many hundreds, thousands of students would have been benefited.
Thank you, sir. Prime Minister has given a call for up to 65. Anyway, Dr. Siddesh, President, your remarks last, because we are running short of time, sir.
Thank you, Dr. Nuli. Short, crisp comment. See, for me, retirement from surgery means when I can be more dangerous to the patient than what I am right now. So if I feel my patients are at threat of continuing to operate, that is the time when I will quit. And well said that. I will tell you, at the age of 53, I felt what happens to me after 60. So that is what made me to start the hospital of my own. You see, understand, it is not for anything else. I wanted to continue operating after 60, which I might not have been possible for me to cater the middle class and low middle class, which are my clientage. If I had not, I have been forcefully given a termination from my institute before 60, or rather maximum by 60. So that started haunting me at the age of 53. That is when I took a decision, I need to have my own platform. So I think each person has his own age timeline. It is up to us to realize it quite early so that we can plan your retirement. So that is what we should not feel people have retired at the age of 55. They are quite happy. They are quite contented. I am happy for them. But you have to realize what is good for you and your mind at that particular stage. Thank you.
Thank you. Dr. Anupama, last words, and we'll conclude this session.
Thank you, sir. It was a great talk, and we got a lots of ideas from you. And I thank the organizers committee and also Dr. Siddesh sir for coming in and putting your valuable input. He is my teacher also. So hi, sir. And Dr. Lakshman sir, thank you, sir, providing this opportunity, and all the organizers. It was really a great session. All the three talks were excellent, and it was a learning experience for us also. Thank you. Thank you, Annika.
Thank you, madam. Thank you for the organizers. Thank you.
Thank you, one and all.
Thank you, Dr. Sharath, for your wonderful talk. I sincerely thank the chairpersons, Dr. Anupama and Dr. Dayanand Nuli, for their valuable time. And I thank the speakers for their enlightening talks. We will now move forward with the inaugural function. I extend a warm welcome to our chief guest, Dr. G. Siddesh, President ASI, Dr. Arvind Patel, Chairman KSCASI, Dr. Chandrasekhar S., Secretary KSCASI, Dr. Chandrasekhar N., Treasurer KSCASI, and Dr. Lakshman K., Chairman Scientific Committee. Dr. V.N. Patil, the Chairman-elect for KSCASI. We'll now move on with the invocation by Dr. Kirti.
शांतरस हरि दुदु तुंगे आगी शारदे नेलेसिहळु मातेयागी शंकराचार्ಯರ ತಪದ ಫಲವಿಲ್ಲಿಹುದು ಶೃಂಗೇರಿ ಕನ್ನಡದ ಪುಣ್ಯವಾಗಿಹುದು ಕಪ್ಪೆಯನ್ನು ನುಂಗದೆ ಹಾವು ಹಗೆ ನೀಗಿತು ಹೆಡೆನೆರಳ ಮಾಡಿ ಅಭಯವನು ನೀಡಿತು ಸಹಜ ವೈರವ ತೊರೆದು ಪ್ರಕೃತಿ ನಲಿದಿದೆ ಎಲ್ಲಿ ಸಹಜ ವೈರವ ತೊರೆದು ಪ್ರಕೃತಿ ನಲಿದಿದೆ ಎಲ್ಲಿ ಸತ್ಯಮಯಿ ತಾಣಿಹುದು ತುಂಗೆಯಾಗಿ ಶಾರದೆಯು ನೆಲೆಸಿಹಳು ಮಾತೆಯಾಗಿ ಶಂಕರಾಚಾರ್ಯರ ತಪದ ಫಲವೆಲ್ಲಿಹುದು ಶೃಂಗೇರಿ ಕನ್ನಡದ ಪುಣ್ಯವಾಗಿಹುದು. Thank you.
Thank you, Dr. Kirti, for that melodious song. I would now request Dr. Arvind Patil, Chairman KSASI, to take over to welcome the chief guest.
Good evening.
Thank you, Dr. Vinny. Over to you.
Good evening, everybody. At the outset, I welcome our national president, Dr. Siddesh, to this inaugural CME of T.S. Jairam Memorial Lecture. I also welcome our chairman-elect, Dr. B.N. Patil, past chairman, Dr. Sopimat, our scientific committee chairman, Dr. Lakshman, and D.O. Chandru, our secretary Chandrasekhar and treasurer Chandrasekhar, to this CME. I also welcome our delegates, senior faculty members to this inaugural ceremony. The CME is being planned by our scientific committee headed by Dr. Lakshman, mixing both basic and advanced topics so that it helps our surgical fraternity. Hope everyone will enjoy this academic feast. And with this, I hand over it to Dr. Chandrasekhar.
Thank you, sir.
I now request Dr. Siddesh to inaugurate the function by lighting the lamp.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
I request Dr. Siddesh to say a few words for the inaugural speech.
Thank you. At the outset, let me really congratulate Kirti, who sang the invocation so eloquently, and I felt for a moment we are offline. It has really brought us all together physically. So your voice has been really enchanting. Thank you. Chairman of Karnataka State Chapter, my dear friend, Dr. Arvind Patel. Chairman-elect, Dr. Basavangowda Patil, who is going to take over the reins in a couple of days. And my dear student and the energetic secretary who is getting reformed well to carry on the responsibilities of Karnataka State Chapter, Chandrasekhar, and of course our treasurer Chandrasekhar. Nevertheless, our dear friend who has taken up the responsibility of holding the whole academic activity of the year of Karnataka State, Lakshman, which he has done very ably. And also I can see yesterday who has been elected, who is going to be declared as the chairman-elect, Dr. Shivram, my dear friend again. So congratulations to you and all the best to your term. We're going to start in a couple of days as a chairman-elect. And past chairmans, Dayanand Nuli, Dr. Godi sir, and the executive committee members and EC members of Karnataka State Chapter, my dear friends and colleagues. It has been really a very pleasurable occasion to be amidst you, an organization which we have all been part of for many years. For me, Karnataka State Chapter is very, very close to my heart, having taken up the responsibility of hosting, at least if I remember, 3 conferences at Mysore, annual conferences, and also a couple of mid-cons which we have held. So we always took it as at Mysore, the team Mysore was always ready to take up the responsibility of hosting. So when gone through those experiences, I would never have imagined in any one of those occasions that I would be having an opportunity to inaugurate one such CME of the annual event, being a president of Association Surgeons of India. It really gives me a proud privilege to be a guest amongst you, a person amongst you, staying with you, having become the chief guest and inaugurating this session. Thank you for giving me this honor. This goes to each one of you having made it possible. Now, at the same time, Karnataka has been in the forefront of academic activities, has always been, and also in the last couple of years, the activities are much more well streamlined. Ever since we had a lot of discussions about the reformations of the academic lectures, CME programs at the annual event. Way back, I remember we were sitting in Hassan Executive Committee meeting where Dr. Sopimat took it as an opportunity, put it across. I think it was very much welcomed by every one of us that we need to go through certain transformations for the good of learning of everybody. So these changes have really done well, and subsequent office bearers have carried on the changes, and I am sure we are all reaping the benefit of these changes, and we are going to continue. Last couple of years, we know the learning has become online. Nevertheless, the impact of learning has not been diluted thanks to the efforts of the organizing committee. And I hope this CME will continue to enlighten all that. But what I see again is the lack of interest, which we are discussing time and again. And I'm sure Lakshman would agree that the numbers of the postgraduates who are taking part in this event is really not a welcome sign. We need to do something as an introspect to make this more attractive to this part of the crowd, which we hope are the most beneficiary out of this. But nevertheless, I am one of the most beneficiary out of the CME program. I would be delighted to continue listening to the lectures today and later on tomorrow also as well. Thank you very much for giving me this opportunity. I wish God gives us all an opportunity to meet physically soon. Thank you very much.
Thank you, Dr. Siddesh, for those kind words. I now request Dr. Chandrasekhar S. to present the vote of thanks.
Good evening, sir. Respected dignitaries and delegates, chairperson, and our judges and moderators. I today take a privilege to give a vote of thanks for inaugural ceremony of CSCP. I thank Dr. G. Siddesh, our national president of ASI, and for accepting our invitation, and he inaugurated our CSCP. On behalf of our Kscasicon 2022, I once again thank Dr. Siddesh sir for inaugurating this. And secondly, Dr. Arvind Patel, chairman, KCSI, he chaired the session, and I thank you, sir, for chairing this inaugural ceremony. And I thank our chairman-elect, Dr. B.N. Patil, for his gracious presence. And I thank our scientific chairman, Dr. K. Lakshman. Without him, this CSCP and conference would have not occurred in this manner. So artfully, I thank Dr. Lakshman sir, and I thank our treasurer, Dr. N. Chandrasekhar. All the way he has come to Mysore and is with us in this auditorium. And I thank all the speakers, chairpersons, and judges. And I request all of you to present for the inaugural function at 8:45 and also tomorrow's and day after tomorrow's program. One and all, I thank once again. Thank you, sir.
Thank you, Dr.
Now,
Chandrasekhar.
I request our Dr. Siddesh to go ahead with your talk, sir.
So, to chair this session, I request Dr. Arvind Patel, Chairman KSCSI, Dr. Chandrasekhar S, Secretary KSCSI, and Dr. Shivram HV.
Hello.
I request Dr. Siddesh to go ahead with his talk.
Sir,
over to you, Dr. Siddesh.
Sir, yes. Just a minute, sir. Sir, I'll introduce, sir. Yeah. As a part of, hello.
Please.
Go ahead, Chandrasekhar.
Chandrasekhar.
Dr. G. Siddesh, President of ASI and a former HOD of HOD and Professor of JSS Medical College, and now a proprietor of Sigma Hospital, Mysore. Sir. Dr. Siddesh is a renowned laparoscopic and endoscopic surgeon. Sir completed his MS from Mysore in 1985 and went on training at Mumbai with Dr. V.N. Shrikande for GI and endoscopic surgery. He has been guide for many PGs and UGs, and he has been active in many academic bodies and like AMS, ASI, IAGS, IMA, ISG, and Hernia Society of India, and few, to name few. He has 18 publication and many scientific presentation in the national conferences. Sir, we welcome you, sir. Please.
Thank you, Chandrasekhar. I think I have 30 minutes to go. Maybe I'll finish a little early. I have been given a topic. I discussed. I'm audible? I'm audible?
Yes, you are, Siddesh. Yeah.
Thank you, Lakshman. So I had a discussion with Dr. Lakshman, the scientific chairman, with few topics, and as for the advice of the scientific committee, I could take up this. It has helped me to formulate my ideas, which has been going on in my mind for last few years, where I have also gone through these changes in my surgical practice. And I'm sure all of us have gone through this. Those who have been practicing for last couple of decades would see especially the changes which have happened of late. And these not only have caused changes to our own way of practicing, we interact with our patients, and many times they are not bad. Actually, they are for good of both ways, for the patient management as well as for us as well. But there are few things which are going in the wrong direction, which I have tried to enumerate, and I think many of them are known to all of you. But and also at the same time, I will be happy to have a sort of an interaction where we can find a sort of solution at our association level and also in the future for the benefit of our next generation surgeons. Who is a general surgeon? I just thought I should have a look into this. A specialist trained in treating diseases which may require surgical intervention. A surgical specialty focusing on abdominal contents, especially, and also deal with many diseases which are involving the thyroid, breast, soft tissue, peripheral arterial disease, hernias, and perform various endoscopic procedures also as well, and many other things. So that various gambit of wide variety of procedures itself makes it a fact to say that we are general surgeons. The general surgeon is one who has completed a prescribed training and have successfully completed his exam. Now let us look into general surgery, what has happened to it over course of years. Over the turn of surgery, over centuries, surgical profession has set standard of ethical and humane practice. Many landmark accomplishments in the surgical science and innovations in operative techniques have revolutionized the surgical care, which we all know. General surgeons have developed, practiced, and passed on legacy to the next generation, which I have experienced myself, like most of you have gone through, and that thing should continue. Beyond science and art of surgery, it's unique, fulfilling feeling as a profession which gives satisfaction. In return to this hard work, surgeons have been given due respect in the society, which we should always proud to be professed to have it. Now the change, what we are talking about today, and this topic today is the change which is occurring all over us. Of course, change is something which we cannot prevent. See, change is an inevitable thing which happens in every corner of the society, in every aspect of our life. But well, these changes should be aimed to the good of the whole mankind and for the end user as well as the one who is providing. And this change should also make the whole process of the patient care a smoother, more smoother one, if not totally without any hazards. From the turn of century has seen profound changes occurring at various levels, has provided challenges and opportunities at the same time. The aging population has contributed to diseases. You know, even in India, the average age of life expectancy has gone up. Likewise, the diseases which are associated with it has gone. So it has brought in a change in the outlook of the diseases as well. At the same time, we look at the composition of the surgeons. You see, I recently, when I go for a RRC, our regional refresher course training programs, I see the hall is filled with more of lady residents than male counterparts. This change has occurred over years, and this is also going to change the preferences of the patient preferences as well. You know, it is well understood without any bias. So the female patient tend to have a preference towards lady surgeons. Market-driven healthcare is a pattern emerging of late. Healthcare is seen as a profiteering enterprise. So more and more business ventures are coming into the field who are putting up healthcare systems, which may also bring in changes which we as surgeons need to adopt. Otherwise, we may also face some difficulties. Any necessity to change should be backed by evidence. This is one sentence which I want to say, because otherwise, if it is without an evidence, we get into a dark period without our knowledge. The choice of becoming a surgeon is purely with us. Over the years, we have seen, if you look at the pattern of selection in the NEET exam, there is a trend of decline in the residents opting for general surgery as a career. What are the possible reasons? If I just looked into that, the duration of exposure of an undergraduate to surgical learning has probably come down compared to what we used to get an exposure as undergraduates. Maybe because they are getting exposed to more of subspecialties, community healthcare postings, etc., which has made this exposure little less. So they get less chance to get inspired by the good work which is being done, which can transform good to the patient. Concept that it is a stressful profession, which is well understood. That's why more people prefer to the top creamy meritorious students take up dermatology, radiology, and other less stressful specialties. Long period of training, the skill learning has a curve which can vary depending on the individual's capacity, and this can get prolonged very much, which may be painstaking. It has been a thinking that surgical specialty is associated with litigations which are much higher compared to other specialties. So these are all reasons which may be causing this decline in the resident opting for surgery. Unless this trend is reversed, general surgery as a specialty is going to be on a decline. Now, today I'm going to discuss, these are some of the points which I thought I should be discussing on: changing pattern of the disease, which surgeon should get adopted in the course of time; development of subspecialties, which has caused again the changing in the type of our practice, changes in the type of our practice; and then technological advances, which has resulted in many aspects of our way we treat our patients; training and education, which is very much should be part of this. Otherwise, these changes cannot take place in a meaningful way. Just to discuss a few, as an undergraduate and as a postgraduate student, peptic ulcer disease was a main chunk of our patient load in both OPD outpatient as well as inpatient. Even emergencies were due to peptic ulcer disease were high. But you know what has happened now because of the better understanding of the disease, and the advent of endoscopy has resulted in a drastic shift that peptic ulcer is no more a surgical disease, except for few complications. Even the number of complications we have seen a decline over years. Whereas on the contrary, when I was in postgraduate students, we had hardly seen few gallbladder surgeries, of course open. The reasons which were not only because the incidence was much at a lesser level, but also they were less detected because the non-availability of sensitive investigations to pick them up. Thanks to the changing life pattern, the diet, we have seen the gallstones going up. That has given a sigh of a relief for general surgeons at large. Malignancy is on rise. All of you know the reason is not only the aging population, but also because of the lifestyles which have got changed over years. Trauma and emergency surgery are also on rise for the reasons which you all know. There are certain new procedures which have got added to our armamentarium or our practice, like metabolic and obesity surgery and the need for cosmetic surgery. So it becomes an imperative as a challenge also to surgeons, especially budding surgeons, to have to spend more hours to develop the skills of doing these procedures when they start their practice, depending on what they want to end up with. Development of subspecialties, which you all know, have crept into our practice. Urology has come as a science much earlier than other specialties. Now, even in the beginning of my practice, I had an opportunity to do large number of open prostatectomies, which we used to do very well. We used to claim that our postoperative results are very good, and hardly had any post-operative bleedings because of the suturing techniques and other things. So, but today, you know, I'm sure any surgical resident would not have an opportunity to see a single open prostatectomy. So urological procedures have gone out of our hands. For example, even in my place where I practice, if I do a varicocelectomy, it is looked upon as a procedure which I should not be doing as a general surgeon to that extent. Plastic surgery, even burns treatment as well as treatment of large ulcers which may require skin grafting, which is now going to the plastic surgeons more than to the general surgeons. I started my practice where thoracic surgery was one of my main component of practice. I used to do a lot of lobectomies, decortications, and other commonly done procedures on the thorax, which totally have gone out of my hand. So this is one more change which has happened over years. What is most important is last few years, as a head of the Department of Surgery, I had to fight in the College Council meeting to retain thyroid, parotid, submandibular gland, and lymph node surgeries within the Department of Surgery as a domain. So these changes are also going to affect the practicing young surgeons in future. Technological advances when it comes, we know the advent of minimal access surgery has really revolutionized the way we look at performing many surgical procedures, especially inside the abdomen. Laparoscopic cholecystectomy has become a gold standard, even with much before any controlled trials were being performed. Advanced imaging, advanced therapeutic endoscopy, I am sure all of you know how much impact it has made in our practice. Even an actually bleeding duodenal ulcer or a gastric ulcer has not found a place in the list of surgery for want of arresting these bleeds. Similarly, variceal bleeds have totally gone. Portal hypertension surgeries, which I performed in the initial stages of my practice. Now I have not performed one for the last 5 years. Robotic surgery has coming up. It has now come and it is staying with us. And it has also made an impact in certain areas of surgical field. So it gives an additional challenge. Who are those surgeons who are interested in picking up this additional skill? And if they do really pick up, where do they go to practice them? Because the available centers are very less. So these are again additional challenges. 3D printing technology and navigation technology, I'm sure they are the ones which are in the horizon. They are going to make an impact soon. And all these newer technologies, one should be aware of before they come and we are left behind. No doubt, we need to look at the evidence and their values before we adopt them into our mainstream practice. Again, coming to the technological advance, I just want to caution the youngsters, telling we should be not losing the human touch when we look at technologies. Artificial intelligence should be only an aid and not should be used as an alternative to our skill and patient interaction. You should be aware of the upcoming technological advances, but have a critical thinking before adopting any. My points on training and education. Training and education, continued education in surgeons who are practicing already should be an integral part. Otherwise, these changes which are occurring in the field of surgery will be left behind. We need to continuously be aware of the change, be part of the change, and also learn those changes and practice to the advantage of the patient and us also. Earlier days, we used to have, as a surgical resident, I have seen they used to be very highly disciplined, contribute hours and hours of long hours working at the wards, and there used to be more of one-to-one interaction, and we used to have one idol whom we try to copy and keep them as our inspiration. So like I always find, even today, if in the field of difficulty or a dilemma, when I'm passed with two options, I would choose an option which my guru in a similar situation would be doing so. So always look back on my guru, Dr. Shrikande, whenever I take such decisions. So do we really look at the same way in our young surgeons who are getting trained to look at idols in an inspirational personality, or they look at the technology as their guide to guide them to the future of their career? Changes in training of surgery to meet the changing trends like virtual reality, simulators, and cadaveric labs. These are going to come in because we don't have that many number of live patients where we go through the formal level-wise training of observation, assisting, performing under supervision, and performing independently. So to go through that, we need numbers. We need dedicated teachers, which both we are lacking. So naturally, we may have to depend on alternative methods in training our residents. Of course, at the same time, let us also remember these alternative methods like simulators and cadaveric labs also bring in that much of patient safety as well. So that is why we have got to know the establishment of skills lab in all medical education centers is coming up in a big way. I would recommend a more focused training for commonly done procedures to the young surgeons, like don't go to get trained in liver resections as your first priority. Try to learn performing a basic hernia procedure very meticulously. Whatever method you would like to adopt based on the evidence, do it and learn very meticulously so that you can perform this, replicate them in multiple times with minimal morbidity and complications. Adopt standard operating protocols in each procedures. Enlist about 20 to 25 procedures which are most commonly done in your practice as a general surgeon. So these will, and master those particular procedures. So that is what I recommend, and I always teach my postgraduate students. I used to say, enlist these 20 surgeries and pay attention to making them come into your blood and commit less mistakes when you start doing them independently. That should be the aim. Additional exposure to trauma and emergency care and wound management. I feel not much of time is given in specialized training in these aspects of surgery, because we may have to be called in to perform more of surgical procedures, and also the wound management has taken a backseat. A lot of advanced newer technologies have come in where if you adopt, the wound management itself can be a good chunk of your practice in future. Basic cosmetic surgery, we need to know because people want to get this done. There is money in it also. As general surgeons, we need to live and earn as well for the good of us and our family. Patient awareness and relationship, couple of words. You know, there is a fast deteriorating trust among patients, and the relationship with the surgeon is going down for various reasons, including the social media and increased awareness, and the information available on the net makes them feel that they know everything before they reach the surgeon for an elective procedure. For example, when they come for a gallbladder surgery, they come and ask me straight away, why do you want to remove the gallbladder? Why don't you? So even before I suggest we need to remove the gallbladder, they are already aware and they start asking questions. So we need to be aware about the newer trends of the patient education level and their awareness about the illness, and we need to be prepared to answer their queries in a calm way without getting perturbed, because that has become the new trend, and the aspiration of the patients have to be kept and respected. So that has become a part of your practice. And I don't want to go into the details of this topic. Pandemic has struck us, and for the last 2 years, we have been reduced. I know many centers, surgeons have become COVID surgeons. They have become surgeon intensivists. You know, our main focus of surgery has got shifted from the elective surgical procedures in managing COVID patients for months together. So this has added additional challenges to our practice. And at the same time, we have now coming to another aspect of practice, that is teleconsultation and tele-education. Even in our hospital, during the pandemic, we had started doing this, and we had a cell where particular hour we used to dedicate for those patients who require teleconsultation, so that can avoid them coming up and meeting us physically.
Sir.
So that may become a norm in the future as well. We need to get adopted to this newer technology of doing teleconsultation as well.
Sir,
I would recommend.
Sir, time.
Yes. What? How much time I have, Chandru?
Only 5 minutes left, sir.
Okay.
Sir, question answer, sir.
Okay. Technological orientation of surgical training. Training in endoscopy should become a part of the PG curriculum. Ultrasound scan should become a surgeon stethoscope. These are my views. So surgical resident should be allowed to have adequate exposure in these aspects as well. Don't lose hopes. There are 5 billion. This is put up by the study group by Lancet, which is there available in our textbook. 5 billion people still cannot access to safe surgery all over the world. 143 million surgical procedures need to be done annually, and surgical specialty, if given a boost, can make a society more productive. Realize the strength in you and make an economic change in both the country and yourself. Surgeons are not only meant to add years to life, but also can add life to years. Be part of the change than fighting it. Understand the change early and adapt to it, but do it only when you are convinced that the evidence is supportive enough. Look up to the evidence before jumping into it. Lastly, one word about the role of Association Surgeons of India. Being a president of association, I should look up when association has to take up a role in aiding to formulate the new healthcare system of the country. Association should also have a choice, have a voice in deciding the curriculum of the surgeons who are getting trained. They should also play a major role in identifying the need of the surgical fraternity, their education and training. And we hope we can work towards the betterment of surgical science and humanity. Thank you very much for this opportunity.
Thank you, Professor Siddesh, for delivering Professor T.S. Jairam Memorial Lecture during this conference, inaugural function. There are few questions. Yes. Dr. Gaddi Divakar is asking. I hope questions are permitted, Dr. Lakshman.
Yes.
Yes, of course. Yes, of course. Yeah.
Should students stop at general surgery, or what should be their attitude towards super specialty? I think he is asking because many of the postgraduates who come for training, they are dismayed that they are doing general surgery, and from first year itself, they start preparing for super specialty.
No, I think
so. What's your response?
Yes, very good question. I think this is what, forget about at the level of postgraduate, even when they take up the entrance, they already are getting prepared to become a super specialist at that particular so-called super specialist. I don't know, but I will tell you, it is our duty to make them aware there is still a very major role for a general surgeon to play in our society. What lacks in us is to motivate them to master the commonly done procedures. That's what I am trying to say. If they become masters, they have a lot of confidence in doing about 20 to 25 procedures without committing mistakes. They can still practice any corner of this world. So that is my message. But I know we all know that super specialty has become a part of the passion. Everyone gets admitted to general surgery. Don't look at that as an end specialty, but I'm sure soon the trend should change because most of these branches are getting saturated. You know what has happened to plastic surgery, pediatric surgery, and cardiothoracic surgery right now.
Right. Thank you, Dr. Siddesh. Dr. Lakshman wants to know how should young general surgeons handle the pressure from super specialties?
Absolutely.
I think partly you have answered.
Absolutely. Yeah. No. I have a additional point to make, Lakshman, about this, because I feel while working in a medical college, suddenly I felt a gallbladder disease, when it comes up to the OPD, would go to a GI surgeon. A breast lump would go to a oncologist. So this is what I had to put up with my management, that this basic surgical the procedure should remain with general surgery. The reason being, my argument was, super specialists, the so-called super specialists, are trained. Their time is more valuable. They need to be dedicated to performing more complex procedures like liver resection, liver transplant, or complicated hepatobiliary surgeries, complex malignancies. So those are the areas where they need to be used. Their man-hours need to be used, and they should not be wasting their time doing hernias and hemorrhoids. I see GI surgeons doing all this, even gallbladder surgeries.
Right. Dr. Arvind Patel wants to know, immediately after MS, is it possible to practice? If not, what is the solution? This is a big problem for all general surgeons who come out.
So again, I have partly answered it during my lecture, that the numbers have diluted the quality of training. See, during my training, we had one postgraduate for each unit coming in. Today, indiscriminately, our government has made it double, 2 number of postgraduates every year per each guide. So that makes, in a unit, there are 2 guides. It makes 4. I think Shanai is telling, Rajgopal is telling 3 now. So you can say if there are 2 guides in one unit, surgical unit, there will be 6 postgraduates per unit, where I used to be only 1 in a government hospital. So that much of opportunity we are losing out. So the training has been really inadequate. We need to look up to the skills lab and alternative methods of training them so that they can become confident at the end. But of course, as you say, they have to spend a couple of years later under somebody where they can become more confident in and safe, I would say safe. That is where they will not fall prey to these platforms, which we are talking. I think our previous past president, Dr. Tanga, was mentioning about it. Yes, we need to be wary about these platforms.
Yeah, Dr. Siddesh, there is another interesting question. Dr. Baswan God Patil. See, general surgical practice is excellent in Taluka place. They can do endoscopy, ultrasound, laparoscopy. You feel general surgeon should concentrate more on the Mofussil areas than the big metropolitan cities?
Well, very good question. In fact, that is what is going to happen, whether you want it or not. So if you want to continue practicing as a general surgeon and you want to work from the day one of your practice, probably that is where the answer lies. But our government should make this conducive enough for young entrepreneurs to establish their practice, because investment, they have to, huge investment needs to be done. Today's aspiration, even if you go to the remotest area, the patient will come and ask you, do you have ICU? Do you have intensive care? What monitors? Do you have ventilators before you operate? Or even if you operate, when something goes wrong, when you say you have to shift for a want of ventilators, then your trouble starts. So we need to understand it requires huge amount of investment. So there is a need by the government to have a look at it to encourage these investments.
Sir, time, sir.
Thank you, Dr. Siddesh. That was a wonderful talk. And because of the time constraint, we'll stop here. There are some questions you can answer from the chat box. Thank you very much.
I will do that. Thank you for this opportunity again, chairpersons, and thanks for the interaction. Thank you, Lakshman.
Thank you
Thank
so
you.
much,
Thank you.
Dr.
Thank you.
Siddesh.
Thank you, Dr. Siddesh.
Now I would like to call upon Dr. Harsha sir to give us speak about the legal crux surgeons.
Good evening.
Good evening, everybody.
We have lost your slide, Harsha. Can you please reshare?
Am I audible, sir?
We got it back and you're audible. Thank you.
Now I think I'm online.
Yeah, you are. Please go ahead. Yeah.
Sir, good evening, everybody. And namaskar to all the dignitaries, senior faculties, head of the departments, deans, university faculties, postgraduates, and if media personnel are covering, and media personnel, and also medical legal advocates. My time is very short, but still the topic is very big. My topic is legal crux, the surgeon's knife is. That means legal trouble, the surgeon's knife is. Myself, I am Dr. Harsha, a chief surgeon in Shivakurpa Multi-Specialty Hospital and Research Center, Arpanadi, which is a taluka headquarter. As correctly pointed by one of the faculty regarding general surgery in, especially in taluka headquarters. I will be dealing with that, sir. And this is to remember Dr. S.R. Kalgudi endowment lecture. So myself, I would like to introduce. I may be a little fast because 30 minutes time is given to me. And next thing is I have condensed some 3 hours of topic into 30 minutes topic. And myself, I am a Dr. Harsha and I am a laparoscopic surgeon. I've done from my general surgery from Bangalore Medical College and Research Institute under Dr. Shivaswamy sir. And I am also done with FMAS and I'm a sonologist trained under PCPNDT. I could pass somehow, I could pass the exam. And I did my LLB from Karnataka State Law University, Hubli, as I am not yet a registered advocate. Worked as a government doctor under Health and Family Welfare for 8 years. Presently, I am a chief surgeon. And also I have mentioned the degrees required at different places or they differ, like Sir said, is practicing in Mysore and we are practicing definitely in Harpanhalli, which is different there. And where in Mysore people demand, definitely they will demand different kind of, for example, if you go with a breast clamp, they will search for a breast surgeon. If you go with a gallstone, they will search for a GA surgeon. Now, today I am not dealing with such kind of topics, but I am dealing what really surgeon's knife is permitted, what really surgeon's knife is not permitted. This is one of the greatest temple where we learned, and this is the temple where we worship. So my skills and my risk. I'm owner of a private hospital. Maybe ideal question just now one of the speaker asked what is really a private hospital and what are the risks there. And I am doing general practice also from pediatrics to geriatrics. I do OP, I do IP. I do diagnostic services also. I'm trained like in ultrasound and do OBG as well as abdomen as well as small parts and vascular, and also I do upper GI endoscopy. I'm learning lower GI and also I'm trying to get to lower GI scope because it's quite expensive here. We are doing very nominal specialty practice, general surgery. We do most of the procedures, most of the general surgical procedures, including thoracotomy also we did. And we have a mixopathy, like we do OBG and we do pediatric surgical work. I myself, I am telling, and I also do some onco surgeries. I do some neurosurgeries and so on. I can say there is a superposing number of surgeries because young surgeons will be watching, and also undergraduates or sometimes someone who is really fond of taking general surgeries also will be watching. So I would like to tell what all the scope there it happens to work in a taluka headquarter, otherwise in district headquarter, which is really back like some North Karnataka places, and also many part of India. I don't think the scenario is same like in South India. Lots of places are still vacant where a general surgeon has a huge amount of scope to work. And we have hired services also. We have everything except ICU cases and cath lab. We also manage even ventilator cases. We have good anesthesia team. We have support nearby from Davangere. So what really legal crux and surgeon safety, the topic chosen, I would like to explain. legal crux, I have put it in front, then the surgeon's epi is kept, because most of us has become an important. So before I put a signature on the patient's body, I should know what really I am permitted and what really I am not permitted. So for that, legal crux is legal troubles or legal things to be understood. And surgeon's epi is nothing but a sport where this one is used in fencing. So it's I have just kept it as name like that. So I am on defense side. Today I'm talking on defense side. I'm not on the complaint side. If I talk on complaint side, definitely I will talk dead opposite against surgeons. But I am on defense side right now. I'm sitting here. So I am going to talk for the surgeons. So a case can be won with a very good discussion, either for or against. If I really defend my case in a proper pattern, I can win any case. If I really don't fight properly inside the court hall, I can't win the case. This is a real thing which every doctor should understand, because if he assigns some doctor, some advocate who is not proficient, who is not competent to handle such kind of cases, he is going to lose the case, not just because of evidence or lack of evidence or something, but still because lack of proper presentation in the court. See, ours is a passive judiciary where judgment is given based on the discussion of two advocates. So judgment is not only simply based on the evidence what we collect or whatever, but how you present is most important. That's why I request all my fraternity to have a good lawyer friend, or at least submit through some medical legal lawyer friends. This is my last call. So I have kept this as a haunting tale of a daunting knife, as some kind of story thing, wordings out of many court cases. I am very specific. I will just talk what is there in the court cases. I will not just beat around the bush. So this topic is chosen to answer what actually is permitted by law. Limits, skill, and competence versus law. Emergency challenges, trauma. When there is nobody, everybody will point all the surgical case to general surgeon. When nobody will send the case to general surgeon. Everyone, there is full of, for example, a medical college full of super specialty, general surgeon has no work. When college has nothing, general surgeon has huge amount of work. Same thing happens when you stand up in a corporate setup, or when you go to a larger city, you have no work. When you come to a small city, you have full of work. Rural surgical practice with nobody areas. And so this is a place where even young surgeons should think of gray areas of syllabus and non-uniform training things. So gray areas of syllabus is a difference where it happens and how it is proved, how quantified, how it is punished, how it is dismissed, how to choose an advocate, and what is really an evidence. These things I would like to run. So surgeon's API deal first. So surgeon's knife is bejeweled, celebrated, similar to me, like a Bangalore Medical College is permitted by curriculum, syllabus. And it has got lots of degrees and MCA registration. It has got fellowship certificates. Fellowships and certificates are accepted in law. I would like to tell you, these are the fellowships which are awarded by associations, are accepted by law. Skills and competence, again, is judged by your syllabus. And it is again limited by curriculum and syllabus, and confused. Read this actually. And we are, of course, there is a confusion also. So knife with confusions and demands. So because a young surgeon, once he finishes his general surgery training, if at all he wants to go for a practice, otherwise the general surgeon wants to stop his studies at that point, then you'll have confusions and demands. Like similarly, superposing branches which have superposing kind of things, where we do thyroid and ENT fellow, they also do thyroid. The extension of skills as per the needs. As we learn endoscopies, we learn laparoscopies. And general degrees. General degree itself is a defense, because general degrees, they have extensive coverage of curriculum. You can see the general surgery curriculum. You can go through the curriculum and syllabus there. you find lots of procedures. They are intentionally preserved in that one because I know very closely about the university people. I have spoken, I have even talked to them, and they have intentionally told, because few of the general surgeons are still practicing all those procedures. And the procedures which are listed in the syllabus itself is a defense. There are subspecialties otherwise sent to general surgery room is also in India, especially thyroid is done by ENT surgeons as well as general surgeons. Do anybody does? No, nobody else will do. Actually, previously it used to be general surgeon, then ENT people. ENT people used to send all the thyroid cases to general surgeons and complex surgery, but permitted by syllabus. And it is peer reviewed. Peer reviewed means peer adjudication permits thyroidectomy as a Boehm's test is concerned. See, thyroid is still within the box of general surgeon. Even it is a complex surgery. Hysterectomy, once upon a time, general surgeons used to do, but now it is done by OBG people and general surgeons. It is less complex, but still it is out of our box. And laparoscopy, GA surgeons and general surgeons, both of them do, but still the scope is there. And laparoscopy, there is still lots of scope, and legally it is not barred. For the general surgeon, it is very well included in the syllabus, and so on. If I keep on listing, there is some certainty. There is a very certainty that ENT people never do hysterectomy, and OBG people never do thyroid. This is certainty. Whereas in general surgery and general kind of branches, general medicine, there is superposing things. So in that scenario, what happens? Few court cases on 9. There are few court cases where MBBS people have done LSCS. And what was the outcome? And general surgery people are doing LSCS and it is permitted. LSCS is permitted as per the syllabus. And ENT people, they have done LSCS in certain emergency situations. And what is the outcome? General surgery, hysterectomy is also done as an additional procedure. Something like PAD is mentioned in the syllabus. So here, in few court cases, the MBBS people are permitted to do cesarean section in emergencies, and even general surgeon is permitted to do cesarean section, even elective also. Elective as well as emergency, because it is being mentioned in your curriculum. No one, that itself is a defense. Only thing is you have to follow the standard protocols. ENT people, they are permitted, even other person has done MBBS, then only ENT has to be done. So that fellow is also permitted, court cases are declared. So general surgeon is also permitted to hysterectomy as an additional procedure. I would like to tell what is an additional procedure. Sometimes you do ventral scar hernia repair along with the appendicectomy, and also you go ahead with hysterectomy. And actually, to be frank, their involvement of gynecologist is essential, but when you add a word of PAD, then it's a part of the procedure to remove the hysterectomy. Usually that is like your part of qualification is solved. And whether you have really taken the proper standard way of management, then that question will start with the Boehm's test. That I will explain next. Standard of care is judged by two things. For the young surgeons who may be watching us, and also for the people who are the young people who are already practicing, and people who are aspiring PGs and first year, second year, third year PGs. Most of the times we are not taught all these things, because in colleges nobody takes such kind of topics, and we don't know general surgery includes what. Okay, my college, my professor is doing this many procedures, I do this many procedures. And other college, these many procedures done, so they are doing that procedure. In our college, they did not train me to do upper GI scopy. I don't do upper GI scopy. I stop at there, and we don't learn also. Usually, after post-graduation learning itself is like it's a kind of challenge. Unless you are really skilled, you can't learn. So, standard of care is judged by two things. One is proper degree, otherwise qualification. When you are not qualified, itself says your duty to select a case, or otherwise duty to investigate a case, or otherwise duty to treat a case itself is breached. Your qualification is not there means. That is what degree. MS general surgery is a degree, MS MD general medicine is a degree, MS ENT is a degree. Whether to select the case, whether to diagnose the case, or whether to treat the case, itself is a breach. So proper treatment method is nothing but standard treatment. It's also a duty. And if it is not done, it is a breach. These are the two breaches where so standard of care is judged by two things. These are the two things. And how to find there is a breach in proper treatment is, it is the minimum procedure. Umbilical hernia repair, appendectomy, and total abdominal hysterectomy procedure qualification, method of diagnosis and treatment. Kscasicons and recipes, you might have heard of this. Kscasicons is okay, you have done umbilical hernia repair, appendectomy, and TH procedure, patient dies of MI. Then you are not held liable, Kscasicons. You are not held liable on the cause of death directly on the surgical procedure, but the patient has died of MI. That is a different layer. You are not directly held liable, maybe criminally not liable. You may be civil liability may come because the death and even sometimes the negligence of other parts. And receipts is it speaks on its own. Usually it is a civil liability. Criminal liability, it is receipts is less used. We can assure the care but not the cure. Care part is peer adjudicated. This sentence is very a little bit a complicated thing for a newer people who listen to this, but the court case, most of the court cases, this sentence is used. We can assure the care but not the cure. Don't read care part is peer adjudicated. Just read the first half of the sentence where care, we can assure the care means judges are assuring the care, but they cannot assure the cure. That means we can assure the qualification, we can assure the standard of care, but we cannot assure the cure of the patient. Patient may die, patient may respond indifferently. That is what the meaning of it. There is a critique that care is part of peer adjudication. That means it's like a medical board which is constituted by doctors. So doctors themselves will definitely cover up the profession fraternity where care is not taken properly. They will never give that kind of report. So, but to assure the care, whether we have equitable distribution of health, that itself is a fundamental question, isn't it? See, we can assure the care if judge says, well, how can they assure the care when the health care is not equitably distributed all over India? You just go to some place away from Mysore or go away from Bangalore or just go away from Davangere to some just 150 kilometers. You don't get a person who can do a cesarean section. Even now also babies are dying. And you go there, you don't find a person to do IND. So equitable distribution of care is not there, then how can you assure the care? So these are all kinds of challengeable things. These are all kinds of defense things. The standard of care is judged by degree and standard methods. Degree means qualification. So high standard, high cost, India cannot afford. Of course, this is mentioned. These are all the wordings taken from judgments I'm talking. General branches, they are defendable degrees. General branches, I mean general medicine and general surgery and onco, in general onco. So where there are defendable branches, we can defend ourselves because it's included in the curriculum or syllabus means you can defend yourself. So one general surgeon who is really good, has learned so many things and he's doing, I should not discourage him from not doing many procedures. Only thing is he has to do it as it is done by any other people or with at least some basic world standards. Otherwise, his qualification is always a defense for him, whereas his competency has to be monitored. So general surgeon can evolve into a laparoscopic surgeon, he can evolve into an endoscopic surgeon, and he himself can boast himself as a pure laparoscopic hospital. He can start up a pure laparoscopic. I don't do anything else. Similarly, so general branches are defendable degrees, I would like to say. So itself has got a arena of super specialty. One has to go ahead and do it. Minimum standard treatment, general surgeon should learn. Okay, and we all know that the cure part is not handled by judges, but it is handled by mainly the mob. They come and hit us, beat us. So case selection is also important, but I will not go in depth into that kind of thing. A professional man, as expected by the court and judges, should have a minimum degree of competence. So you should go for reasonable care, reasonable qualification. These two words are very cautiously used in judgments. Reasonable standard care, standard minimum care, I would like to say. Standard minimum care and reasonable qualification is standard qualification. That's your MS degree holder, whether you are passed or not is more important. And you are really awarded, you are registered under Medical Council of India, Karnataka State Council or some state council. And also court has mentioned commercial minded doctors recently because few of the judgments are coming in adverse ways, that is commercial minded doctors. These are commonly mentioned terms. Fiduciary position is a very standing top position where patient cannot take judgment decisions, whereas a doctor has to take on his own fiduciary position. So professional rights, that means we are covered under Article 19. If somebody says you can't do this procedure, so then it's not right. It's a fundamental right. If somebody refuses to refer a case to you when you are sitting as a general surgeon in a college, and he writes this is not a case of general surgeon, then you definitely go for reinstatement of your right, because 19, which gives your writ petition, has full legal proof that if some dean or some professor, some head of the department writes and gives you a letter that these cases should not be seen by general surgeon, then professional rights are infringed, and you can directly go and claim for the Article 19 under writ petition. So paragons of service, which is very wonderful terminology used by the court, where for institutions where the treatment is free. Medicine is an advanced complex science with many variables where response of each patient varies. These are the wordings taken from a judgment, Supreme Court judgment. Cure is not like results of physics and maths. So Boehm's test still stands. Really what Boehm test is test for qualification and test for minimum standard of care. Who does the Boehm test? It is done by usually medical boards. So medical board, usually standard medical board constitutes 3 people, usually odd number, 3 people, 5 people, 7 people, 9 people, 11 people. So 3 people medical board usually should have a person who is now accused, and that person, the same kind of degree holding persons should constitute the board, especially from a government medical college. And one fellow should be forensic science expert, and otherwise LLB qualified person from with a medical degree background. So they will take a decision on Boehm's test. This is called peer adjudication. So again, care is guaranteed on Boehm, cure is not. That means care is guaranteed on Boehm means Boehm test tells about qualification. It tells about the standard of care, and that is how the care is guaranteed, and cure nobody can guarantee. So simple, complex and complicated things which are mentioned in the court cases is like alone, if you are alone dealing, better involve some complex cases or complicated cases. If you can't involve, better refer. A complex case, why you want to handle when you have got plenty of simple cases? If you don't have plenty of simple cases, only complex cases are coming there, means that's not the place to practice. Nobody does complex cases in private practice. Most of the complex cases are done in medical colleges because we don't know the outcome and you need around the clock monitoring by doctors. So complex cases are there means either you involve or refer. So this is a message for young surgeons. I know our HODs are sitting there, but still, these are the few of the things which are from the court cases I am stressing. Case selection comes under duty. You have to think very carefully where duty and breach. Duty, breach, and then the injury. Otherwise, these 3 things are looked in the court. So you can't involve a doctor. Like for example, you call a gynecologist, but she's not coming to help you for removing his uterus. Hysterectomy is a common procedure where you have not taken a consent. Then you have to disclose directly, or otherwise you better refer such case, but you are in the middle of the operation. Then you have to disclose to the patient attenders directly that this is a procedure should have been done by a gynecologist, but it's not available here. I'm going ahead, I'm a general surgeon, I'm not a specialist of that branch, and take a special consent and take a signature and you can go ahead. That consent itself is a powerful defense. So to constitute a crime, a negligence, there should be a duty to select, duty to investigate, duty to select, duty to investigate, and duty to treat. Then there should be breach of either of the three. Then there should have been a damage. Then it leads to criminal, otherwise civil liabilities. So MBBS doctor is permitted by law right now, presently in India. I don't know whether it is permitted in US or UK or even the Western or European countries. No MBBS doctor is permitted to do delivery. So delivery is a complex, complicated health service, but still it is permitted to MBBS doctor. ANC looking into antenatal checkup itself is case selection. Conducting for full-term normal delivery itself is a procedure. Putting vacuum is an advanced procedure. Putting forceps is an advanced procedure. But all these things are permitted to an MBBS doctor. It includes diagnosis and treatment, but still permitted because essentiality, healthcare. So it is still inequitably distributed, still unequally distributed. So India is not in the state of European standards. Still, India is in the state of Indian standards, where still we need doctors to work hard and not to get afraid of doing few things where because of we are afraid of doing things, and the public are deprived of their services, and there is no availability of services at so many places. I can name some 100 places where no availability of doctors. So doctors should not be hesitant to do. And this era of subspecialty and the era where we try to become super specialists and try to stay at some faraway places, that itself defeats the original motto of what doctor. So surgeons epi again continues, surgeons epi itself, unequal distribution of health care professionals and hospitals, how to guarantee care as per the courts. I already explained limited resources and emergencies. There itself is a defense. Then court's opinion.
Sorry to interrupt, sir.
Advances.
We have
Yes, sir.
5 more minutes for the discussions.
Yes, sir. I will just go ahead and I'll try to consolidate it. So before I could finish, I would like to tell you only one minute. So qualification approves the skills and competency. Please note this. Bolums is still standing in India. Bolita is not standing. And along with the plans notes, you should write refusals, referrals, and irregular follow-ups. You should better mention. Not written is not done in the medical records. Written may be done. So records has to be maintained for 6 years. Records as written in the court cases, then emergencies. Refuse you have to mention. And medical records, not for medical legal purposes, should not be written. Registration number should always be written. Consent and consider names. I am just can we disclose something? Disclosures of your degree, your facility, your complication should be there. And consents and disclosures I already mentioned. And we have to take separate consents. It's not only consent, it is actually consents. And it should have on table deviation should also have taken additional, like we have to take consents. And fees, actually it's compensation multiplier method is actually followed, which should be we should fight against through ASI. So self-declaration of income form should be taken and feedback form should be taken from the patients. So group practice, gold standards, referrals, provision of reports and summaries, and shifting disclosure facilities. And medical institute who requires duty breach. I am just going like same criminal 304, 337, 338. How to lack of qualification is the only way to punish the general surgeon, which is difficult. Whereas deviation from the procedure, it may be still civil liability stands. So no need to worry too much. General surgeon cannot opine on obstetrician's syllabuses. For example, similarly, obstetrician syllabus, we can't opine by general surgeon. So who can opine on syllabus standard of care? This is also very important, especially for those who are there in the medical boards. Experts opine on minimum standard of care. General benches are protected under qualification issue, but may suffer civil negligence under minimum standard. So no before do. Negligence is commission or omission. Okay, I am just closing it. Bolam and Bolito, you are understanding. Bolito has got only once the Supreme Court has used, where Bolito is logical basis of the opinion from the medical board. So I'm just closing it. So 304, I'm telling, criminal negligence, I just want to 304A, criminal negligence, diagnosis and treatment, death, rash, negligent one, lack of qualification and death of patient. These are the requirement for 304A. So we go for all these things. I'm just closing my presentation, sir. Any questions I'll take.
Sir, thank you so much, sir. Sir, permission of the chairpersons, can we conclude the session?
I think so, because we have consumed the time. There is no time for question hour, right?
Yes. Thank you so much, Harsha, sir.
Yeah, thank you, sir.
And thank you, Dr. Arvind Patel, sir, Dr. Chandrasekhar, sir, and Dr. Shivaram HV, sir, for chairing the session. Moving on to the CSEP session 3, I would like to call Dr. Naresh Kumar P. and Dr. Shrikar Pai, sir, to chair the person, to chair the session. And also I would like to call upon Dr. Ramkrishna HK to give his speech about drawing up a protocol for a thesis or a research study.
Hello, good evening, everyone. Can I share my screen?
Sir, it is shared, sir.
Good evening, everyone. I would like to thank KSCSI for giving me this opportunity to talk on this subject. So for our practical purposes, I think we can make a thesis and research study as one and the same. Though there are some slight differences are there, we can take it as one and the same. I would like to deal with this topic by answering these questions. What is a protocol? Why we need it? How to write a good protocol? What are its components? So first of all, what is a protocol? A protocol, next slide please. A protocol is an explicitly written document. Explicitly means you should explain everything. You have explained everything in detail, leaving nothing to imagination. There should not be any ambiguity in any of the sentences. And during the research, the researcher or the person who is assisting him, they will get some questions. So the main researcher should anticipate all the possible questions, and he should answer in the written protocol. The statements, the parameters, the definitions, all those things should be unequivocal. There should not be any ambiguity in the definitions. Anyone who reads the definition or the parameter, he should interpret it in the same way. That is the type of definitions we require. Why I am stressing more on these words: explicit, unequivocal, unambiguity. Next slide. Next slide. Because the human beings are known to interpret anything in a way that is attractive to them, that is useful to them. See, this sentence looks very straightforward. Spend at least 1 hour on treadmill to reduce your weight. And this person, next. This person, one patient, he has spent 3 hours a day and still he is not losing the weight. Why? When we asked his wife, she showed this photo. He has literally followed. He has interpreted that sentence in a way which is convenient to him. And that's why it is not giving the results. This looks like a joke, but this can happen in real life and with many of the research projects. So I am stressing explicit, unambiguity, all these words. The protocol should describe the background information available on the subject, the lacunae, the knowledge, and how the study is going to fill that knowledge, lacunae, the objectives, study designs, and all these things. We'll come back to these things a little later. Next. So in short, the protocol should be written in such a way that if some other researcher uses the same protocol and conducts the research in the same pattern, he should get similar results. This is how the protocol should be. An ideal protocol will be will satisfy this condition. So any other person, if he repeats the same research using the same protocol, he will be able to get a same result. Next. Next. So having known what is a protocol, now we should know why we need to have a written protocol. See, while doing the research, the main researcher, he will have some unexpected questions. He should expect them in advance and whatever is there in his mind, he should clarify all his thoughts in a written way. For example, he would have excluded some patients, like all pregnant women are excluded from the study, but he would have forgotten to add a pregnancy test. So now when he is writing down, he will write down that in the materials and methods, a pregnancy test will be done in all women of childbearing age group, like that. So this is how it will answer some of the unexpected questions. Next. In case of multicentric studies, or multiple researchers are involved in the same study, the written protocol will ensure that all the centers, all the researchers, they use the same method, same definition, so that there will be uniformity in the methodology used. Otherwise, what happens if one center will be using a 10 into 15 size mesh, another center is using 7.5 into 12 centimeter mesh, then the study results, it will not be valid. So somebody will question the validity of the conclusions. This should not happen. That's why the written protocol should be there. It will ensure the uniformity. A written protocol is also required to get approvals from various authorities. It may be the institution, institutional head, or ethics committee, or funding agency to sanction the funds for the project. They all require a written protocol. Because a written protocol is a registered document, it ensures that the study is conducted according to the protocol right from beginning to end. Nothing is added or deleted or changed in between. So the same protocol will be continued throughout the study. So these are the reasons why we need a written protocol. So having known what is protocol, why we need it, now we shall see how to write a good protocol. Planning is very, very important. Spend some time in planning the things. Maybe you can write it down, see it, discuss with your colleagues, seniors, and then if necessary change. And before finalizing the written document, you should have adequate plan. And it is really worth it. Whatever time you spend there, it is really worth it. Next. The protocol should contain the details of the investigators. All the investigators' details should be there, their name, their contact details, what are their qualification, to which institute they belong, what are their experience. All these things should be mentioned about each of the investigators, and more importantly, the exact role they are playing in this research project. For example, Dr. A may be concerned with the concept, Dr. B may be concerned with the actual operations, another Professor C, she may be dealing with the analysis and statistics. Like this, exact role should be mentioned so that they are, whether they qualify for the authorship or not, we will know. And the questions regarding that particular problem can be directed to that particular person. The protocol is written in a definite format. This is the format. If you see this, you will observe it is similar to the type a scientific article is written. The headings are more or less same, except that there is no conclusion here because the study is not yet completed. It is only protocol. Conclusion is not there. Otherwise, this looks similar to a scientific article. Next. First of all, the protocol should have a title. That title must be concise. It cannot go into paragraphs or too many words like. At the same time, it should be descriptive. These two things looks like contradicting to each other, but actually they are not contradicting. I will tell you how. And the main thing is, if you look at the title, it should the reader should know what to expect out of this study, what new knowledge he is going to get after completion of this trial. So to give a attractive, catchy title, you should think a little bit and try a few titles like. Perhaps this is the only part of the protocol which can be changed later. If the researcher thinks that a change title suits better for his study, then he can change it, but other part of the protocol cannot be changed. See, for example, this I have taken from one of the protocols examples from the internet. This says robo-assisted versus conventional laparoscopic surgery in rectal cancer, a randomized control trial. Next. So this title is concise. It has got only few words, but at the same time, it is descriptive also. It says what type of trial it is. It is a randomized controlled trial, what disease it is dealing with, it is a rectal cancer, and what it is studying. It is studying two types of surgery for the same disease, like robo-assisted versus conventional laparoscopic surgery. So all these things are there. So it is concise as well as descriptive. And the moment you look at it, you will know what knowledge you are going to gain after this conclusion of this trial, because you will know whether robo-assisted surgery is better or conventional laparoscopy surgery is better for rectal cancer, or both have got the same result. There is no difference between them. This is the knowledge you are going to get. So all that will be there. So that is the ideal title. The next comes is the project summary. So summary should be written in the end, even though it comes first in the protocol. It is best written in the end, because only at that time the researcher will know all the the problems and the advantages and what are the important things to stress. All these things will be known only at that time, and he will see that nothing important is left. And this part should be written in such a way that it makes sense in itself. The reader should not be referred to another part of the article or the writing to understand a particular sentence. So if you read only abstract, still he should be able to understand everything. That's how it should be written. And there is a word limit. It cannot go into pages together. Around 250 to 300 words would be ideal. While writing project summary, you should keep in mind that this will be read by many. If it is a science article, if it is an article on the surgery, only general surgeons will be reading that. But this protocol will be read by many, and some of them may not even be doctors also, like ethics committee members. There may be lawyers, or the funding agency, maybe accountant, like that. So they also should be able to understand the protocol written. So this you must keep it in mind while writing. So keep it as simple as possible, so that even non-doctors also will be able to understand that. And you will write it better if you realize that probably this is the only part of the whole document which is read by many to decide to reject or to accept. So you should exercise maximum care in writing this part of the project protocol, and spend sufficient time. Perhaps you can discuss with your colleagues, and if you think it is not okay, then rewrite the whole thing in part or whole project summary, and it is worth it. Next. Then comes the project details. So project details are also written in these definite headings. So first of all, rationale. Next. The rationale should describe what is the background information already available. Any subject, any topic, there will be already some known facts. So those things you should describe. Maybe you have to quote some of the published paper which are already published in the literature, and then you can quote them. And you should specifically mention what knowledge is not there right now. That means there is a gap in the current knowledge, and how your study is going to fill that gap in the knowledge. And ultimately, you should be able to justify your study by saying how relevant it is to the current practice. Suppose some current practice is something is going on. At the end of the study, by your conclusion, you should be able to show that the current practice should be improved by instituting such and such things. So that importance, that information should come up in the rationale of the study. Then it will be a good one. Then you should mention what is the objective. Tell me how your aim is, how you are going to fulfill your aim by studying particular objective. This should be very specifically mentioned. It should be very specific, like recurrence rate. We are going to study mortality rate, the disease-free survival. Like that, it should be very specific. And the objectives will be usually one or more. One primary objective will be there. A few secondary objectives may be there. The primary objective is very important, because based on the primary objective, you are going to calculate the sample size. These are discussed more detail in designing a study. Here, I will skip it at this point. Next. Next comes the methodology. This is the most important part from scientific people point of view, this should describe everything about the project. What are all you are going to do? Everything you must describe, starting from the study design, whether it is prospective or retrospective study, whether randomized or not. If yes, how you are going to randomize, whether blinding is done. If yes, how you are going to do it, whether it is single blind, double blind, like that, how you have calculated the sample size, what is the duration of the study, what are your inclusion criteria, exclusion criteria, all these things. And the most important is the description of the intervention is very important. If you are studying some particular procedure, you must describe it in detail. Everything should be described. If it is a laparoscopic mesh repair, then you should mention whether what is the size of the mesh, what type of mesh, whether it is light mesh or heavy mesh, whether we are going to fix it or not. Everything, all details should be written in the protocol. How you are going to follow up your patient, this is also to be mentioned. So this is the thing requires great detail. Next. So this is the most important, but also you should mention the timeline, how long you are going to enroll the patients, when you start the enrolling of the patient, when you are going to end it, when you are going to start the analysis, when you will be publishing the report. All these details, approximate timeline should be given in the protocol. Also, you should show how the safety of the patient is ensured. See, safety of the patient is most important point in any of the clinical trials. You should mention how you are going to ensure this. If any conflict of interest like funding, or you have got some interest in type of material you have used in the study, these things should be mentioned. And last but not the least, the limitation of the study. What knowledge you are not getting out of this, means there will be limitation because of the sample size, or it may be no blinding is there, it is a retrospective study. These are all limitations of the study. These things also should be mentioned in the methodology. And the database management and data analysis, these are very big topics. Each one itself will become a talk like. So to summarize, what are the data points you are going to collect, how you are going to collect it and create a database, what statistical methods you are using for the data points. If you are using any of the software applications like ASPSS or module, something like that, you mention what module you are using, whether you are using intention to treat protocol or modified intention to treat protocol. These things also should be mentioned there. This is beyond the scope of this talk, so I will skip it at that point. Next. Any study involving the human beings should be ethical, means it should conform to the Declaration of Helsinki guidelines. So visit this web page. Next. This is the web page of World Medical Association, where the Declaration of Helsinki is there. You read this, and your study should conform to the statements made here. Next. So the importance of informed consent cannot be overemphasized. Needless to mention that signature of each participant should be taken along with a witness. There should be a provision to sign a witness there. And a copy of the informed consent form, what you are going to use in your study, that also should be attached along with the protocol. Specifically mentioned that each participant has got a right to opt out of the study without assigning any reasons at any point of time. Initially, he might have agreed, but later he thinks, I want to opt out. She has got right of that, and he can do that. That also should be mentioned here. Next. References, it is just like we write references in the scientific article. So all the articles, resources from which you have used the information, it must be cited. We know there are two styles. Most commonly used is Vancouver style. You can also use Harvard style. You should mention that. It is just like in a scientific paper, you have to mention that. Next. So if you have already got approval from any of the agencies, to the authorities, those things should be mentioned along with the approval number, or a copy of the approval letter also to be attached. Or if you are not at got, you are going to take, that also you should mention. Next. The type of approval you require depends on the type of the study. Next. For example, if your study is dealing with radiation, then approval from the Baba Atomic Research Center may be required. If your study is dealing with some animals, then Institutional Animal Ethics Committee from approval will be required. Like that, depending on the study. This is not an exhaustive list. A few possible things I have mentioned. All may not apply to all studies. So depending on the study, some of them will apply. Next. And it is a good idea to register your protocol in Clinical Trials Registry of India. Right? Next. So this is the website. And please note that you can register only prospectively. Once you start your study, you cannot register here. So plan it, register there. That will be a good thing. Next. And another thing is in the same website, you can see some of the already entered protocol. Download some of them and it will be a good model example like. So if you study them, you will know how to write a good protocol. Next. Next. Hello. Next. Can you hear me?
It's a little broken, Ramakrishna. It's a little break in the audio.
Hello.
Yeah.
Sir, now?
It's better now. Please go on. Yeah.
Yeah. Next step. Slide is not moving, sir. Hello.
Please go on, Ramakrishna. Yeah.
Sir, slide is.
So probably Dr. Ramakrishna network is weak.
Lakshman sir, good evening.
Good evening.
Dr. Naresh here, sir.
Hi, good evening. Yeah.
I think there's some network issue from his side, I think, sir.
All right. Ramakrishna, do you want us to share the slide and show the concluding slides, or how would you like to do that? Or you want to just conclude? We seem to have lost you altogether. Dr. Ramakrishna, just log in just with the audio if you have a bandwidth issue, and we can. Go on, Ramakrishna.
Yeah.
There may be a problem with the slides. Don't forget the slides. You can stop sharing and just talk and conclude, Ramakrishna, please.
No, actually, I am not sharing, sir. It is.
Oh, somebody else is. Oh, sorry. Okay.
Yeah.
Then maybe there's an issue there, but just give your conclusions and we can have some discussion then.
Okay. Studying a few model examples will help to write it in a better way.
Yeah.
To conclude, a protocol is an explicitly written document about a thesis or research project. Definitions and statements made here in the protocol should be unequal, it should not be ambiguous, so that everyone who reads it should interpret it in the same way. Next. The written protocol is required to get approvals from various authorities like ethics committee, institutional fundings, or funding to make methodology uniform if multiple centers or multiple researchers are involved, and it is written in a definite format like what I have already mentioned. Next. The project title, summary, all these things we have already mentioned. So in that way only you should be written so that one can know what to find where. Next. Of course, you should know what are the ethical considerations and informed consent taken from all the subject. It also should be mentioned. Think of various types of approval which will be required during the study, and those things should be mentioned in the approval, in the protocol. Studying a few model examples from the internet, from the CTRI website, you can download, study them so that you can write it in a better way. Visiting some of the online resources like our association's website, kscasi.com, you can find information not only on how to write a protocol, but also on other
part like research methodology. Even our book, Research Methodology and Evidence-Based Surgery, that also will help you to understand how to write a good protocol. Thank you. I thank KSCSI for giving me the opportunity. I'm very sorry for the interference. Somehow my net connection gone in between. So I am talking through another mobile. So I'm sorry for that. Thank you.
Very good talk, Ramakrishna. There is a nice question in the chat box. Shrikar asks, how are we going to ask for funding and how does the protocol impact on such an application?
So funding agencies, there are various funding agencies. One is ICMR. The other one recently, our KSASI also started one program on this. So the thing is, you should write a good protocol, submit it in advance so that they will be able to fund it. So this funding agency, it is the responsibility of the researcher to find. If you search and find out, most of our studies, what we do in our medical college, it doesn't require much of the funding, sir. This is very minimal expenses will be there. So we can manage it. If at all necessary, it should be got in advance. Means for that, they require your protocol that should be written.
If I may add, Shrikar and Ramakrishna, MERT, Medical Education and Research Trust in Bangalore, also gives you funding for research projects. In addition to what has been very nicely listed by Ramakrishna, for funding application, you have to add a letter, a covering letter, where you have to specify what the expected cost is and what the expected grant is from the given agency. So just add that, perhaps you want to do 100 venous Dopplers, for example, each at 800 rupees or 750 rupees. Then you have to add, this is the total amount that I plan to incur. And you can specify how much of it you want, 100% of it or 50% of it, whatever. You can specify that so that the funding agency people can actually evaluate what your protocol is and give the required grant.
Yes, sir. Thank you for that input, sir.
Thank you, sir. Thank you, sir.
The chairperson's permit, can I conclude this talk?
Yeah, please conclude and go to the next topic. Thank you.
Thank you so much, Ramakrishna, sir.
Thank you, sir.
Now,
Thank you, sir.
I would like to call Dr. Narayana Hepsur, sir, to give a talk about evidence for use of lasers in anal procedures.
Good evening, everyone. I especially thank the organizing committee for giving me this opportunity to be a part of this wonderful conference. I'm going to talk about evidence of lasers in anal surgeries today. Let me just show you a few slides, few videos on how the surgery is done, and then we discuss on the evidences. Can we play the video, please? Can you just click on the video, somebody? Yeah. So this is a laser equipment. This is not the one which I use. This is another one. This is a case of laser therapy for hemorrhoids. This is nothing but laser hemorrhoidectomy what is done, which is shown here. It is as usual, the Milligan-Morgan or the other Ferguson's method, both can be done in this lasers. It is just cauterize and cut the tissues. So this is what it is. I'm not talking about what lasers are, all those basic things I'm not going to talk here, because my topic is on evidence in laser surgeries, lasers in anal surgeries. So I'm just going to show you this video and then another video, and then we're going to talk about what are the evidences. So this is how as we do the routine surgeries, this is the routine surgery. The laser energy is used for excision of the thread of laser hemorrhoidectomy. Next video, please. Yeah, this is how it looks. The other one is laser hemorrhoidoplasty. What we routinely do now here. This, can you play the video, please? It is very simple. We usually use 5-watt power, and it can be continuous or repetitive mode. Both can be used. We use the probe which goes inside the anorectal junction or mucocutaneous junction, or you can go directly into the hemorrhoidal tissue, and then we use the energy source there, and we keep withdrawing, go up to the base of the hemorrhoids, and then keep on withdrawing 1 millimeter per second. As we withdraw, the hemorrhoid tissue shrinks. How much the shrinkage occurs? Usually it is about 30 to 40% the shrinkage which we get to see, not more than that. We don't expect it to just disappear like that once you use the laser. It takes about few days for it to shrink, but immediate shrinkage of about 30 to 40% shrinkage what we get to see. The light emitted should not be more than right. See, this is the too bright area. We're not supposed to use the lasers here. Once it's in the right plane, once you realize it is in the right plane, you can fire, and then it will be able to shrink. It will cauterize and shrink the tissues. So coming to the evidences, what we have got. Hemorrhoids, there are 14 studies which has been done and described about laser hemorrhoidoplasty and laser hemorrhoidectomy, represented by 1570 patients, that is 1,570 patients with grade 1 to 4 hemorrhoids. Primarily, there are the studies, primarily the laser therapy seem to be very safe. Single intraoperative complication was bleeding, which we have seen. Bleeding is the only complication, which is about 0 to 1.9% for laser hemorrhoidectomy, and the other laser hemorrhoidoplasty is 7%. So I'm not able to move my. Okay, I'm not able to move the cursor. Fine. And the single intraoperative complication was, as I said, it is about 0 to 1.9% for laser hemorrhoidectomy and 5.5 to 16.7% for laser hemorrhoidoplasty. Managed with intraoperative laser or suture or conservatively. Post-operative complications occurred up to 64% of the patients after laser hemorrhoidectomy and up to 23.3% after laser hemorrhoidoplasty. However, these complications were frequently minor and which did not require therapy or were treated with conservative measures. Only 0.9% post-operative complications required surgical therapy. 64% of the patients of bleeding reported with laser hemorrhoidectomy consisted of post-defecatory bleeding, which did not require treatment and spontaneously resolved with 7th post-operative bleeding. So with this, we can conclude that laser therapies confer the advantages of quick return to normal activities and low post-operative pain. Non-excisional laser therapies, including laser hemorrhoidectomy and laser hemorrhoidoplasty, are safe and effective, and it should be considered for treatment of grade 2 and grade 3 hemorrhoids, non-responding to conservative management. This compared with open hemorrhoidectomy, which showed that decreased post-operative pain score associated with laser hemorrhoidoplasty and hemorrhoidectomy. 2 studies reported symptomatic recurrences with ranged between 10 to 11.3 at 12 months. And RCTs have been done. All have shown that the results are much better with laser hemorrhoidectomy, significantly lower than open hemorrhoidectomy. That was the conclusion which we have drawn. Next slide, please. And then we're going to talk about fistula in ano. Fistula in ano, I've taken a video of Dr. Kamal Gupta because I had no video of mine. I've spoken to Dr. Kamal Gupta and I've said I'm going to utilize his video. Kindly play the video, please. So this is the laser hemorrhoidoplasty, laser fistulectomy, which is done. We identify the internal opening by injecting the betadine with peroxide or methylene blue with peroxide, and flushing of the tract is done. And the tract is railroad method of introduction of the laser beam fiber which is used. This is a railroad method. And the laser then the bare fiber which can be used. As the laser fiber is used, again we withdraw every second 1 millimeter. Once we withdraw, the tract gets burnt and the internal opening is excised and ligated with 2,0-vicryl. Similarly, external opening can be left open or can be ligated also. So coming to the various studies which have been done, they're all retrospective studies which we have come across. The fistula, these studies published within the last 5 years, and all of them were from European countries. All studies were retrospective cohorts concerning the quality of studies. 6 studies were of fair quality. In total, 454 patients were reviewed. 67% were males and rest were females. The median age of the patients was 43 years. Technical aspects of PHYLAC. In 5 studies, PHYLAC procedure was performed using a device of Biolytic, which is a German equipment, while one study used the device of Ifton, and one study did not specify. The procedure was performed with diode laser platform, emitting laser wavelength of 1470, and in all studies, but the power of the laser varied across the studies, ranging from 12 to 15 watts, and the withdrawal speed was about 1 millimeter per second as usual. The total 296 patients achieved healing after primary PHYLAC with median follow-up of 23.7 months. What was seen, the mean rate of primary healing among the studies was 67%, while 34% patients showed non-healing recurrence with mean primary failure rate of 32%, which was significant, of p-value of less than 0.001%. And re-PHYLAC was performed in 19 patients, and 8 patients of them achieved healing. The weight after primary and secondary PHYLAC was 69%. That is p-value of less than 0.001. 25 patients developed complications after PHYLAC. All of them were minor. Complications were managed without surgical intervention. Temporary pain was which was noticed post-operatively in 11 patients was most common complication, followed by abscess in 5 patients and bleeding in 4 patients. Next slide, please. So this is a study of Dr. Kamal Gupta in current hospital, Jalandhar. They have done a study of PHYLAC, DPL SOLFT, and DLPF. Total 114 cases have been studied. Recurrences were 8 comparatively, and no incontinence has been noticed. Overall pain score has been less than 1. Okay, and next slide, please. Next slide, please. So to conclude, The FILAC or fistula laser closure is promising sphincter saving technique for the treatment of FIA. It has proven efficacy of 2/3 of the patients achieving complete healing after primary application. The main advantage of FILAC is good safety profile with very few minor complications and almost no negative effects on incontinence. These promising results for FIA treatment, fistula nano treatment, well-designed randomized controlled trials comparing the FILAC with techniques are required to substantiate the promising outcomes reported in this review. Next slide, please. Can you just play the video, please? This is of fissure in nano, a small video. So what we do is we usually locate the can you just play again? I'll just show you that. Can you just go back a little? Yeah. This is the point. This is the fissure, which is anterior fissure. We usually identify the fine line between the external sphincter and the internal sphincter. You can recognize and feel the sphincter well. You need to develop sphincters. Internal sphincter is well felt. We hook it up as usual. Some of them are, I think so, used to this kind of closed sphincterotomy. The same technique is used here, nothing else. And the power is about 5 watt power, what we use. We just pass the bare fiber inside and we go on cutting it from inside at the with the feel from inside. When we cut, it's about again 1 millimeter per second. When we withdraw, the tissues get coagulated and it will be disconnected. As we withdraw, there may be some amount of bleeding. If there is a bleed, you can always put pressure and it will stop. Or if there is no bleeding, you can always just withdraw it and no need to close the opening. So this is another laser therapy for fissure in a nose. The clinical case control study was carried out in another hospital, ARC in Iran. The total 300 patients with acute anal fissures who were non-responding to medical therapy were taken up for this laser sphincterotomy. The mean healing time was about 14 to 10 days with case group of 16 to 12 days in the control group. An independent test showed mean healing time scores were not significantly different in the two groups. Next slide, please. To conclude, the new surgical method was found to be successful, that is none other than laser therapy for anal surgeries, which is easy and quick way of treating the anal fissure. The technique also increased blood supply and decreased pain. The benefits of laser therapy include effective resolution of all clinical symptoms, decreased recovery, and time and minimal risk of side effects. The techniques have to be satisfied with the treatment. However, there are some limitations to this procedure. Surgical techniques and biostimulation effects and methods of employing the handpieces should be taught to the surgeons. Safety is also important when working with the lasers, which should be considered always. These are my references. I could find very few references actually. With these references, I have given whatever evidence is possible in the anal surgery. Thank you. Any questions? I think so. There were some questions in the chat box.
Yeah, Dr. Epsur.
Yeah, please tell me, sir.
Dr. Naresh here. In your experience, I just want to know, by using lasers, were there any instance where you could, could overshoot the tissue or get into some other plane when Because when we use
Yeah,
lasers for
we
venous,
always do that. Yeah, it is always, it happens. It does happen. In the initial few days, I really had this kind of trouble. I used to overshoot or underdo or things, and slowly, once I started doing it more and more, I've been able to correct them, and I'm able to overcome that. As I told you, the laser beam, what you see, that light, what you see, it should not be too bright or too dull. If you are in the right plane, it will be just visible. I always, what I do is I put off the lights, OT lights completely, and then pass the probe, and then I see the probe whether it is in right plane or not. After I understand it is in the right plane, then only I fire. Otherwise, I don't do that.
thank you.
Yes, sir. What about the lasers in complex fistulas? Complex fistulas, I have not done actually, and usually the plain fistulas, good tool. Complex fistulas, we need to identify all the fistulous tracts and do it. And if at all done properly, it should give a good result. The cost of laser equipment in India, it is about 5 to 10 lakhs or 12 lakhs based on the equipment we want to purchase. There are two companies which are promoting in India now. That is Lasertronics, and another one is Neo Lasers. The Neo Laser is priced around 13 lakhs. Bioletic is priced around 12 lakhs. Then Lasertronics is priced around. Take a separate consent, disclose your degree and complications, disclose a limitation of facility. No,
but
I
that
don't
is
think
for
so.
the
This
previous
is,
talk.
yeah, I'm sorry. The internal sphincterotomy, damage to the external sphincter. Yes, sir, that is what I told you. We need to recognize the internal sphincter, feel the internal sphincter properly. And if you go in the proper plane, you'll be able to feel the internal sphincter properly. You can hook it up. And as we used to do the closed sphincterotomy, if you do the same procedure here, do these procedures, we will not get a hang of it. We need to do these procedures, then only we'll be able to understand. Lasers, it's more of a hype than reality. Once we start doing the procedure, it becomes very simple and easy. What is the essential difference between the laser, cautery and laser, which makes the outcome better between the true hemorrhoidectomy and laser hemorrhoidectomy? As I've seen the laser with cautery, I have done laser hemorrhoidectomy or regular hemorrhoidectomy with a cautery or bipolar. Overall, the scarring of the tissues and the healing of the tissues, post-operative pain is much more in cautery, whereas with lasers, the post-operative pain and shrinkage of the tissues is quite much better and faster.
Sir, perhaps so, Dr. Godey has asked if you can deal with high fistulas also with lasers.
Yes, sir, we can deal with the high fistulas. We need to curate out the whole tissue tract, which should be clearly visible and felt properly. Our fingers are the best way to feel the tract. We should develop our fingers to feel all the tracts and all the sphincters properly. What is called as digital palpation, what we do, it should be better than a Doppler, I feel. So once we develop that fingers, we'll be able to get the fistulous tract properly. Please, I don't perform a leak test for lateral sphincterotomy. It is not routinely performed. It's not required. Role of harmonic versus lasers. Harmonic also I have used. The shrinkage and the results are much better in laser than the harmonic. Between WAFT and FILAC with high fistula, which is better? WAFT is a similar method. FILAC is nothing but laser usage in that WAFT. That's all. Nothing different much, madam.
Sir, good evening, sir. Dr. M.B. Patil here, sir.
Here, sir. Anand.
Sir, nice talk. I just want to know, before you proceed for hemorrhoids, do you have to
Yeah.
compulsorily de-arterialize the vessel, sir? Is it part
No,
of
no,
the?
no, this is a very interesting thing. I do it only whenever there are hemorrhoids are too huge, or which digital palpation, ligation of the hemorrhoidal tissue at the base, which was done.
So because
where we use
some studies have
it's a-
mentioned that irrespective of size of the hemorrhoidal mass, it's better to de-arterialize because you before you proceed with the hemorrhoidal main hemorrhoidal mass, you just throw few pulses on the artery, so that will it will de-arterialize and
de-arterialization of the tissues, and the results are much better, it is said. But I have done I do it only when the hemorrhoidal tissues are quite
okay.
Sir, absolutely.
big and 3+, if at all, then only I do it. Otherwise, yeah.
Absolutely. How do you tackle the prolapse thrombosed hemorrhoids with laser?
Prolapse thrombosed hemorrhoids. Again, we can always use this hyalinase. It can be injected into the thrombosed tissue, and it will shrink, and we can excise that, and then we can do the regular hemorrhoidectomy or laser hemorrhoidectomy.
Thank you.
So with the permission of chairpersons, can we go to the next?
Thank you, Dr. Lakshman sir, and the organizing team for giving me this opportunity. Thanks for
Still, we have 8 minutes. Are there any questions more, sir?
Excellent speech.
Thank you.
So can we move to the next topic?
Yes, please.
Thank you so much, Hepsur sir. Now I would like to call Dr. M.B. Patil sir to talk about fecal diversion. Is ileostomy or colostomy better after colon surgery?
May I?
Sir, you are
Hello?
audible, sir. Please.
Yeah. Good evening, all. My senior colleagues and fellow postgraduate students. I'm very happy to be part of this conference of Karnataka State Chapter, Kscasicon 2022. And also, I'm very happy to be part of this Professor T.S. Jairam Memorial CSC. My topic is a very, I would say, a little controversial one, because fecal diversion, which one is better? Should we go for ileostomy or colostomy? And which one is better after colonic surgery? I will take you through the journey, maybe initially general part, and then the lot of studies have been done. So maybe you can also, some of our senior colleagues or colorectal surgeons can contribute to this controversial topic. Next, please. Yeah, this is the scheme of my presentation. Next. Yeah, as all of us are aware, what is a stoma? Stoma or ostomy is an opening of intestinal or urinary tract onto the abdominal wall, constructed surgically or which appears inadvertently. A surgeon forms a stoma by rolling the bowel's end back on itself like a shirt cuff and stitching it to the abdominal wall. You can see in this picture. Next. Yeah, a lot of history involved in the creation of stomas. If you look here in the first line, Sushruta, our own great scientist and surgeon, way back 600 BC, advocated the closure of traumatic wounds using pincers of black ants and reintroducing the gut in the abdominal cavity. The first deliberate stoma was done in 1710 by Mr. D. Litter for anal atresia. In 1757, Lawrence Hister recommended exteriorization of intestine after trauma and wrote, lips of the intestine so wounded, wound sometimes quite unexpectedly added to the wound of the abdomen, and therefore there seemed no reason why we should not take hints from the nature. Next, please. Further, Benjamin Bell modified by creating double barrel ostomy to prevent stomal stenosis. Then the first surgical colostomy was performed by Dure in 1793. And Paul of Liverpool did large series of cases and popularized lumbar colostomy. Further, Brooke, who popularized the ileostomy, mentioned a mere simple desire is to eogenate the ileal end at the time of operation and suture the mucosa to skin. No complications have occurred from this. And we should all be grateful to this great surgeon, Koch, who is credited for describing the first continent stoma in year 1969. Next, please. Coming to the type of surgery, colostomy. So Charles Ballance used rubber tube to keep the stoma in place and prevent retraction. And Mandel is credited with being the true father of colostomy rod. And all of us owe a lot to Mr. Henry Hartmann from Paris, who advocated closure of distal stump and colostomy. Ileostomy was first reported case by Baum of Germany in 1879, and it was popularized by Mr. John Eng Brown, a St. Louis surgeon. And I'm sure many of us know French military leader Napoleon was known to have a stoma, and if you can see his pictures, you can see that one of his hand is always on the abdomen. Next, please. A little bit of anatomy, as you can see in the first picture, 9 quadrants equally distributed, and the right one shows the various sites where colon can be opened and ileum can be opened. Next, please. This is the blood supply, just refreshing the superior mesenteric artery that is supplying the jejunum, ileum, and the other part of the colon. Next, please. And this is the inferior mesenteric artery. Next. Well, a lot of physiology is involved, as all of us are aware. It's very important to understand the normal physiology and systemic response to an ileostomy or colostomy to improve the lifestyle of a patient with stoma. When an ileostomy is done, initially effluent is bilious and liquid. Later, it thickens as the patient starts with soft food. For initial 10 days, it increases and settles with stool volume of 200 to 700 ml. So if ileostomy volume is between 200 to 700 ml per day, it is considered to be normal. Anything that is more than excess of 1200 to 1500 is considered to be excess, and in fact, it can be considered as diarrhea. And form stools are unusual in ileostomy since 90% of the effluent is water. Next, please. And if you can see, the effluent depends on various factors like the amount of oral intake and metabolic effects that we see is effluent has a low volume and high concentration of potassium. Sodium loss is 60 milliequivalents per day compared to 2 to 10 milliequivalents per day in normal individuals with intact ileum. And potassium depletion is very rare in these patients. And the calcium and magnesium losses are unaffected in ileostomy. Next, please. There are a lot of studies done. One of them was by Soper et al., who studied on the intestinal transit, and he found that the emptying, gastric emptying was not affected in these patients. And bacterial flora increased by 80-fold in patients with ileostomy because the stoma is opened outside. And urinary calculi are quite high in these patients of ileostomy. Next. The colostomy fluid is approximately 1500 ml of fluid, and 12 milliequivalents of sodium is passed daily from ileum to colon. And after 10 to 15 days, the stools become viscous and semi-solid. When it comes to colostomy, in distal colostomy, the fecal volume in a well-adapted sigmoid colostomy is almost same as that of losses from intact colon. Next, please. Yeah, what is the rationale for building a stoma? So there are two important aspects. Either we want to defunction to allow healing of distal anastomosis, or reconstruction, which has been done. Decompression for distal obstruction, and then to prevent complications, we need to do the stomas, and ultimately the aim has to reduce the morbidity and mortality. Next, please. These are the indications in general, which are classified into 3 main headings: to protect anastomosis, that is in patients of immunosuppression, shock, or peritonitis after certain procedures like low anterior resection, restorative proctocolectomy, protecting repair when we have done a complex anal sphincter repair, complex fistulae, which my earlier colleague mentioned, colorectal trauma, and infections. Fournier gangrene usually doesn't spread to the perineal region, but in some cases, if it spreads far posterior, there's extensive involvement of the perineal region, you might require a stoma, and of course, bowel perforation. Next, please. This is the sighting. This is the ostomy triangle, which is between the pubic crest, then the anterior sphenoid spine and the umbilicus. And when you sight a ileostomy, it has to be in this triangle, and it has to be in the rectus muscle or to the right of the rectus muscle. Next, please. There are special considerations which we need to keep. These are the some of the conditions like obesity, patient has undergone multiple stomas, and of course, if there's a prior stoma, we need to plan properly. Next. The stomas are classified into, based on the anatomy, we have colostomies, ileostomies, based on the duration into temporary and permanent, and based on the configuration into end, loop, and others. Next, please. Yeah, ileostomy is an artificial opening made between the ileum and skin of the abdominal wall to divert intestinal contents to the exterior. And we should keep in mind that there's no sphincter which controls the emptying of the effluent, and the effluent is usually liquid. There are different types of ileostomies. It can be an end ileostomy, wherein the distal loop is closed and you bring out the loop of ileum onto the abdominal wall. Then you have loop of ileum which is brought with the proximal and distal stumps. Then you have loop end ileostomy and continent ileostomy. Next, please. Next. Yeah, you can see here the end ileostomy. That's how it is prepared, which is next. This is about a loop ileostomy. You can see that you have both the distal and proximal stomas. Next. This is a divided and loop ileostomy. Next. This is a loop and ileostomy, wherein the cut end is sutured and it is put back into the abdomen, and then the stoma is brought out as a loop ileostomy. Next. Again, about the colostomy, as you can see here, there are different types of colostomies. It can be end colloid, end sigmoid colostomy, and descending colostomy or transverse colostomy, and cecostomy in some conditions. By function, it can be decompressing, blowhole decompressing, it can be tube cecostomy or loop colostomy. Next. This is a picture of end colostomy. Next. This is loop colostomy, wherein either transverse colon or sigmoid colon is used. Next. This is a double Barrett colostomy. Next. Yeah, if you can see here, in colostomy, it is flush with the skin, and usually it's raised about 1 to 2 centimeters above the skin level, whereas it's around 3 to 5 centimeters above the skin level with a sprout in patients of ileostomy. Next. Okay, indications for either temporary colostomy or ileostomy, which already I mentioned. Next. Yeah, the differentiating points between the two types of stomas, ileostomy and colostomy. You can see stoma in ileostomy, you have sprout and it's flush in colostomy. The sighting is also RIF in ileostomy. It can be in the right upper quadrant, or it can be left iliac fossa in colostomy. And effluent, which I already mentioned, more of liquid and more of solid or semi-solid in case of colostomy. And the odor, the most important thing is ileostomy, the odor is less. It's more offensive in colostomies, and frequency of discharge is quite high. As I told you, in ileostomy, there's no sphincter, and it's less in colostomy. And another important feature of ileostomy is a significant skin excoriation and reaction, which is less common in patients of colostomy. And the most, I would say, dreaded complication, which can cause significant morbidity, is significant fluid and electrolyte imbalance or loss in patients of ileostomy, which is unlikely in colostomy. Next. Yeah, these are few of the complications of stomas. You can see here necrosis. Next. Yeah, this is, there can be hemorrhage from the stoma. There can be stoma stenosis, stricture, retraction. Next. mucocutaneous suppression, if it's not properly fixed, or there's a sepsis, or there's a retraction, or there's a effluent which can escape into the parietal wall, causing infection and disruption of the sutures. Then, of course, infection and fistulae. Next. Stoma retraction that can happen if it's not properly constructed, or if patient is obese, or if there's a short mesentery. And parastomal hernia is another complication which has been often heard, and a lot of corrective surgeries are being done to prevent this parastomal hernia. Next. Yeah, it doesn't matter if a good doctor made your ostomy. If you have it long enough, you have a 100% risk of parastomal hernia, Mr. Byron Gathright saying. Next. These are the other complications. I'm sure all surgeons have seen this. Especially this is seen more commonly in patients of transverse loop colostomy. This is very commonly seen in children. I'm sure many of us have seen the prolapse. Next. Skin complications, as I was mentioning, excoriation is a significant complication of ileostomy, and the right one shows some infections, pyoderma, gangrenosome, and granulomas. Next. Okay, just a few sentences about the stoma. Which stoma is good, which stoma is likely to go in for complications, and of course we should always look for a healthy pink or red color looking stoma, which should be moist and glistening, and the darkness always indicates ischemia and maybe in anemia. Next. Stoma can become difficult if proper planning is not done, if there are technical errors in fixing or designing a stoma, and of course difficult post-operative maintenance. Next, please. Peter Cataldo, a great surgeon, mentioned, better to create an ugly stoma in a good location than a pretty stoma in an ugly location. Next, please. Okay. After briefing all of my colleagues about the basic aspects of stoma, I thought I'll touch on the basic aspects, then move on to the topic proper. Fecal diversion, is ileostomy or colostomy better after colon surgery? Well, diverting the lower gastrointestinal tract using an ileostomy or colostomy is a challenging surgical procedure. Since centuries, there are dilemmas of surgical diversion has been, and it's been a daunting task to mankind. Temporary fecal diversion remains an area of controversy. Next. These are the sites where stomas can be done from colon or ileum. Next. According to statistics, one stats available from Western Australian Ostomy Association, there are around 3 million ostomates in the world. US has around 10 lakh people with stoma at any given time, which accounts for nearly 1/3 of the population. And the statistics mention that 1 in 500 Americans undergo stoma for various diseases. Around 1 lakh ostomies are performed. Ostomy patients are in India, and also around 1 lakh ostomy surgeries are performed annually in USA. And India, the number of ostomates is expected to be around 3 lakh. This is the statistics that is available at Tata Cancer Hospital, Mumbai. Next, please. Well, this is same, yes or no. Should I go for ileostomy or colostomy as a fecal diversion for colonic surgeries? Next. Yeah, a lot of studies have come, a lot of research, a lot of studies, prospective studies, retrospective studies, and meta-analysis have been done. I'd like to just share some of these studies about these two types of surgeries which were done and compared for various indications which I mentioned just now. In a study published by Rondelli et al. In International Journal of Colorectal Diseases, they studied among 1,529 patients and found that ileostomy reduced the risk of prolapse, sepsis, risk of hernia after stoma closure. And they did find that dehydration and small bowel obstruction in few patients was seen after ileostomy. Closure of colostomy requires opening of peritoneum. And ileostomy, you can see some of these patients going in for ileostomy, diarrhea, ending up in acute kidney injury, renal failure. And in their study, they found that small bowel obstruction was seen in 1/3 of the patients. Next. In another study done by Christian Diekling, which is published in the International Journal of Colorectal Disease, they found that shorter time to first bowel movement in the loop ileostomy group, and there was higher incidence of hypokalemia, hypocalcemia, and dehydration in ileostomy group. Peristomal skin irritation was more in ileostomy group, and peristomal hernias were more common in colostomy group. Next, please. These are the statistics. If you can see the renal insufficiency after COPD, you can see 7 patients had renal insufficiency, 3 in colostomy. And these are the various indications. Malignancies in loop transverse colostomy 76 and 70 in ileostomy. ILS was seen in equal number of patients in both the patients. Next. Next, please. Yeah, here you can see the complication rates during fecal diversion. If you can see, wound infection was significantly high in patients of colostomy. It was only 8 patients in loop ileostomy, and stenosis was seen in 1 patient of ileostomy. Hospital stay was more in patients of transverse loop colostomy, and it was less in patients of loop ileostomy. And time to first defecation was 2 ± 1 days in loop ileostomy. It was 3 ± 2 days in transverse loop colostomy. Next. Next, please. Pliny et al. Published another meta-analysis including 1,204 patients, published in the World Journal of Surgery in 2007, and found that hernia and prolapse were less in patients with ileostomy, and whereas dehydration was less with colostomy, and they didn't find much of other differences. However, the authors endorsed loop ileostomy over loop colostomy. Next, please. A Cochrane database of systemic reviews. They did a large study on ileostomy or colostomy for temporary decompression, and found that stromal prolapse was significantly less with loop ileostomy apart from other complications. Next. In another article by Mark Hanna et al. Published in Langenbach's Archives of Surgery, they found that loop ileostomy is a procedure of choice for fecal diversion due to probable lower risk of stromal prolapse and equivalent clinical outcomes otherwise. Next. Next. Yeah, same. This is the left one. The upper one shows the patient characteristics, various indications, and if you can see the complications related to ileostomy, dehydration was seen in around 12.8% of patients, and hernia after closure was seen in four patients, and ileus stricture at closure site in 1 patient. That's around 1.1%. Next, please. This is another study done by Hendren et al. They found that loop ileostomy is preferred over transverse loop colostomy for temporary fecal diversion in most cases. Next. Well, after going through a lot of studies which have been done across the world, I would like to put in the advantages of ileostomy. It's easier to construct, easier to maintain in obese patients. Interval to close is less. Effluent has no odor, whereas hernia and prolapse are less common in ileostomy patients. The disadvantages being empties continuously, there are higher rate of skin complications, high risk of dehydration, passes liquid stools. Next, please. About the colostomy, the advantages being less dehydration, less skin complications, and they pass form stools. The disadvantage being difficult to construct. Interval to close is more. Hernia and prolapses are more common in colostomy patients, and effluent has odor. Next, please. Next. There are other methods, alternatives to elastomy or colostomy. There's something called percutaneous elastomy by exclusion probe for the protection of extrapatent colorectal anastomosis. Then transumbilical defunctioning elastomy has been attempted, and transanal drainage, wherein you keep a tube across the anal canal and keep it for about a week or 2 weeks. And there's something called ghost elastomy, where pre-stage elastomy is kept. It is kept under the skin. If required, it is exteriorized and repaired if needed. Next. To conclude, proper planning and indications can reduce morbidity in stoma construction. I'd like to reiterate here that before we plan a stoma, I don't know how many of us do. We need to plan, talk to the patient, counsel them, and we need to mark the site of stoma and the sizes of the stoma. All these things have to be marked, and patient has to be made to lie down, stand, sit, bend, and make sure that this stoma is properly positioned and it is properly constructed. Both elastomy and colostomy have advantages and disadvantages. Prior chemotherapy or radiotherapy can alter the complication rates. There are newer stoma appliances and bags with a lot of advantages, which have significantly reduced skin-related complications and wound infections. However, the various studies which are published indicate that there is a slight edge in elastomy over colostomy. Thank you. Thank you for giving me an opportunity to share my thoughts. If you have any questions.
Thank you, sir. Now the panel is open for discussion.
Patil sir. Hello.
Yes, sir. Good evening, sir.
Good evening, sir. Sir, there was a beautiful article on tube ileostomy. They used endotracheal tube in the ileostomy. Endotracheal tube, wherein you can reduce the skin complications also. Do you have any experience on that? Endotracheal tube, big size they use.
No, sir.
No.
Don't have. What we've been doing here, sir, conventionally, either we do loop elastomy or end elastomy, and then we have colostomy, either loop or end, depending on the surgical indications. So my topic was for as a diversion for colonic surgery, sir.
Okay, thank you.
Hello, sir.
Yes, sir.
Dr. Naresh here, sir.
Good evening, sir.
Sir, one question. In your experience, what is the current thing that you are doing as far as the diversion is concerned?
Sir, to tell you frankly, no, we haven't done too many cases, but elastomies we construct less. In our experience, more of colostomies we have done, sir. Our experience in our institution, sir.
Okay, sir. Thank you, sir.
Go through the literature, they're both, plus and minus, advantage, disadvantage in both the groups, sir.
Yes, sir. Yes. Thank you, sir. Thank you, sir.
Chairman, sir, can I speak? Dr. Siddesh here.
Good evening,
Yes,
sir.
Yeah, good evening. It was a good talk. I think it is a topic which is really relevant, and always there is a dilemma in surgeons. What I have seen in literature when we presented a paper similar, because we normally does a ileostomy most of the times. The reason would be the literature what I had done review on in our experience also. When you have a definite period of defunctioning what is required, like most often we do it for a low anterior resection or an unplanned left-sided colonic resection. Ileostomy, we have a definite period endpoint where we will plan for a closure. So that when it is planned for about maximum of 6 to 8 weeks, ideally would be an ileostomy. A long indefinite period diversion would require better with colostomy because the chances of intestinal obstruction has been found to be higher because of bands and adhesions with ileostomy. Otherwise, the rest of the things regarding effluent is now become irrelevant because we have, as you have already suggested, they can be easily managed with the appliances, and what dehydration and electrolyte imbalance is not a issue in any of our patients. So this is my input.
Sir, just want to know from you, because you've been doing a lot of surgeries, because there's one of the question which has been asked to me about the meshes to prevent parastomal hernias. If you go through these articles, literature, there are a lot of studies which mention that you should use the mesh to prevent parastomal hernia. What's your take on this, sir?
Routine use of mesh is not recommended. We don't practice, but there are certain situations where if you feel that these stoma, especially when it is going to be a long term, when it can be indefinite, and also when it is permanent, people use them. So that is the situations. And when you think that the patient is thin, frail, musculature is not adequate enough, so that is when we should be able to decide on this. Otherwise, parastomal herniation should not be an issue in when it is a definite endpoint is there.
Yeah, there's one question by Dr. Narayan. Good evening, Narayan. Post LAR, which ostomy preferred and why? Well, I did mention about the various advantages and disadvantages, but in our institution, we are always doing a loop, transverse loop colostomy in these patients who have undergone, LAR. And there are more questions. Lakshman sir.
Sorry, I think you called out my name, but I'm talking to the secretary. Kindly excuse me.
I'm sorry, sir.
No problem. No problem.
Because this is my our limited experience which I have shared. So maybe you pioneers or seniors can throw some light, because I'm thankful to you, sir, because you've given me a very good topic and also equally controversial topic. So maybe you can throw some light on this topic.
No, I think you did an excellent job. The topic was chosen because it is controversial, and in fora like this, these are the kinds of topics that have to be discussed. And I think a very good, a series of good questions were asked and were adequately answered. I would like to just add one or two things. I have put in the chat box the European guidelines for what should be done for parastomal hernias. As you rightly said, many papers have been pushing it for even prophylaxis, but the evidence is not strong. So I don't think we should use it as a prophylactic method using a mesh for parastomal hernias. But if you do have a big hernia, parastomal hernia in a permanent stoma, the question doesn't arise in a temporary fecal diversion, but if it's a permanent stoma, if there is a parastomal hernia, it would be wise to use an ordinary mesh. As somebody has pointed out, mesh infection is not a big problem. I can't explain why it is so, but meshes have been not biological meshes, average usual meshes like a proline mesh, polypropylene mesh, have been used with safety, even in the repair of parastomal hernias. And slightly differing from what Dr. Siddesh has said, like in your institution, I also recommend transverse loop colostomy for a diversion after a left-sided resection or a LAR. My main argument is for stoma treatment, stoma management. Definitely in the urban areas, it's very easy when we have formal stoma therapists. You can take their help, the patients can take their help in managing perhaps a little more difficult ileostomy. But particularly if they are in Mufassil areas, the patients live outside metros. Without the help of a stoma therapist, it will be easier for them to manage a colostomy rather than an ileostomy. Thank you.
Thank you, sir.
Can I chip in one more comment? I agree with partly with my patients don't. Recently, I did one for a post-operative fecal fistula.
following which we had to do ileostomy. But this patient didn't come back for even once for a leak. But anyway, that depends on the stoma therapist, how effectively they can do. But another advantage of ileostomy is closure of ileostomy can be, I can leave it to my resident. Whereas colostomy closure, I had to do it personally myself.
Yeah.
So this is what I have observed, because colostomy closure takes an extra skill compared to ileostomy closure. The leak rate following elastic closure is much lesser compared to colostomy closure. These are other arguments, but in general, in our center, we prefer ileostomy. Thank you.
Thank you, sir.
Siddesh sir, good evening, sir. Good evening, sir, Dr. Naresh here.
Good evening, good evening.
Sir, just want to ask you one question. Do you routinely give loperamide? Because there was one question in the chat also, following ileostomy. Loperamide.
Only if the effluent is significant, and if you find that these patients are going in for dehydration, we need to give, sir. As I mentioned,
Yes,
in
sir.
a week or 2 weeks time, the effluent becomes more thicker, and patients also will learn to eat, what not to eat and all. Only if it's more than 1200 ml to 1500 ml, we need to give loperamide antidiarrheal drugs, sir.
Yes, sir. Thank you, sir. Yes, sir. That was an excellent presentation, sir.
Sir, thank you very much. I thank the organizers for giving me an opportunity, and we look forward for more such participation. Thank you. Have a nice time. Thank you.
Thank you, sir.
With the permission of chairpersons, can I conclude this session?
Yes, please.
Thank you so much, M.A. Patil sir, for the talk. And I would also like to thank Dr. Naresh Kumar sir and Dr. Shrikar Pai sir for chairing the session. Shall we start the next session, CSCP session 4?
Yeah, please go ahead. Please go ahead. Yeah.
I would like to call Dr. Gatti Divakar sir and Dr. Naresh Biradar sir to chair the session. And also I would like to call Dr. Rajgopal Shanai sir to talk about the surviving sepsis campaign.
Good evening.
Shanai sir, you are muted, sir. Your voice is not audible. Hello.
Good evening, Gatti Divakar sir.
Sir, good evening. I think Dr. Rajgopal Shanai sir has started speaking, but he is not audible.
Yes, sir. He is not audible.
Shanai, you are not audible.
John?
Yes,
if
sir.
you
Yes,
can
sir.
unmute. Yeah,
Yeah.
if you can unmute your Shanai sir.
No, he is
Problem with the mic?
There is some problem.
yeah, because his video and audio both are on, sir.
Okay.
We shall call him up on his mobile and I will ask him.
Rajgopal, can you hear us? Say a few words. We don't, you're muted.
Actually, I can hear
Hi,
you.
now we can hear you.
We can hear you also.
Yes, he's back.
So can I start now?
Please, sir. Go ahead, sir.
Yes, sir.
Yeah.
Thank you.
So I'll be good evening. My talk is a surviving sepsis campaign. I would like to thank organizers for giving this opportunity, and especially Chairman Arvind Patil, Secretary, and Scientific Committee Chairman. Remember, this is a topic which is more of a critical care and ICU. I'll try my level best convey some important message in this talk. Yeah, can we have the next slide, please?
So just a minute, sir. Give me 1 minute.
Screen manager, do you want me to take over? Hello, screen manager, do you want me to take over?
I have, sir. Just a minute, sir.
Hello.
Why don't you let me do that? I think I'll do that. Okay.
Yes, sir. Okay, sir.
Go ahead, please. I have.
Hello.
Yeah, I have done the recorded version. Would you prefer that, or would you prefer to talk yourself?
I can talk, no problem. So I just need the slide moving. That's all.
All right, get the slide moving, please.
Whichever way. So.
Rajgopal, you have slides with you? You can share.
I have.
You can share, or I'll play the video and then you can answer the questions, Rajgopal. Is that better?
Okay, fine. No problem. Yes, please.
Sir, the audio is very.
Audio is not coming well.
All right, I'll do it.
Sepsis campaign 2021.
Is that better?
Better,
Yeah,
sir.
better.
Thank
You may
you.
be wondering why this topic has been given, because there are a lot of articles and a lot of chapters have been written on this subject. However, compared to the last 2016 recommendation, there are few recommendations have changed. The whole purpose is to sensitize the postgraduates and the surgeons so that we follow certain guidelines to reduce the mortality. That is what is surviving sepsis campaign. Now, my talk has got following contents of screening, resuscitation, infection control, hemodynamic management, ventilation, additional therapy, and a long-term outcome and goals of care. I think this picture is not very uncommon to see. All of us would have seen how to manage the source of sepsis, a case of anastomotic leakage here. But remember, I am not talking about how to control the sepsis per se in my talk. My talk is based on how to do this resuscitation program on these grounds so as to reduce the mortality. As you know, sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection. You know, during the COVID time, different people have responded in a different way. Our aim is for an early identification of the source of the sepsis, early identification of the patients who are in the shock, and appropriate management should be done in the early hours, because septic shock per se has got a very high mortality of almost 15 to 30%. So the first recommendation goes as screening for the patients for the sepsis and septic shock is what is called as a robust screening program. Screening program doesn't mean it is a TCDC, ESR, CT scan, ultrasound, no. We talk about now the MUSE, NEWS or a SIRS. Whenever you have a suspected sepsis, please measure serum lactate. I would like to mention here Kscasicon, I'll be talking about it more, is no longer recommended, right? So now what is Kscasicon? Q refers to quick assessment. Earlier, they used to measure there are so many, parameters such as Apache 2, man-in-peritoneal index for the peritonitis from perforations, etc., etc. Kscasicon came because SOFA refers to sequential organ failure assessment based on 3 simple criteria of measurement of the blood pressure, altered mental status, and tachypnea. So that's what it is. GCS less than 15, tachypnea more or less 22, and systolic blood pressure less than 100, and a score has been given. However, it is now proved beyond doubt that it is so simple and too simple, and it is not recommended. So then what is recommended is what has been called as a MUSE score. This is called a modified early warning score. Don't concentrate complicated table like this, but just concentrate the central line. Where is a normal respiratory rate, heart rate, and systolic blood pressure? He is very alert, and there's a temperature. So anything on this left side and right have been given the scoring system. I will just take out one Glasgow Coma Scale or what's been AVPU system or APOA system. Look at that. Unresponsive means he gets the score of 3. On the other hand, agitated means he gets the score of 1. So this is what you add and you get a final score. If our postgraduates or a surgeon's consultants, if you put the score in the ICU, you can definitely reduce the death from mortality, and that is why it's called a modified early warning system. In England, they follow the modification of that is called a national early warning score system, in which they consider oxygen saturation, any supplemental oxygen, systolic BP, heart rate, etc. So we either put a muse or a news. At the end, you need to get some kind of a score here. Accordingly, aggregate of less than 4 is low, 7 or more is a high scoring system. Now, I mentioned to you about sending the lactate very early. These are some normal levels. Anything more than 2 to 4 millimoles per liter indicates, without acidosis, indicates patient is in shock. You know that when oxygen is not available, anaerobic metabolism takes place. The pyruvate gets mobilized into lactate. So lactate clearance cannot take place because of the poor microcirculation. The reason why you get a high levels of lactate. So septic shock is one of the important causes of increased lactate levels. Now, occult sepsis means you have a patient who has got a cholecystitis. He has got a borderline elevation of a tachycardia, mentally alert, blood pressure may be normal. You may take it lightly, but if you measure his lactate, lactates are very high. That means he is in a sepsis. This is called occult sepsis. Treat him aggressively. So procalcitonin is another marker of bacterial infection and systemic inflammation. It is actually more specific than lactate. So next comes the initial resuscitation of all the patients with the septic shock goes in what's been called as early goal-directed fluid therapy of 30 ml per kg of a crystalloid within first 3 hours. How do you assess? Ideal will be to have a dynamic measures. What is a dynamic measure? You need to put an arterial line so that you can measure the stroke volume variation, or even a systolic pressure variation may happen during respiration. More than 10% suggest patient is in sepsis or hypovolemia, so you can transfuse more fluids. Central line CVP is no longer recommended. So stroke volume measurements, arterial line is a must. Then you have a bedside ultrasound, check the diameter of the IVC. So increasing the checking of the diameter of the IVC also gives you an idea of the volume loss in this patient, so that how much volume to be given. Yes. So you need to have a detailed assessment now and avoid under resuscitation or over resuscitation. But important point is to note here is last one which I have written here: heart rate, blood pressure, CVP alone are poor indicators. If you do not have a dynamic measurement, then you can do what has been called as bedside measurement. I already mentioned to you about the IVC, but you don't have an ultrasound to check the diameter. Simple is a passive leg raising. Just do a passive leg raising for 60 to 90 seconds. 15% increase in the pulse pressure means it is a good response. Similarly, capillary refilling time. Normal is 2 seconds. It's more than 4 seconds. That means it is also affected. So ultimately, our aim in this patient is to bring the mean arterial pressure to about 65 millimeters of mercury. For that, after the initial 30 ml per kg volume, you need to give a small boluses of 4 ml per kg fluid to be given. And increasing the mean arterial pressure beyond 65 means it causes its own problem of vasoconstriction, etc.
So it is not recommended, and admit the patient now in ICU for within 6 hours. Next important point is to control the infection. As you know, whenever you have a patient in the septic shock, you are sometimes confused whether he has got a septic element or also consider non-infectious causes. If you have got a sepsis as a strong possibility, you need to start the antibiotics as early as possible and in a shock, ideally within 1 hour. That is a very important, which should try to cover all pathogens. And it is understood that you have sent the patient for culture sensitivity. Now look at this chart. You have a patient who has got a shock and sepsis is possible or maybe not be possible, but he has got a shock. Start the antibiotics immediately within 1 hour. Later you find that this is not due to, let us say, mesenteric ischemia. This is due to a aortic aneurysm dissected or something. You can always de-escalate or stop the antibiotic. But because he's in shock, you have started. Now look at this here. Sepsis is possible. Antibiotic should be given within 1 hour if the shock is present. But sepsis is possible. Shock is not there. Then wait for 3 hours. So you have a time now to examine, to get the investigation done. He has no shock, so start it within 3 hours. Now, what about the infection control? As I already mentioned, if you have no infection, defer antimicrobials. Now, then if you know that this, let us say, due to gangrenous cholecystitis or appendicitis, start the antimicrobials based on the clinical evaluation. Now, don't depend upon the procalcitonin. You have a right iliac fossa tenderness. You have the patients of the high count here. Treat it as appendicitis. Start the patient on antibiotic. There are groups of patients who have got a high risk MRSA possibility, like those who are staying in the hospital, those who are for a longer period, indwelling catheters, dialysis patients, etc. You need to start them on empirical antimicrobial, which cover MRSA, including vancomycin, etc. Now, whenever you have a patient who has come to the hospital in a shock, as I mentioned to you, you need to have an empirical one till you establish the diagnosis. For that, you suspect an intra-abdominal pathology, better to go for a piperacillin-tazobactam combination. As I mentioned, multi-drug resistant, go for a vancomycin. Still vancomycin resistant enterococci, go for a linezolid. Then MDR, again here you have got extended beta lactamase spectrums like carbapenems to be used, beyond which please take the help of ICU consultant before you starting the higher drugs, including. So this is you can stop up to here and later probably including penems, tigecycline, cholestyramine, etc. Take the ICU consultation into confidence and start. Now, as I mentioned to you, you try to do drugs which have got a gram-negative coverage, especially multi-drug resistant organs. When you have a low-risk patient, do not use 2 antimicrobials. Once the causative agent susceptibility are known, do not use a double gram-negative coverage. You might have already started empirical, but later you know this is due to this organism. There's no point in adding on 2 strong gram-negative organism and cause coverage and cause complications, including renal damage. All high-risk patients who are probable for a fungal infection, ICU patients, patients are staying for a long period of time, recovered from primary peritonitis, secondary peritonitis, etc. Start them on empirical antifungal therapy. No recommendation to start any antiviral agents. So you have started the patient on the initial bolus of the antibiotic. It's better to give the infusion of the beta lactams. You know, this is what has been recommended now. You can give the infusion or at least half the dosage. Interval is better than a conventional bolus for what has been called as maintenance. Again, here one need to know, optimize the dosage. based on the pharmacokinetics and pharmacodynamics principles and the drug property. Rapidly identify or exclude the specific anatomical area. Upper GI pathologies have less anaerobes. On the other hand, the colon and appendix, etc., have got more anaerobes. This is what I mean by identify them and control the emergency source control. This is very, very important. If you have a CVP line, if you have a catheter, if you have any other indwelling devices, etc., remove them, because otherwise the sepsis will continue. Now come to the 2 lines about the source control. Immediately patient has got hypotension, shock, and you don't know what it is. Fluid picks up, aspirate the pus, drain it with the pigtail catheters, optimize him. And if you know the definite pathology, take them for immediately a major laparotomy, etc. So surgical exploration is definitely indicated when the diagnosis is uncertain and percutaneous drainage has failed to improve. Once you know that you have controlled the infection, patient is improving, now try to de-escalate. There's nothing like you for a peritonitis, you give the antibiotic for 14 days, 15 days, etc. Yes, assess them clinically and also use procalcitonin or even CRP so that we know that patient is improving. Source control is achieved, short control duration of the antibiotic is advised, right? So now you have got a hemodynamic management here. In this, your septic shock and cardiac dysfunction is there. You have tried with all the possible the measures, but it has not improved. This is a time to add a dobutamine, then to norepinephrine or use epinephrine alone. Earlier, they have tried terlipressin, is a vaso analog, but nowadays it is not been recommended, of more of a toxicity. Levosimendan is another drug earlier used in a septic shock with a chronic heart failure. No recommendations. And there is an invasive arterial pressure monitoring. This is strongly recommended as soon as you diagnose a patient in shock. So start vasopressor peripherally for a reason that you are not getting the central line. Central line is not necessarily for the monitoring, but to introduce these drugs. But don't wait. Start the vasopressors in a peripheral line. You can always get into the vein. So this is a chart to tell you the shorter duration, as I mentioned to you, versus longer duration. So many articles, but ultimately they find no difference. So clinical improvement and some biochemical parameters improved, stop the antibiotics. Now, hemodynamic management, you have the crystalloids as the first line, which all of you know, and balanced crystalloids like ringer lactate is better than just pushing a normal saline, because normal saline can cause hyperchloremic metabolic acidosis, renal vasoconstriction, and even a concern about acute kidney injury. What about the role of albumin? It is given patients who have received large amount of crystalloids. Now, gelatin, starch, they are colloids. They do not help. They are basically suspension particles. So they will not help you. So please start these patients only on balanced crystalloids. Now, hemodynamic management after starting the crystalloids, use norepinephrine if the blood pressure is not picking up as the first line vasopressor. Whenever you are using norepinephrine, it is not help. Now you add vasopressin. Please remember, still it is not enough. Add epinephrine. Whenever you use the dopamine or epinephrine, remember there are some complications including arrhythmias, impaired splanchnic circulation, etc. So quick chart of vasoactive management. Norepinephrine as a first line. Target arterial pressure is 65 millimeters of mercury. Considering, as I mentioned, invasive artery monitoring for arterial blood pressure, arterial line has to be put. If the central access is not yet available, start vasopressor, and as I mentioned, add vasopressin. Later, you also add dobutamine, or lastly, epinephrine. Now here you look at that central access is not available, use the peripheral line. And whenever you use the peripheral line, pick up a vein proximal to the cubital fossa. For some reason, if there is a little extravasation, and if you use the vein more distally, vasospasm can happen, and you can have a gangrene of the fingers, what has been called as peripheral gangrene. So please avoid that. The reason why you select a vein proximal in the cubital fossa. Now ventilation, just like the COVID time people you have seen, high flow nasal oxygen is better, and rather than just non-invasive ventilation. Please remember, NIV versus invasive, no recommendation. So better to use the patient on high flow nasal oxygen. And when there's ARDS, you may have to ventilate, maintain the patient at the higher PEEP with the limit platelet pressure to 30 centimeters of water. So in patients who have got moderate to severe ARDS, ventilation with the prone position, at least more than 12 hours a day is recommended. What are the additional procedures? Neuromuscular blocking agents, they do reduce the muscle tone, and so patient may breathe better. That is the reason why they have been given. And when the facilities are available, veno-venous ECMO is recommended. And if there's ongoing requirement of vasopressor, a continual requirement, that is a time, there is a recommendation to start this patient on corticosteroids. And other few things like polymyxin B, imperfusion, immunoglobulins are not recommended. Few other therapies use a restrictive transfusion, means blood transfusion. Hemoglobin is 8 grams, start the blood, no. Transfusion refers to blood, infusion refers to fluid. Yes, when the significant blood loss is there, you need to start the blood. And whenever you are having this patient in the ICU, stress ulcer prophylaxis, whether sucralfate and pantoprazole are recommended. If there's no contraindication, start the patient on pharmacological therapy, including low molecular weight heparin, whereas mechanical therapy or prophylaxis for venous thromboembolism is not recommended. If you feel that anastomosis is perfect or DU perforation we have closed is fine, start early enteral nutrition within 7 to 2 hours. And if the sugars are beyond 180 plus milligram plus, start the patient on insulin. Patients are going for oliguria. In such patients, they require definitely dialysis. IV vitamin C is no longer recommended. And do not use pump soda bicarb as and when you require, feel like, no, nothing like that. Because what happens is, if there's severe metabolic acidemia, pH less than 7.2, and acute kidney injury, the scores are available, use soda bicarb. Whereas don't use it in patients with hypoperfusion-induced lactic acidemia to improve the hemodynamics or to reduce the vasopressor requirement. At the end of this septic shock patient after the treatment, patient might have recovered, or a patient may require further therapy. This is an example of a massive resection of a mesenteric ischemia in a young boy who requires now a small bowel transplantation. So at every stage of the life, treatment of the patient, please discuss with the family members whether you are giving a palliative care or whether you are giving a supportive care or whether you are giving a definitive care. He's been in ICU setup for a long period of time. Every decision making should be discussed with the patient party and document them in the discharge summary. Support is required for this patient. And those who are especially on a mechanical ventilation of more than 48 hours or ICU stay, some kind of a rehabilitation program is also required. So with this, I conclude my thanks also to all of you who are listening to this patiently. I want Divakar, am I audible?
Yes, sir.
Yes,
Yeah.
yes.
Yeah, just to say the quick.
You're audible, sir. Go ahead, sir.
Working with you for a muse and the new score, mean arterial pressure should be minimum 65. Fluid recommendation is 30 ml per kg, then boluses. As simple like CFT, passive leg raising, feeling peripheries, and they are important. No role for terlipressin. Corticosteroids are used in, as I mentioned, in a refractory shock which is not responding. Early diagnosed sepsis and empirical antibiotics. And mechanical VTE prophylaxis is not recommended. On the other hand, pharmacological is important. High flow nasal oxygen, and always discuss with the families on the goals of the care and prognosis early. Thanks a lot.
Yes, sir. That's a very informative talk on the critical care aspect of managing a patient who comes to ICU in sepsis. There are a few questions. The few of the questions have been answered, which have been posted in the chat box. So there is one question. Do you have any experience of renal dose dopamine? Your experience, sir?
Yeah, we had earlier used to give 2 micrograms per kg body weight of the dopamine in the early part of it, and then if not picking up, even we have increased to 5. But in now, when the norepinephrine has been used as a first line of treatment, dopamine is dopamine is now not being used regularly.
Yes, sir. According to this, as you mentioned clearly, the first thing which needs to be used is norepinephrine.
Norepinephrine.
Yes, sir. There is one question from Dr. Ashok Godi, sir. A drop in procalcitonin, does this indicate stopping the antibiotic or de-escalating the antibiotic?
Actually, it's a good question, sir. Nowadays, the procalcitonin is actually becoming an important investigation. Thing is, it's extremely, compared to the lactate and all, it's costly. However, there's what's called a procalcitonin algorithm is there. As you rightly put it, if the levels of the procalcitonin is coming down, it's a time that a clinical assessment with the procalcitonin levels coming down, we can de-escalate the antibiotics. It's a good the marker. In fact, it indicates high levels indicates a bacterial load better than lactate. And I would like to mention one thing that even in myocardial infarction, you get a high levels of lactate, but you will not get a high levels of procalcitonin. So this is also an advantage of procalcitonin.
Sir, one observation, sir. You said the Kscasicon should not be used, but they recommend that it should not be used alone, but it can be used along with, it should be used along with the SIRS or mu score, they say. Correct me if I'm wrong, sir.
In this recommendation, what I have read in this 2000, it came in October, this article.
Yes, sir.
Yes, for as I said, it's a simple one. No doubt it's a very simple one, but they say it's not recommended either is muse or a news. Maybe as you rightly put it, it can be added when the facilities are, not available for such a complicated scoring system. I think so.
Yes, sir. So compared to the third edition of the Surviving Sepsis campaign, the focus of fourth edition is more on the long-term recovery and the long-term outcome, sir.
Outcome.
Yes, sir. One question, sir. How do you define a time frame to define ongoing shock? Is there any indicators when we should consider that it's a still ongoing shock, or the shock has come into control? How to decide, sir, and to de-escalate the management?
Yeah, I think it's all based on the, as I mentioned, not by a CVP, as I mentioned, stroke volume. That one is a stroke volume, second is the IVC diameter, as I mentioned to you. Third is we have to also should go by clinical and lab. There comes the levels of the lactate, procalcitonin, etc. Because all of us will go through sometimes phases of secondary peritonitis, going in for tertiary peritonitis. So clinical, biochemical, as well as these advanced dynamic measures, these are the way to probably decide the patient is in shock or not.
Fine, sir. And in ICU setup, sir, they are worried and cribbing about the weight. Which weight we should use, sir? It is the ideal body weight or they call it adjusted body weight? Which should be used, sir?
I think adjusted is better. I don't know.
Yes, sir.
I think you can give the answer.
The important thing here is a few questions I saw on the antibiotic. I purposely meant double negative when I say that 5% in tazobactam and all when we use using metronidazole is not required. On the other hand, if you use only sulbactam or a cephalosporin combination, there metronidazole is required. So similarly, meropenem and all when it is used, it is also active against gram negative. So there's no point in adding on another gram negative coverage. So we should be very careful while looking into this. Nowadays, what happens is we just call critical care person, call infective person, specialties, and come and write the antibiotics. So at least the postgraduates and the consultant should be aware of this.
Yes, sir.
Rajgopal, I have one small question. If Gatti, I can speak.
Yes, sir. Quickly, sir.
See, you told about antibacterial. There are two things which you want. One is if you are using a meropenem or a imipenem, you said there is no need for an additional gram negative. See, but Pseudomonas, some strains don't get covered by this. So I think that is where when you are giving an empirical broad spectrum, we give initially because wait for the first culture report. So that's what we always do. So that is some of these strains of Pseudomonas get escaped in this gambit. So that is one of the reasons why we use. Number two, you told you depend if the procalcitonin, of course, procalcitonin is a very, very good biochemical marker as far as sepsis is concerned. But alone, if it is coming down, having not controlled the sepsis, I think source control is the primary aim.
Yes, sir. Sir, with your permission, sir. Sir, with your permission, please, I request Rajgopal sir to answer it in the chat box. We are getting late for the next. Yes, sir. Dr. Rajgopal sir, I compliment you on presentation of a difficult topic very beautifully as always. Thank you very much. So we invite the next speaker, Dr. Rajshekhar Reddy, to present on VATS and general surgery.
Good evening, everyone. I hope I am audible.
Yes, sir. Please go ahead, sir.
Yeah.
Thank you. It's my privilege and pleasure to come after Professor Rajgopal Shenoy, professor, teacher, author. And I practice exclusively thoracic surgery, and I have kept my talk and slides to the minimum possible so that there is ample time for discussion and interaction from those who are practicing. I think next slide. Slides, you will be changing it. I have practice experience of thoracic surgery, gradually changing from thoracotomy to thoracoscopy over a period of more than 20 years. I'm actually involved in the Indian Journal of Thoracic Surgery as an editorial board member, and the rest is there on this slide. Next slide. Greetings from the Surgical Society of Bangalore, where I was the president in 2017. Next slide. I have nothing to declare. At the outset, I thank the organizers, state chapter, the chairperson, secretary, Dr. Lakshman, and our national president, Siddesh, to involving me in this talk. Next slide. I stick to the practical points because there were many slides that I have deleted. Like if you are planning for a thoracotomy or a thoracoscopy, classical saying is that the patient should be under general anesthesia, which if I go one more extent, double human endotracheal intubation, single lung anesthesia, then comes the central line on the same side as you are doing thoracoscopy, then a Foley's catheter. These three are a must for every patient undergoing thoracoscopy, at least is a must in the beginning of your practice, so that later on, as you, with experience, you decide this given patient is a simple, straightforward pneumothorax, no need for Foley's, no need for central line. But to begin with, you must keep the patient in the lateral position. The picture on the left side is the lateral position for classically done for thoracotomy. And if you notice, both of my hands, one hand on the shoulder, one hand on the hip, both at a higher level than the chest. For thoracotomy, this position is fantastic, but for thoracoscopy, you cannot proceed beyond a few degrees of rotation because both the shoulder will obstruct as well as the hip will come in your way. So you put a sandbag or a jelly bag underneath the chest, and then you break the table in a way the shoulder, the chest, the hip, they all should be in same line so that you can look into the every corner of the chest as may be needed. Next slide. Single lung anesthesia itself is a big topic which most anesthetists will not be aware. But if you are practicing thoracoscopy, it is better you discuss with your anesthetist on a day-to-day basis, on case-to-case basis. This is what I said, classical position for thoracoscopy, patient in complete lateral position. For most of the thoracic procedures, this lateral position will suffice, with the lower leg being bent and a pillow in between the two legs, and straps, one at the hip level and one at the shoulder level. And again, with a sufficient cotton pad or a pillow between the two hands as in the sleeping position, so that there is no pressure and pressure necrosis. Next slide. There are only few procedures where the position of the patient is in not lateral position, like this one, where a patient with primary hyperhidrosis, meaning excessive sweating of palms, axilla, face. Many of these patients will also have sweating of the feet for idiopathic reasons, where you need to approach both sides, bilateral thoracoscopic sympathectomy. Next slide. And next slide. Yeah, keep it there. And in patients where you access for anterior mediastinal tumors, like in this patient for thymectomy, you need this supine position. Next slide. This prone position, much popularized by our own well-known Dr. Palanivelu from Coimbatore, is commonly used and preferred for posterior mediastinal tumors, esophageal mobilization, and it is preferred for esophageal mobilization for cancer or leiomyoma excision, and even if in case of a denture which is stuck for excision, posterior mediastinal dumbbell-shaped schwannoma, which is going through the intervertebral foramina, where the neurosurgeon does a posterior decompression, and then a prone position. Same prone position can be used for thoracoscopy also. So lateral position is the one that is commonly used, like in pneumothorax or empyema or pleural effusion or lobectomy or pneumonectomy in most of the thoracic procedures. Supine position is required for accessing the tumors in the anterior mediastinum or a bilateral sympathectomy. Prone position for posterior mediastinal tumors and for esophagectomy. Next slide. Just to iterate, when you are doing a classical thoracotomy, you stand at the back of the patient. Please keep this in mind as I go further. There are a few points which you need to keep in mind. That's why I put this picture. Next. Next slide. Yeah, stay there. If you want to practice thoracoscopy, I would rather categorically insist that you should have worked with a cardiothoracic unit or a thoracic surgeon and be familiar with at least thoracotomy, if not a sternotomy, because conversion is not a crime. Pulmonary vessels directly from the left atrium and right atrium, directly from the chambers of the heart, within 2 minutes, if there is a damage to these vessels, they will exsanguinate. So you cannot ask for help in the event of a major complication. So you must be familiar to convert. Not just you, your staff, your assistant, your anesthetist should be comfortable if you say, I have a problem, I need to convert. And the instruments for conversion must be in the OT before you start your thoracoscopy. That is the basic requirement. If you want to start fresh, please visit somebody or work with somebody, orient yourself and make sure you have these instruments. Ideally, single lung anesthesia, because I'll show you the difference between laparoscopy and thoracoscopy, then you will realize it. Abdomen is a soft cavity under general anesthesia with muscles relaxed. Put one port and insufflate the COT. Abdomen gets distended, and you have plenty of space. Put the ports and to fiddle with whatever surgery you want to do, and you're all familiar with that. In comparison, chest is a rigid cavity bounded by the ribs. You can't expand or contract to get more space. Of course, you can use the same rigid cavity intercostal space for your advantage. One other major thing that you have to keep in mind is all the thoracoscopy sets are also laparoscopy sets where the CO2 pressure is kept by default at 12 millimeters of mercury. But for thoracoscopy, you need not keep it more than 6 millimeters. 12 millimeters is more like a tension pneumothorax. Patient will not tolerate. The problem with this is whenever there is a electricity off and on or generator is on, your pressure settings automatically go to 12 millimeters of mercury. You have to keep that consciously in mind and reset it to 6 before you restart the procedure. Of course, in the current day single port thoracoscopy, I don't use, and most of us don't use CO2 insufflation. And I'll tell you what the advantages, disadvantages as you go further. Most of the thoracoscopy was started by the surgeons who were practicing laparotomy and both thoracic procedures. So when they jumped into laparoscopy and saw the advantages, the same principles were adopted for the chest and thoracoscopy, which is 3-port thoracoscopy at a hand breadth different distance for triangulation, for better access to the organ or the dissection. All those principles were used in the beginning only to realize chest is a rigid cavity, intercostal spaces much wider in the anterior parasternal part. As you go back to the paravertebral region, they are very, very small, narrow. And you can't get the same flexibility when you are working. Next slide. Of course, the use of instruments are similar, same instruments as that of laparoscopy. And in the current day of single port thoracoscopy, we use the open instruments that are used in the conventional thoracotomy or laparotomy. Endostapler is again endo-GIS stapler that is used for either gastrectomy or colectomy. So there is white, green, blue cartridges. Everything is the same. White being used for the vessels, green for thick tissue like the bronchus, and blue for separating the fissure and etc. Use of energy devices, either the harmonic scalpel or any other device, is same as that in the laparoscopy. Next slide. Like I said, the 3-port or 4-port thoracoscopy has some drawbacks. Patient in the lateral position, you cannot put a Veress needle or a first port. In most patients, common condition is empyema, where the lung will be stuck other than the areas where there is pus. So you don't know where to put the first port. Most of the time, the pocket of pus is in the paravertebral region and the intercostal space is so narrow, you can't find it very difficult to put the port in. To facilitate that, if you ask the anesthetist to disconnect the ventilation, then the diaphragm comes up. Many a times when we were doing a port thoracoscopy, the first port often used to go into the abdomen. That's the major disadvantage. As a result, we have switched over to anterior thoracoscopy, which I'll show you later on. Also, when you are doing port thoracoscopy, in the abdomen, if there is a bleeding, you push the gauze piece through a 10 mm port. That luxury of time is not available in thoracoscopy. You should be able to take a swab and a stick and go into the abdomen with no waste of time, so that you can put a pressure and stop the bleeding. That is very easy if you are doing an anterior thoracoscopy. And also, if you are doing lobectomy, pneumonectomy, or tumor surgeries thoracoscopically, to retrieve the specimen, you have to put an incision at the end of the surgery. Instead of that, you can put the incision to begin with and use it for your advantage. Next slide. Just 1 second. When you do an anterior thoracoscopy, we don't use CO2. You have a big space anteriorly to, if you are familiar with the intracorporeal knotting, suturing, etc. Or you can put extracorporeal knot and push it also. And if you have a doubt where there is tumor, in the form of a small tumor in the subpleural location, you can put your finger and feel it also. But the only problem with anterior thoracoscopy is, next slide. Next slide. You are standing in front of the patient, not at the back of the patient like in thoracotomy. So you need to reorient yourself for the entire anatomy, and it's not at all difficult. If you are familiar with the anatomy, if you are familiar with thoracotomy procedures, reorienting anatomy by standing in front of the patient is not at all difficult. Very simple. Next slide. This is what I mean to say. Let's spend some time here. Patient is in lateral position. The monitor is at the back of the patient. You are standing in front of the patient. You mark the angle of the scapula, mark the line of thoracotomy. At least in the beginning few procedures, it will help you to orient yourself. In the anterior, along the anterior axillary line or in the parasternal region, the 2 centimeter or 5 centimeter, like length of the incision really does not matter. If I'm doing an empyema case, I use only 2 centimeter utility incision. If I'm doing a lobectomy, pneumonectomy, or a tumor excision, I use 5 or 6 centimeters also. Length of the incision does not matter because you are not spreading the ribs. I infiltrate with bupivacaine, give the intercostal blocks, cut the skin, fat, muscle, everything directly into the pleural space along the upper border of the rib. And then you can put your finger and feel whether the pleural cavity is free or there are dense adhesions. If there are adhesions, you can always release it with your finger or on a swab and a stick, and then create a space, 1 or 2 spaces below towards the diaphragm, and then put a 10 mm port and take the camera there. Or if you have a wound protector, dual ring wound protector, you can put it through that single port and you need not use the ports at all. You can keep the camera to the upper end of the wound protector and use the lower part of that wound as a single port thoracoscopy to do all the dissection. Next slide. I'll just show a few examples. This was a 60-year-old gentleman, colectomy for carcinoma 4 years back, presenting with hemorrhagic pleural effusion, obviously suspected to be recurrent metastasis. But if you look at thoracoscopy, multiple miliary nodules. This is an enlarged view, turned out to be tuberculosis. Next slide. This was a 70-year-old gentleman treated with ATT for almost 5 months with recurrent effusion, turned out to be mesothelioma on thoracoscopy. Next slide. This was a very peculiar patient. The first and the only patient I have seen is a hemorrhagic pleural effusion in a 50-year-old patient with multiple cats and pets at home. Turned out to be what we call as a cat scratch disease. Like the nodules are very small, kind of like tuberculosis, but classically these granulomas are more of eosinophils rather than Langerhans joint cells. Next slide. This was a post-COVID large pneumatocele, which we could excise. If you go back 1 slide, please. Yeah, this one, post-COVID pneumatocele, filling the entire chest and the rest of the lung being compressed. Our patient was on 6 liters of oxygen. We could do thoracoscopically, and the video is not playing for some reason. If you can notice, if the video was to play, I am using a sponge stick suction like in the open instruments. Next slide. This was a multiple cases of spontaneous pneumothorax. You can see those whitish bullae. And in this patient, we have used again the conventional instruments where the video is playing. Next slide. These are all multiple cases of early empyema with lot of debris, phlegmon, septations, which can all be removed through the single port. Next slide. This again, if you can see a decortication, I'm using the regular sponge holder to remove all the collections. Next slide. Thank you very much. I would like to answer any questions if you have. That's why I kept my talk very short, please.
Hello, sir. Topic yes, sir. The practical aspects have been mentioned very easy in a manner, very easy to understand. So there is only one question that one lung anesthesia is a must. There is a question mark after
preferable,
that. Yes,
preferably, yeah. Currently, many patients we do with a regular endotracheal tube our anesthetist knows that this is a quick case, less than 1 hour or less than half an hour, we can finish and come out. In those patients, to reduce the cost, instead of a double lumen tube, he will put a regular endotracheal tube. But when I'm doing the thoracoscopy, he will do the hand ventilation with as low tidal wall volume as possible, maybe 250, 300 ml rather than 450, 500 ml, so that I get little space to see the bronchopleural fistula and apply the stapler. Or if it's a diagnostic thoracoscopy, drain the fluid, see the pleural cavity, if required, decortication. But in the beginning, preferable to have a single lung anesthesia so that you have little space to put the instruments and manipulate and then go around. Otherwise, if the lung is expanding against your camera and the instruments, you make multiple holes and tears into the lung and it starts to bleed and starts to bubble, air leaks, and you lose the entire vision and you start to panic. It's a very scary situation if that happens.
Yes, sir. In our setups where the double lumen tube in the Mofussil places or the tier 2 cities, usually we are unplanned and the double lumen tubes are not available. Sometimes our anesthetists will be using those Fogarty catheters or the balloons to block that.
That was the way in which we used to achieve single lung anesthesia in the olden days. Put your regular endotracheal tube, and then if you really want to position a Fogarty's catheter, say you put a left side thoracoscopy, you need to collapse the left lung. You put a Fogarty catheter into the left main bronchus and keep it inflated. But the problem with that is the lung is still inflated. The air that is trapped in the lung takes 10 to 15 minutes for it to go away through the endotracheal tube. With a double lumen endotracheal tube, while the anesthetist is ventilating the right lung, he will suck the left side so that the lung will collapse. Also, many of our procedures are done for empyema, aspergilloma, lung abscess, these infective pathologies, and the secretions invariably flood into the endobronchial tree. So for him to be able to suck out, the Fogarty can't be there.
Yes, sir.
So the Fogarty was the good olden days of trying to get a single lung anesthesia. Double lumen endotracheal tubes are plentifully available. If you just keep your anesthetist in the loop 1 or 2 days before you post a surgery, they are easily available. You can get access to it.
Sir, clarified very well, sir. And there is a question, any specific measure to avoid damage to azygous vein or any other vessel?
If you start with the anterior thoracoscopy with an incision in the parasternal region, you will get into the pleural cavity. There is no doubt about it. Once you are in the pleural cavity, then you decide where to put the camera, visualize the organs, visualize the adhesions, visualize the lesion that you are need to dissect. If you are doing an esophagectomy, only you need to worry about azygous vein. If you are doing an anterior thoracoscopy, if the tumor is in and around the azygous vein where you need to dissect out, then I use an endostapler and staple it. And there is enough space for you to put suture and reduce with a tie also. But preferable to use an endostapler, staple the azygous vein, and then go ahead. For the rest of the procedures like decortication or pneumothorax or mediastinal tumor excision, you don't go near to the azygous vein. You don't have to worry about that.
Sir, in the initial part of your talk, you mentioned that you'll not use carbon dioxide. Only the lung deflation of the lung itself will suffice, or?
Yes. I have limited my work to 2-3 hospitals in Bangalore where double lumen tube single lung anesthesia is pretty good. Even if there is double lumen tube placement is not correct and the lung does not collapse, like I said earlier, the anesthetist will do the hand ventilation with a low tidal volume, and I can keep the lung down with a swab anesthetic and then go to the area where I want to work. As we speak, there are surgeons who do awake thoracoscopy, in the sense patient not being intubated. One surgeon in Korea does that. All these advances came as we learned about anatomy, dissection, use of energy sources, use of staplers. Currently, with a regular endotracheal tube also, I can do my thoracoscopy work. I know where the lesion is, where I need to go. Orientation is already there. With a swab anesthetic, keep the lung down, and then I can reach there with my instruments.
You insert that swab anesthetic through the same incision, or you
Same
use a
anterior
different
utility incision. All my instruments will go through that. Wound protector is something that I don't have it in all the hospitals that I go to. So I use that utility incision for all my work. Keep the 10 mm trocar and camera 1 or 2 spaces below, so that I'm not fighting with the camera person. And we have only one tower with a monitor, like in most typical Indian hospitals. So if I hold the camera in the same utility incision, the assistant has to stand very next to me. That's practically not possible. So I use 1 or 2 spaces below, one 10 mm port for camera.
Yes, sir. And though you mentioned it, there is one more question, sir. Why carbon dioxide pressure at 6? That needs to be
Pressure of
explained
12 is a tension pneumothorax. Patient will collapse. Venous return will stop. Will go to saturation will drop. You will go to hypotension. So max that is advisable is 6 millimeters of mercury.
Yes, sir.
You have to be very conscious and make sure you readjust whenever there is a power failure.
You mentioned that very clearly earlier also, sir. Yeah. There was again a question about that. And there is one question from Dr. Lakshman, sir. Tips to reduce lung damage in tough adhesions.
You can use the regular cautery or you can use the harmonic scalpel to reduce. Sir, as you go, as you push the lung down when you are releasing the adhesions, very easily you realize these are flimsy adhesions. I can push it down with a swab and a stick, and then some adhesions where it will not reduce. That's the area where you have to use the energy device and release the adhesions. And even if there is a small tear in the lung, initially it looks like a big tear and then there will be oozing and air leaks. Just keep a swab and a stick on that area for 1 or 2 minutes and then release it and see. It would have stopped bleeding. It would have stopped leaking air. You then wait, just wait, keep quiet for 1 or 2 minutes and then you proceed. That's all.
If there are multiple air leaks, the bubbling will be obstructing your view and the clarity of the vision. So how to come around that, sir?
When we are doing decortication is essentially like peeling an orange. You need to take out the outer skin, that fibrous layer on the lung surface, preserving the lung parenchyma and the visceral pleura intact. Invariably, there will be few areas where there is a tear in the visceral pleura also. Like I said, my only action is keep a swab and a stick or a gauze piece on it for 1 or 2 minutes. Just keep quiet. Don't do any other dissection till that problem is sorted out. Most of them, the air leak will also stop. Bleeding will also stop within a minute or two. It is the panic because of that blood that you see and the air leak bubbling that you lose the vision, and then you start to react to it, and then things get complicated.
Yes, sir.
You just put a little pressure and wait for 1 or 2 minutes. Problem will be solved.
So in one of the papers for which I was going through prior to coming here, they said general surgeons should restrict to only the basic procedures like lung biopsies or empyema, and the malignancies should be left for the experts. Your take on that, sir?
You should, if you are interested in thoracic surgery, and if you are familiar with the open procedure, lobectomy or pneumonectomy, whatever the steps that need to be done for that tumor, like thymectomy, then I don't see any need for restriction. You repeat the same steps in thoracoscope. Get the patient position correct, get the instruments correct, and then get going. Since you are familiar with the open procedure, at any stage, you can always convert and complete the procedure, keeping the safety of the patient in mind. That's all.
Yes, sir. The safety is of paramount importance.
Don't draw a rigid boundary for yourself. With experience, expand your indications, expand the size of the tumor that you can do thoracoscopically, get going.
There is one last question, sir, before we wind up with this talk. So when the empyema can be drained under local anesthesia, can we put a scope and see?
I have not done one. There are pulmonologists who do what is called pleuroscopy, where the tip of the instrument is flexible enough to go around the pleural cavity. They claim they do a good job under local anesthesia. If you try and do a local anesthesia thoracoscopy, and when the patient starts to cough and the lung comes up against your instrument, you will realize how cumbersome it is. I don't suggest it, and I have not done. I don't want to do it.
Thank you, sir. I compliment you.
Can I just say one?
Yes, sir.
Yes, sir. Last question.
It was an excellent talk, Rajshekhar. I know you have been become an expert now. You can be looked upon for guidance. I think people who are trying to pick up you should conduct condensed courses where they can come and expose.
I think we can do workshops when we become offline, maybe from next year.
Correct. No. Even close group, 2 or 3 people, you can be taken up as a national skill enhancement program. One of the centers of excellence, you can be taken as person of the resource person for thoracoscopy.
Thank you.
Whatever limited procedures can be done by the general surgeons, you can teach them.
We can demonstrate.
So that's what,
teach.
But this medical thoracoscopy, I really don't know what does it mean really. I don't think that is really appropriate. And the term itself looks inappropriate for me.
It is scary. They go in, take 1 or 2 biopsies from the parietal pleura to prove the diagnosis and come out. That's what they practically do.
No,
we know what they practically
that under
do.
local anesthesia, we also have been doing fluoroscopy and biopsy under local anesthesia in sick patients. That is fine. But that to call it as a separate procedure, medical thoracoscopy, and claim that we are specialists in that is bit, I was not accepting that. Anyway.
That debate is on forever. Anyway.
Thank you.
Thank you very much, sir. We'll move on to the
Thank you.
next topic.
Pleasure. Pleasure. Thank you.
There might be some questions cropping up in the chat box.
Sure, I will
Just,
answer.
them. Thank you very much.
Thank you.
And I invite Dr. Rosario to present on antibiotic prophylaxis. Over to you, Dr. Rosario.
Thank you, Dr. Divakar. I need to thank ASI and KSC for giving me this opportunity to talk on antibiotic prophylaxis. Slide, please. Slide.
Abhishek, go to the next slide, please.
Surgical site infections account for about 30% of all hospital-acquired infections. And what most of us, all of us would want is something what we see on to your left, a clean incision, patient goes on well, unlike the one on the right side where there's the beginning of an infection. Slide. Now, prophylaxis to reduce SSI, just not giving antibiotics. It starts in the preoperative period, moves into the intraoperative period, and goes on to the postoperative period. Slide. Preoperatively, what one needs to look at is the patient has a shower, whether you can use soap or antibacterial solutions. There's no evidence to say one is better over the other. In diabetics, you need to have a good blood sugar control of less than 200 milligrams on the morning of the surgery. Hair removal, we were used once upon a time to having these patients shaved in the ward, which has been proven to be a source of infection, and therefore hair removal is to be done in the OR, preferably in the receiving area. Do not use a razor and use a trimmer. The use of surgical safety checklist has been found with improved compliance with antibiotic administration and a significantly lower surgical site infection rates. Slide. Intraoperatively, you need to have skin preparation. Prophylactic antibiotics is just one of the components here. What you use for the skin preparation, it depends on individuals, for either iodine or chlorhexidine based. You need to have a sterile atmosphere and minimize the traffic movement in the OT. And the anesthetist should be able to maintain the homeostasis of the patient with a good oxygenation and keep the patient warm. Slide. And the same homeostasis need to continue in the postoperative period, along with an antibiotic dosing. I'll talk about a little later. Slide. This is a Cochrane database review. It's a good article which covers the entire gamut of prophylaxis and how to reduce surgical site infections, the preoperative, intraoperative, postoperative modus operandi for all these things. What is prophylaxis is when a antibiotic agent is given prior to initiation of a specific surgical procedure in order to reduce the number of microbes that enter the tissue or body cavity. And these agents are selected based on the likely activity against the microbes present at the surgical site. And prophylaxis is limited to the time prior to and during the operative procedure. And the vast majority of times is usually use a single dose of antibiotics and only for certain types of procedures. Slide. Slide, please. Now, empiric antibiotics comprise the use of an antimicrobial agent or agents when the risk of surgical infection is high. For example, when you have used antibiotics for ruptured appendicitis, and when there is significant contamination during surgery has occurred during, for example, during inadequate bowel preparation or considerable spillage of colonic content during a colonic resection. Next slide, please. Empirical therapy should be limited to a short course of drugs, as already mentioned by Dr. Rajgopal Shenoy in his talk, and should be curtailed as soon as possible based on microbiological data, either absence of positive cultures or when there is clinical improvement in the patient. Slide. Empiric antibiotics, again, antibiotic treatment involves de-escalation therapy, where initial antimicrobial selection is broad, and then you need to come down on that based on the cultures and the improvement of the patient. Slide. So therefore, prophylaxis is usually up to a period of 24 hours, empiric therapies for 3 to 5 days, and therapy itself is lasts for about 5 to 10 days or sometimes even longer. Slide. Now, surgical site infections are infections that occur in the tissues, organs, or spaces exposed by the surgeons during performance of an invasive procedure. Slide. The development of surgical site infections is related to 3 main factors: the degree of microbial contamination of the wound during surgery, the duration of the procedure, and host factors such as diabetes, malnutrition, obesity, immunosuppression, and varying other underlying disease states. Slide. This chart gives you the various risk factors for development of surgical site infections. The patient factors: smoking, immunosuppression, older age, diabetes. Local factors: a prolonged procedure, local tissue necrosis, hypoxia, and hypothermia. And in microbial factors, the patients who are longer in the hospital before surgery are more prone to develop surgical site infections. Slide, please. The classification of wounds, just a brief recapitulate. Class 1 wounds include those in which there is no infection, only skin microflora potentially contaminate the wound. There is no hollow viscous that contains microbes is entered. Class 1D wounds are similar to class 1, except that a prosthetic device, for example, a mesh, is inserted. Clean contaminated wounds are those in which there is a controlled entry into a hollow viscous. Slide. Contaminated wound, class 3 wounds are those, the open accidental wounds, wounds encountered early after surgery, those with extensive introduction of bacteria into a normally sterile area of the body. And when there's a major breaks in sterile technique, for example, when patient has to undergo an open cardiac massage and it's cross spillage of contents, viscous contents such as from the intestine. Dirty wounds, class 4 wounds are traumatic wounds in which there is significant delay in the treatment. There is those created in the presence of overt infection when there's obvious purulent material, and created to access a perforated viscous accompanied by high degree of contamination, for example, diverticular perforation. Slide, please. So this slide gives you the various percentages of infections, expected infections. In clean or class 1 wounds, it's about 1 to 2%, and the highest is in the dirty or class 4 wounds. Slide. Now, prophylactic antibiotics, what should be the main characteristics? They should prevent SSIs and improve the patient's outcomes, reducing the duration and related cost of healthcare. They should reduce adverse effects such as acute kidney injury or risk of difficile infection, Clostridium difficile infection, reducing consequences of the patient's microbial flora, and reducing the emergence of antibiotic resistance. Slide. They should have active against the bacteria that most likely contaminate the surgical site, and therefore we need a local antibiogram. Each institution should be administered at an appropriate dosage and at the correct time. Sorry. In order to administered in an appropriate dosage at a correct time in order to obtain appropriate tissue concentrations during the period of potential contamination during the surgical intervention. They should be safe and they should minimize the adverse effects and to maximize its efficacy. Slide. So what are the principles of appropriate antibiotic prophylaxis? Prophylactic antibiotics should be administered for all those operative procedures which have a high risk of postoperative surgical site infections, or when prosthetic materials are implanted, for example, hernioplasty, or an orthopedic procedure where they do implants. For elective surgical interventions, prophylactic antibiotics is recommended in selected cases of clean surgery and in all cases of clean contaminated surgery. Slide. So when to use prophylactic antibiotics? Slide. In class 1D, that is when you use in clean cases where you use a prosthesis, and class 2. We're not going to address class 3 and class 4 because there you definitely need antibiotics. Which antibiotic to use? Slide. Now that's a very busy slide. It depends. These are the recommendations, but however, the local antibiogram, the local antibiotic sensitivity pattern for each hospital varies, but these are some of the recommendations. Slide. When should prophylactic antibiotics be given? It's given usually 1 hour or less before incision. However, in some patients who are allergic to, let's say, cephalosporins, and they need to go on vancomycin, or patients with who are an MRSA positive, these have to run over a period of time. So vancomycin fluoroquinolones can be run about 2 hours before the incision. Slide. When should the dose be repeated? It's usually done about based on the antibiotic half-life, or if there's extensive blood loss during surgery. Redosing in the operating room is recommended at an interval of approximately 2 times the half-life of the agent in patients with normal renal function. So, for example, cephalosporins have a half-life of 2 hours. So you repeat the dose if necessary after 4 hours if the surgery is prolonged. And however, for unusually long procedures, redosing may be needed. When to convert to empiric therapy? Slide. That is a decision, prudent decision, which has to be taken by the surgeon. For example, you start, let's say we start prophylactic antibiotics for acute appendicitis, and then the patient has perforated appendix. You need to, the surgeon needs to take a call whether you need to continue, convert it into therapy or empiric antibiotic. Slide. Should antibiotics be continued when drains are used? Slide. Answer is definite no. There is no proven benefit of continuing antibiotics when somebody uses drains. So this is the antibiotic protocol that we follow at St. John's. Slide. Keep moving forward, please, till I tell you. Slide. Slide again. Okay. So these recommendations have been taken from the clinical practice guidelines for antimicrobial prophylaxis and surgery. Very similar to what is given in the IDSA and the CDC. Slide. Thoracic procedures, single dose of cefazolin or ampicillin sulbactam combination. Or if the patient is allergic to that, you can give clindamycin or vancomycin. Slide. Gastroduodenal procedures, single dose of cefazolin is recommended in procedures where the luminal intestine tract is entered. Higher doses are recommended in morbidly obese patients undergoing bariatric surgery procedures, and higher doses of antimicrobials should be considered in significantly overweight patients undergoing gastroduodenal and endoscopic procedures. Slide. Biliary tract procedures, again, cefazolin should be administered in patients undergoing an open biliary tract procedures. The recommendation in that article is no antibiotic prophylaxis necessary in low-risk patients undergoing elective laparoscopic surgery, elective laparoscopic cholecystectomy. However, antibiotic prophylaxis is recommended in patients undergoing laparoscopic cholecystectomy with an increased risk of infectious complications. And for example, let's say there is spillage, or the gallbladder gets opened up, and there is spillage, and therefore you need to continue the antibiotics. And because some of these risk factors cannot be determined before the surgical intervention, it may be reasonable to give a single dose of antibiotic preoperative, intraoperative. Slide. Appendicectomy, for uncomplicated appendicitis, the recommended regime is a single dose of cephalosporin with anaerobic activity. Unfortunately, I don't think we have these kind of antibiotics recommended, or you can give a single dose of cephalosporin along with metronidazole. Slide. Small bowel procedures, for small bowel surgery without obstruction, the recommendation is to give a first generation cephalosporin. And for small bowel surgery with intestinal obstruction, the recommendation is to give cephalosporin with anaerobic activity, or if that's not available, a combination of first generation cephalosporin plus anaerobic or metronidazole. Slide. Hernia repair and procedures, herniaplasty, herniorrhaphy. Recommendation in that article is give a single dose of first generation cephalosporin. Slide. Colorectal procedure. That's interesting because what they recommend is a single dose of second generation cephalosporin with both aerobic and anaerobic activity. That is available. If not, cefazolin plus metronidazole is recommended for colonic procedures. However, they've recommended an MBP, that is a mechanical bowel preparation, along with the oral neomycin sulfate or erythromycin, plus oral metronidazole should be given in addition to IV prophylaxis. And this should be given as 3 doses approximately 10 hours before the surgery, in the afternoon, evening, before the operation, and after the MBP. There's no point in giving these oral antibiotics and then giving MBP, which all get washed out. Slide. Head and neck procedures is not, antibiotic prophylaxis is not required in patients undergoing clean surgical procedures of the head and neck. Slide. Vascular procedure, the recommended regime for patients undergoing vascular procedures with a high risk of infection, including implantation of prosthetic material, is cefazolin. Thank you.
Thank you, Dr. Rosario, for that wonderful and simple, lucid presentation on antibiotic prophylaxis, which needs to be used. There is one question from Dr. Lakshman. Can antibiotics used for treatment? Just a second, I missed that.
Antibiotics used for treatment, can they also be used for prophylaxis? Or would you reserve the antibiotics, one group for prophylaxis and another for treatment?
Can you be okay? Give me an example, Lakshman. For example, what?
If you're using, say, a meropenem for treatment in your hospital, would you at some stage consider using it as a prophylaxis?
No.
No, that's a point.
No.
Yeah. To put a more common example, if you use something like augmentin, would you use that for prophylaxis if you're using it for treatment?
Yes, if the patient is allergic to, some of the recommendations is to use augmentin, that is ampicillin sulbactam combination, as prophylaxis, if the patient is allergic to cephalosporins. There's one more question I saw from you, Lakshman.
Yeah,
What is that?
I did. Yeah, I was waiting for Diwakar to.
Yes, sir. I'm taking over.
Yeah.
Would you recommend empiric therapy if the personal hygiene of the patient is poor, in view of the fact that external contamination is unlikely after 12 hours of surgery?
If I may explain this, many people justify a 3 or 5 day routine, mind you, routine antibiotic cover for patients on the basis that their personal hygiene is not very good. But we also know that your surgical wound is impervious to bacteria 12 hours because of a good fibrin seal. So is there justification for using prolonged periods of antibiotic beyond 24 hours on the basis of the personal hygiene not being good?
I don't think there is any such recommendation, Lakshman, because personal hygiene again depends on what you consider personal hygiene. There are some people who bathe 3 times a day. Some people bathe once in 3 days. So I don't think there is a recommendation as to convert prophylaxis to empiric therapy or therapy at that treatment based on personal hygiene. No.
Yeah.
As you rightly said, there is a seal that is formed within a few hours after surgery. Shivram has something. Any
I
antibiotics?
have a question. Am I audible?
Kalaivani, please go ahead.
Yeah. So this is regarding antibiotic prophylaxis. Will you continue if there is a drain being placed?
Sorry, Kalaivani, I'm not able to.
If a drain is being placed.
No, I've already answered that question.
Yes.
I'm sorry, sir. I'm sorry.
Okay,
That,
there is
no.
Yes, sir. Choice of antibiotic, does it vary according to the geographical antibiotic policy?
Yes. Whatever has been recommended, like by the IDSA or the CDC, is just a recommendation, but you have to use what is there locally available, and your local microbiologist should be able to give you an antibiogram. Based on that, we at St. John's have written up a policy of antibiotic prophylactic antibiotics.
Yes, every hospital should have antibiotic stewardship and its own antibiotic policy. So
Shivram has something there. Any what is it, Shivram? Any antibiotics
is recommended for anal procedures like hemorrhoids.
Oh yes, yes.
Yes, sir. And
Do
Do you give antibiotic for hemorrhoids, fissure, all these procedures?
Hemorrhoids, definitely. Fissure may not be.
No, regarding personal hygiene, there was a question. If the personal hygiene is poor, I think we should postpone any elective surgery and should not, that may create infection. I think we should postpone. Do you agree with that?
I guess it will help, but question is how long will that person, what do you mean by personal hygiene is not good? I can't understand that.
Maybe from patients from villages and all, that's what maybe I thought.
Yeah. Yeah, that in that case, it starts preoperatively. I think that the NAS has the same question. In patients with poor hygiene, will a chlorhexidine wash prior to surgery help prevent desiccation? Yes. So you need to make sure that these guys have a shower, at least, with a couple of showers, if not just one before the surgery. With soap, it doesn't make a difference whether you use chlorhexidine. There are papers that say I just using ordinary soap and chlorhexidine, there's no difference between the two.
I have a question, sir.
Chip in with this hygiene part of it. Prakash?
Yeah, who's this?
Dr. Siddesh here.
Yeah, Siddesh.
Yeah, see, I always refer in my talk on the surgical site infection with the paper which we have conducted, a study we're using our interns in our institute long back. How many of our patients have had a bath 24 hours before surgery? It is a very, you believe it or not, more than 60 to 70% of our patient had not had a bath within. So we just consequent to this study, corollary to this study, we did a control study of giving a chlorhexidine, telling that it is a potion, just not the branded, just we made a diluted solution and gave them. We did a control study. We found significant difference if they have a bath on the day of surgery in the morning with a careful, with a chlorhexidine bath. It does make a difference in surgical site infection outcome. So
It is mandatory in our hospital that the patient bathes the morning of surgery. They are given chlorhexidine and they bathe with it the morning before surgery, and some even the evening before surgery.
Yes, sir. Are there any special precautions in patients who are splenectomized?
Any? Yeah, we need to give them the pneumovac and the influenza vaccine, and we use post-splenectomy or post-splenectomy.
Post-splenectomy, patients with post-splenectomy status.
Not sure I can answer that question. Sorry, I thought it was post-splenectomy.
Yeah, as you said, if somebody has an experience, would you stop the recommended antibiotic prophylactic dose at the recommended period, or you continue for a longer period in these patients with splenectomy?
I can't answer that question. I'm sorry.
If any senior has, let them please type it in the chat.
As far as I am concerned, it's splenectomy. Surgical site infection, it should not be different from any other thing. See, post-splenectomy scenario, infections associated due to splenectomy, immunosuppression will not occur on the surgical site. It is a systemic infection. So I think as far as the wound is concerned, prophylaxis for surgical site infection should not be different from rest of the.
Probably will agree with you on that, Siddesh.
Thanks, sir. And still the point on hemorrhoid is not clarified, sir. Which antibiotic would you prefer, or do you recommend any particular antibiotic for that?
We use quinolones with metronidazole.
Fine, sir. So there is a question: how often do you revise the antibiotic policy?
I think ours was revised after 3 years, recently as last year. So I don't know what the recommendation is. I need to check with the microbiologist, but I think ours was revised last year after 3 years.
Fine, sir. I think, are there any special consideration like patient factors, the obesity, renal impairment in selection of antibiotic for prophylaxis?
Yes. Renal functions, if the renal functions are poor, it has to be dose adjusted according to creatinine. Obesity, you go by ideally antibiotics are given more on based on body weight.
Can I say something, if
Yes,
time
sir.
permits?
Yeah, there is still time, sir. There
I
is
think, right,
5
as
minutes more.
rightly told by Dr. Anthony Rosario, that most of us say that we are using the so-called the prophylactic antibiotic and continuing. It's only this is the most important purpose of these conferences and sensitization again. So audit, internal audit, then NABH accreditations, antibiotic policy, and all these things, hospital acquired infections, and regular prophylactic antibiotics used in your hospital. All this should be a part and parcel, very important program.
Is that Ravi?
Local hygiene probably will not, that as it been pointed out. In fact, the antibiotic shower and all those things have been mentioned. So
I would say some of our senior people would realize there was a time about 20 years ago, each one would choose antibiotics, would change every day, depending on what the mood is on that day, and which company has spoken to the previous day. So all that is gone now. You know, today we have to stick to what is laid down.
Yes, sir. There is one more question, sir. Is gentamicin local instillation justified in ventral hernia repair after placement of mesh? For that matter, some people are still using the local instillation before the skin closure. They instill some antibiotic solution into the wound. Is that justified?
No. The only recommendation for local antibiotics comes in orthopedic surgery, where they use gentamicin beads and soak the implants in the antibiotic solution. Also, the local antibiotics, ophthalmologists, they use a lot of that. So these are the two specialties that use local antibiotics.
So mesh is also an implant. So a lot of people immerse the mesh.
Yeah, agreed, Shivram. There are some papers which say that immersing the mesh into antibiotic solution reduces it. But if you look at the Cochrane review on this, there is no statistical difference between the two, whether you immerse or you don't immerse.
Yes, sir. Thank you very much, Dr. Anthony Rosario, for that lucid presentation. I compliment you on that, and thank you very much.
Good
And
talk.
I thank KCSI and the scientific committee for allowing me to chair this session. If there are no more questions, I'll hand it back to the screen manager. Thank you. Thank you very much.
Thank you, Dr. Rosario, sir, for that informative session. I extend my gratitude to Dr. Gati Divakar, sir, and Dr. Amrish Biradar, sir, for taking time out to chair this session. I thank the speakers for their enlightening talks. We learned a lot from the talks, sir. We now move on to the inauguration of the 40th Kscasicon 2022. I welcome Dr. Arvind Patel, sir, Chairman KSCASI, to chair this session. I welcome our chief guest for the evening, Dr. Ramesh VK, sir, Vice Chancellor, RGUHS, Bangalore. I also extend a warm welcome to our guest of honor, Dr. G. Siddesh, sir, President, ASI. I also welcome Dr. B.N. Patel, sir, Chairman-elect KSCASI, Dr. Sanjay Kumar Jain, Vice President, ASI, Dr. Pratap Sinha, sir, Secretary, ASI, Dr. Santosh John Abraham, sir, Director, Academic Council, ASI. I also welcome Dr. Chandrasekhar S, sir, Secretary, KSASI, and Dr. Chandrasekhar N, sir, Treasurer, KSASI. I now request Dr. Kirti to present the invocation song.
ಹರಸಲಿ ದೇವರ ದೇವ ಬುದ್ಧಿಯು ಹರಿಯಲಿ ನಿನ್ನಯ ಚರಣಕ್ಕೆ ಸೇವೆಯು ಸಲ್ಲಲಿ ಪಲ್ಲಿ ಶಾಂತಿಯು ಅರಸಲಿ ನಿತ್ಯವೂ ಸತ್ಯವ ಪ್ರಜ್ಞೆಯುತವು ಚಿನ್ನುತ್ತ ಹರಿಯಲಿ ಶಾಂತಿಯು ಅರಸಲಿ सत्यवो सत्यवा प्रणिनौदकवो चित्तहरिय चित्तदरे भूमि यदिगनि विद्येय मन्दिरविदनु हरसरि देवर देवा विद्येय मन्दिरविदनु हरसरि देवर देवा हरसरि देवर देवा हरसरि देवर देवा. Thank you.
Thank you, Dr. Kirti, for that melodious song. I request Dr. Chandrasekhar S. Sir, Secretary KSASI, to now welcome all the delegates.
Good evening, sir. Good evening, respected chairperson, chief guest, guest of honor, all the dignitaries on the dais or off the dais, and delegates. On behalf of organizing committee of Kscasicon 2022, I take the opportunity to welcome you all for 40th annual conference of our association, that is Kscasicon 2022, with the theme Surging Towards Surgical Competence. On behalf of KSASI, I welcome Dr. Arvind Patel, Chairman of KSASI, to preside over today's inaugural function. Sir, I welcome you, sir. I would like to extend a warm welcome to today's chief guest, Dr. M.K. Ramesh, the Vice Chancellor of RGHS Bangalore. It's an honor for the entire surgical fraternity to have our own member occupying this prestigious post, and he has taken a charge today as a Vice Chancellor of RGHS. I also take an opportunity to welcome another eminent personality as a guest of honor, Dr. G. Siddesh, the President of ASI. It's a matter of pride for us to see our state member at this highest post. Sir, I welcome you, sir. I also welcome our guests for the evening, Dr. B.N. Patil, Chairman-elect KCASI, Dr. Sanjay Kumar Jain, the Vice President of ASI, Honorary Secretary of ASI, Dr. Pratap Sinha Orte, and Director of Academic Council, ASI, Dr. Santosh Jan Abraham, and also I welcome Banulal Yadav, Treasurer of ASI. A warm welcome to Treasurer of KCASI, Dr. Chandrasekhar. I also welcome all the national and state EC members of ASI, orators, conveners, speakers, judges, and chairperson, and all delegates and postgraduates of this evening. Thank you, sir.
We now have the inauguration of the 40th Annual State Conference 2022 by our chief guest, Dr. M.K. Ramesh, sir. I request our chief guest, Dr. M.K. Ramesh, sir, to give an inaugural address.
Thank you. Dr. Arvind Patel, Chairman, KCASI, Dr. Siddesh, President, ASI, other guests, and other office bearers of the association, and all my surgical colleagues who have assembled here. Just today itself, I've taken charge, and I feel honored to address this function today as my first official inaugural function. We are proud to be surgeons who cater to various needs of patients with available infrastructure. We have a humongous task of delivering clinical services to the satisfaction of patients. The specialty of surgery has tremendously improved over the decades. Earlier, there were very few super specialty subjects. Most of the surgical procedures of the super specialty were done by general surgeons only. Where focused attention is being given for certain of the segments of general surgical procedures. To give a few examples, now we have bariatric surgery, advanced minimally invasive and robotic surgeries, which are being carried out by general surgeons using state-of-the-art technologies. This was possible because of the training that these surgeons themselves got through sheer interest in these fields. It is well known that a medical graduate is a lifelong learner. The science is expanding so rapidly that the knowledge available today may become irrelevant tomorrow. With explosive growth in technology and introduction of newer gadgets, many of the surgical procedures, which were very difficult to perform earlier, are being tackled with relative ease. With better understanding of the pathophysiological process and better availability of monitoring modalities, it is becoming possible to give better results following surgical procedures. The point to be noted here is that though technology and gadgets are available, unless one learns to make use of these gadgets, he may not attain success. In this regard, there is a necessity for constant upgradation of skills so that we maintain our relevance in day-to-day practice. There is a necessity for all of us to attend workshops, seminars, conferences, so that knowledge upgradation is possible and ultimate benefit passes on to the patient. One of the most neglected fields by the surgeons is the research. I know that surgeons' hands are tied with ample clinical work and they have minimal time to think in terms of research. But I believe that where there is a mind, there is a way. We have plenty of clinical material. If documentation of the clinical data is appropriately done, many fascinating and interesting conclusions can be drawn which have a potential to change the way we practice in clinical scenario. If you can concentrate on research with whatever little time that's possible, I'm sure that we can contribute significantly for the growth of the specialty. So all over the world, surgeons from India are known for their dexterity. Many complicated surgical procedures are being carried out by our colleagues with great success, underlining their capabilities because of very good clinical skills. All of us may not be bestowed with that ability. However, we can achieve to become better surgeons through constant honing of clinical skills. In this regard, simulators provide an ideal opportunity to improve our skills. I feel introduction of simulators has greatly helped postgraduates as well as junior staff to improve their clinical skills. Hand-eye coordination and attention are important in minimally invasive surgeries, and this component of clinical skill can be achieved quite successfully using simulators. My surgical colleagues working in medical colleges have an additional responsibility of training the young postgraduate students who join the specialty of surgery. With the introduction of competency-based medical education, the way we teach the postgraduates is going to change greatly. Earlier in our days, more importance was given for knowledge acquisition. However, with the advent of information technology, the knowledge acquisition is no longer important, as any information can be obtained by using various search engines. More important is knowledge application. This concept of change from knowledge acquisition to knowledge application has led to the concept of competency-based medical education. The teaching methodology that needs to be adopted for implementation of CBMA is more student-centric compared to the traditional teaching. I'm happy to share that National Medical Commission is coming out with guidelines for implementing CBME in specialty of surgery. And before I conclude my talk, I would like to remember the famous quotation by Dr. APJ Abdul Kalam. Accept your past without regret, handle your present with confidence, and face your future without fear, which I find is very, very relevant to our specialty. I thank the organizers for giving me an opportunity to share few of my thoughts on this platform. I wish all my surgical colleagues the best of health, wealth, and prosperity. Thank you.
Thank you very much, sir, for your words of wisdom. I now request Dr. Chandrasekhar S., Secretary KSISI, to introduce the orators for Kscasicon 2022.
Thank you. It gives me a immense pleasure to introduce orators for 2022. First one, Dr. H.S. Bhatt oration will be delivered by Dr. Vidyadhar Kinal. Dr. Vidyadhar Kinal, born in 1958 in Dharwad, he did schooling in Ballari, MBBS from Karnataka University, MS General Surgery from Gulbarga University. He started his career as a PSC medical officer, then he took a change to medical education. He is a former professor and HOD of Department of Surgery, Superintendent and Principal of WIMS Ballari. He is a former senior consultant and DNB teacher at District Hospital, Bijapur. He is a former chairman of Kscasicon for the year 2019-20. He is currently a professor of surgery, Basaveshwara Medical College, Chitradurga. He has presented many papers and has many publications to his credit. He served as a joint secretary of IMA and joint secretary of Lions Club of Bellary. He was an executive committee member of Kscasicon in 2008. Under his presidentship, the IMA Bellary won the National Award for Best IMA Branch in the year 2012. He was the chairman of Malpractice Inquiry Committee of RGHS, Bangalore, from 2018 to 2021. He served as an office bearer in so many organizations like Old Student Association of Ballari Medical College, Teacher Association, and WIMS Development Committee. Sir, here presented Vidyadhar Kinal.
Sir, I'm very much there online. I'm really honored that he has read so much about me. I'm really happy to be a part of ASI KSC this year, one of the best organized conferences I'm attending. I'm extremely overwhelmed with joy that the introduction done by Dr. Chandrasekhar. Most of it, I personally feel that he has enlisted and taken it from his this thing. I'm extremely happy about this. Delivering my lecture evening 4:30 to 5. I request all of you to kindly log in and help me to improve my methodology of presentation. Thank you very much, sir.
Thank you, sir. Thank you very much, sir. Now we'll go to second orator, that is Dr. A.J. Narendran oration will be delivered by Dr. K. Lakshman. Dr. Lakshman did MBBS from Bangalore Medical College, LRCP and MRCS from London, FRCS Edinburgh and FRCS England, fellowship in surgical metabolism and nutrition. He was trained in UK and USA. He is a consultant GI and laparoscopic surgeon practicing in Bangalore since 1986. He is a former faculty surgical gastroenterology, RGHS. He is a former associate editor, Indian Journal of Surgery. He has set up the Digital Library and Clinical Skills Center at BMC. He is the chairman of BMCDT, Infosys Bone Marrow Registry. He has published several papers and written chapters for books. He is the examiner for DNB and the Royal College of Surgeons exams. He practices general surgery with interest in GI surgery, including GI oncological surgery. He works includes both upper and lower GI endoscopy and laparoscopic surgery. He has an interest in computer as applicable to medicine, ethics in medicine, consumer affairs, surgical audit, HIV and its surgical implication, and surgical metabolism and nutrition. Sir, Dr. Lakshman.
Thank you very much, Dr. Chandrasekhar, for your kind words. It's indeed an honor and a privilege, and I'll be looking forward to this oration tomorrow evening. Thank you very much again, Kscasicon.
Thank you, sir. Now we'll go to next orator. That is MP Pai, Professor MP Pai oration will be delivered by Dr. Gabriel Sunil Kumar Rodriguez. Sir, Gabriel is professor of and HOD of General Surgery and Chief of Surgical Unit at KMC, Manipal. He is a teacher for undergraduate and postgraduate, both MBBS and BDS courses since 23 years. He is an examiner for various universities and for FRCS, MRCS, and European Board of Surgery. He is actively involved in research, publications, and attending conferences. He has been awarded an international scholarship to UK, a fellow of Royal College of Physicians and Surgeons, FRCS Glasgow, and a fellow of European Board of Surgery, General Surgery. He is the life member of various national and international associations and organizations. He is a referee and reviewer of international and national medical journals. He is a member of Indian Medical Association and executive member of Udupi Manipal branch in 2008 and 9. He is a member of Board of Studies of General Surgery in SDM University Dharwad and Goa University. External editor for Borneo Journal of Medical Science, Malaysia from 2020 to 2021. Thank you, sir. Sir.
Dr. Chandrasekhar, good evening and good evening, everybody. Thank you very much for that profuse introduction of mine. And I'm actually honored to have been given this chance to present the MP5 oration. And thank you, Kscisi. Thank you very much and good evening.
Thank you, sir. Now, we'll go to next orator. That is Dr. S.S. Narasangi oration will be delivered by Dr. Naz Jahan Sheikh. She did her MS General Surgery from Ballari with the work experience at Sion Hospital, Mumbai. She has presented a paper in various state and national conferences. She has an interest to serve the lesser privileged and undertook a lab sterilization program and visited various places with the credit of performing more than 25,000 surgeries and a record of 200 in one day. She is actively involved in the state IMA Save Child campaign. She is consultant general and laparoscopic surgeon at City Hospital, Hospet in Ballari district. She was vice president of IMA case Karnataka State Branch in 2012. She is district coordinator for IMA Vijayanagar and EC member of Karnataka State Chapter of ASI. She was editor of newsletter Shastra for 2 years. With the poetry as a hobby, she writes poetry on medical topics published in various magazines. Thank you, madam. And she's going to deliver tomorrow.
Good evening, everyone. Thank you, Dr. Chandrasekhar, for those kind words. And I feel honored and privileged to be delivering Professor S.S. Narasangi oration. And I look forward to it to be delivering it day after tomorrow evening. Thank you, one and all. And thank you, KSC, for this wonderful opportunity.
Thank you, madam.
Thank you, sir. I now request our chairman, Dr. Arvind Patel, sir, to honor the senior surgeons.
Next.
Chandrasekhar?
Yes, sir.
You have the biodata of our senior surgeons to be felicitated. Dr.
Yes,
Lakshman, Dr. Shivkumarappa, and Dr. S.M. Patil.
Yes, sir.
Please go ahead.
Sir, now I'll start with Dr. S.M. Patil, sir. So S.M. Patil is a gold medalist in MS General Surgery in 1984 in Gulbarga University. He has served as a faculty for 31 years in MR Medical College, Gulbarga. He is a postgraduate teacher for more than 25 years, has guided, supervised, monitored many postgraduates and junior surgeons in research and publication. He has involved and organized and monitored health checkup camps and CMEs and workshops. He is the Dean of MR Medical College, Gulbarga. He has served as a HOD, Department of General Surgery, MRMC, Gulbarga. He is a life member of Association of Breast Surgeons of India and a life member of Indian Medical Association. He is the founder secretary of Surgical Society of Gulbarga in 1987. Here is S.M. Patil, sir.
Good evening. My personal greetings to all. It is my privilege to accept the honor from KSCASI. With all humbleness, I accept this award, I accept this honor. I thank everyone who is responsible in identifying me for this honor. And I am grateful to KSCASI and my best wishes to all. Let us all hope our COVID-19 era will be over and our pre-COVID time will be with us in future. Thank you very much once again and best wishes to all.
Thank you, sir. Now we'll go to next senior surgeon, that is Shivkumarappa. Our treasurer, Dr. Chandrasekharan, will read the biodata of Shivkumarappa.
Good evening, everyone. It's my privilege and I'm really proud to introduce Dr. Shivkumarappa GM, my teacher, to the August gathering. Dr. Shivkumarappa GM, born 11th May 1952. He did his MS and MBBS and MS from JJM Davangere. He served in this Department of General Surgery for more than 36 years. From 1985 to 1990, he was in JJM Davangere. From 1990 to till date, he is working in Department of General Surgery in Tumkur, that is Siddhartha Medical College, Tumkur. He was the former HOD of the Department of General Surgery in Siddhartha Medical College for more than 12 years. And he has guided many postgraduates and undergraduates. And he served as a registrar evaluation in Sahi University for more than 10 years. He was the former president of IMA. He was chairman of organizing chairman for Kscacon in 2006, which was held in Tumkur. He was the past president of ASI Tumkur City chapter, and he has received Best Doctor Award from Rotary Tumkur, IMA Tumkur, and ASI Tumkur City chapter. And here is Dr. Shivkumarappa presenting you the August gathering. Thank you.
Sir, please speak,
Hello.
sir. Yeah, you are audible. Speak, sir.
Okay, thank you, Chandrasekhar, for the introduction. I thank KSCASI for the honor which is bestowing on us. I'm very proud and happy to receive this with all my proud this thing. I'm very happy that I want to thank RDS once again for selecting us and thinking competitive for this. Thank you very much. Thank you, sir.
Now we'll go to next senior surgeon, that is Dr. K. Lakshman, sir.
We have Chandru, we have just had this, so can we skip the intro? You did this when
Yes,
the orators were introduced.
As you like it, sir.
Yeah, please. I mean, they've heard the same thing. Thank you very much. I would like
one more thing, sir.
Only
Sir,
thing we just wanted to tell your
tell that
contribution to the
contribution
to the ASI state and also national as far as academic subjects are concerned.
I join with all of you to thank Dr. Lakshman having taken up, and he has taken up additional responsibility at this time to carry on the research activity, propagating the knowledge, and how to write papers at the national level. He is going to conduct a workshop. Thank you all that, and you fully deserve this honor.
Thank you. Thank you very much. I'm deeply touched and honored by this gesture of KCASI. My sincere thanks to the chairman and the EC of KCASI for bestowing this honor on me. I sincerely hope that I'll be able to continue to contribute to the academic activities of this August association. Thank you again, KCASI.
Thank you very much, sir. Thank you.
Thank you, sir. I humbly request Dr. Siddesh J. Sir, President ASI, to address the gathering.
Good evening, everybody. Dignitaries on the dais, senior surgeons, orators, executive committee, members of the National ASI, and senior surgeons who are sitting here, and my dear colleagues and friends. It is indeed my proud privilege, belonging to the state of Karnataka, to be occupying this chair of the President of Association Surgeons of India. I take this opportunity again to thank the membership at large of my mother state who have supported me, stood with me, and felt that I am deservingly a candidate to be supported to become the President of Association Surgeons of India. I take this opportunity also to congratulate my dear friend and chairman of the Karnataka State Chapter, Dr. Arvind Patel, and ably supported by his team, Dr. Chandrasekhar, the secretary, and treasurer again, Dr. Chandrasekhar, and the champion of academics, Dr. Lakshman, who has so meticulously drafted and helped in conducting such a wonderfully designed conference. At the outset, let me take this opportunity to congratulate my dear friend who has been a senior to me at Mysore Medical College, none other than Dr. M.K. Ramesh. We all should feel proud to have him taken the charge as the Vice Chancellor of the prestigious Rajiv Gandhi Health University at our state. Congratulations, sir. You have been a simpleton but a very silent but hard worker. You have shown how a surgeon can remain silent yet achieve big laurels by simple hard work. I really hope that you will take the university to a new academic height and make it as one of the best health universities in the country. My only humble submission, sir, is to make, when we approach you with an official request, to include in the curriculum and recommend it strongly to the NMC, endoscopy as a part of the curriculum in MS surgery curriculum, sir. So we will be coming up with this suggestion, and we want you to take up this to the NMC and get it approved at the appropriate time. Karnataka State Chapter has been one of the esteemed chapters of the association at the national level. It is not just by the numbers we make this chapter big, but by the presence of such esteemed colleagues who have been eager to contribute in academics. To name a few, we have amidst us Dr. Lakshman, Dr. Rajan sir, we have Rajgopal, and we have many more who have been constantly active at the national level in the RRC as well as National Skin Enhancement Program. I would not hesitate to mention Dr. Gurshantappa and Dr. Ishwar Masmani to be added to this list. Dr. Sopimat has been contributing immensely as an office bearer of the Social Security scheme, and he has been instrumental in taking this scheme to newer heights. And every time Karnataka has been having the maximum number of new members year and year again. This just shows the amount of involvement of our senior leaders. Dr. Gadi Divakar has been the recently completed his term as a secretary. He has shown how meticulously things can be planned and executed. And he has also been rewarded to become the executive committee member this year. So that shows the vibrant state of Karnataka for the office bearers of the association who are present here. Sir, you can expect still to come much more contribution from the Association Surgeons of India. I would say this to our incoming president, going to be taking over from me, Dr. Sanjay Jain, our Director of Academics, Dr. Santosh Jan Abraham, Pratap Orite, who has been a very young and dynamic secretary. I can say is one of the youngest secretaries what Association Surgeons of India have got. And we have full faith in him that he's going to be very active. And when our association going through certain changes in the formulation of new renewal of headquarters and many other issues, is going to be very instrumental in bringing up these changes. At the same time, I would have a word to the incoming chairman, Dr. B.N. Patil. Sir, you have been a social leader. You have a capacity to conduct many social activities, social service activities, I mean. Sir, in your tenure, I would request you to take up and to work for the fullest capacity of your charm. And you are a good leader. And I can just remember the vocabulary and poetic language fluent in Kannada. You can use that language to captivate your members, to motivate them to contribute in social service activities and make a meticulous record of it, sir. And we have amidst us our past chairman, Dr. Dayanand Nuli, who has been nominated because of his credentials as one of the members of the National Social Service Council. I'm sure you can take a guidance from him. Both of you together can do a lot of social service activities for this state in this particular year. And by this, I would also urge you, along with Chandrasekhar, as secretary, two Chandrasekhars, I would say, take it up as a challenge to win laurels to Karnataka State Chapter as the best chapter this year. And that would be the befitting gift to me as the president. I would take up this opportunity again to address all the members who are present here to make note of the already started National Skill Enhancement Program, which is happening under the able leadership of Dr. Santosh Jan Abraham, which has become a hit from the first day. And already we have finished with the 2 weeks. Every Wednesday, stay tuned to 9 to 11 o'clock in the evening to get the best benefit out of it, and try to canvass amongst all your membership colleagues to get this. RRC is going to come up next. I'm sure this year going to be as interesting as possible. At this juncture, I would go ahead to request all the heads of the department and faculty at the medical colleges to encourage your students, all of them, to take up the quiz when it comes as the initial screening program for RRC. I'm sure Santosh will add a word on this. Again, I take this opportunity to thank the organizers for giving me this opportunity and feel privileged to be amongst you, and greet you all the well with your family. Have a safe year ahead. Thank you very much.
Thank you, sir, for your kind words. I now request Dr. Sanjay Jain, sir, Vice President ASI, to address the gathering.
Thank you very much. Dr. Arvind Patel, the Chairman of the Karnataka State Chapter, Dr. M.K. Ramesh, the Chief Guest, Dr. Siddesh, the Guest of Honor, Dr. B.N. Patil, the incoming President, Dr. Santosh Jan Abraham, and all the dignitaries on the dais, off the dais. I would like to congratulate the Karnataka State Chapter for all the good work which they have done, all the laurels which they have got. And today, the Karnataka is not only leading the state, but leading the national ASI in the form of Dr. G. Siddesh. And we are expecting many things to come in the coming time. I I hope this conference will be a step ahead what has been and what we have witnessed in past. I congratulate all the orators and the senior surgeons. I pay my regards to senior surgeons who have been felicitated today. And I thank everybody for inviting me and giving me opportunity to just interact with you. Thank you very much.
Thank you, sir. I would like to request Dr. Pratap Sinha, sir, Secretary ASI, to say a few words.
Good evening, everyone. Chief guest of today's inaugural function, Dr. M.K. Ramesh, sir, Vice Chancellor, Rajiv Gandhi Health University. On behalf of the headquarters of the Association of Surgeons of India, I bring greetings and well wishes towards the success of Kscasicon 2022 under the able leadership of Chairman Dr. Arvind Patel, Chairman-elect Dr. B.N. Patil, Honorary Secretary Dr. Chandrasekhar S., Honorary Treasurer Dr. Chandrasekhar N., Chairman of Scientific Committee Dr. Lakshman sir, and towards the entire organizing committee. Needless to say that a lot of attention must have been gone towards planning of this academic content of this conference, and I am confident that the crisp scientific program would have attracted a record number of delegates from all over the Karnataka and beyond. Once again, I extend my best wishes for the grand success of the conference, eagerly waiting to meet you all physically for the next year's Kscasicon 2023. Thank you very much.
Thank you, sir, for your kind words. I would like to request Dr. Santosh John Abraham, sir, Director of Academics, ASI, to address the gathering.
Good evening, everyone. Chairman of the Karnataka State Chapter, Dr. Arvind Patel and his team of officers, Chief Guest of the evening, Dr. M.K. Ramesh, Honorable Vice Chancellor, Rajiv Gandhi University, Professor Siddesh, President, Association of Surgeons of India, and his team, represented by Dr. Sanjay Jain, Dr. Pratap Varade, and Dr. Baurlal. My colleagues in the EC, representing Karnataka State Chapter, senior surgeons, orators, and surgeons who have been felicitated by Karnataka State Chapter, and all the colleagues in surgical profession attending this meeting. It is indeed a proud privilege for me to attend this meeting. Karnataka being very close to Kerala, I have had many an occasion to visit your state, both in various occasions, your state chapter conferences, your peripheral, your midterm meets. Not less to say that the most coveted Kscasicon in Mysore, Bangalore Surgical Society meetings, and many CME programs. Karnataka, I must tell that it's a chapter which is very active in the academic deliberations. And we have great academicians in Karnataka like Dr. Lakshman, Dr. Rajan, Dr. Rajgopal Shunai, and a galaxy of eminent teachers from Karnataka. For the last 6 years, we have been having academic programs regularly, and I must thank all the heads of departments whom I have personally called at odd times, with whom I have pleaded and got the addresses and other details of the students. And I would have rubbed against some few and the wrong note for having not given me the details. They're all part of the job that I wanted to complete. And we have run this program very efficiently. And these programs will continue to exist under the leadership of Dr. Siddesh, ably assisted by other colleagues in Karnataka who are in the academic council as well as in the team of RRC. This year, the admissions to the postgraduate course have just begun, and it would complete by end of March, at which point of time either the representatives of in the EC or myself will approach each one of you for giving the details. Kindly help us so that the data bank becomes strong. I would also like you to attend in large numbers the ASI NSCP 2022 program, which again without fail Dr. Siddesh is spearheading. And it's a 2-hour program that this year we are addressing basic topics. And I'm sure that many of you are already been engaged in various deliberations of that. With this, let me conclude by best wishes to all of you and to the conference in the next 2 days till Sunday. And I'm sure with the hard work done by the organizing committee and the scientific committee, the deliberations are going to be of immense use to all the delegates. Thank you once again for having me invited to this conference. All the best. Thank you.
Thank you very much, sir. I now request Dr. Arvind Patel, sir, Chairman KSCSI, for the presidential address.
Respected dignitaries, Dr. Ramesh MK, Vice Chancellor of Rajiv Gandhi University of Health Sciences, Dr. Siddesh, our dynamic President of ASI, Dr. Sanjay Jain, Vice President of ASI, Dr. Pratap Varate, Dr. Banwar Yadav, Dr. B.N. Patil, the Chairman-elect of KCSI, Dr. Chandrasekhar and Chandrasekhar, Secretary and Treasurer of KCSI, our Governing Council members, and our EC members, my seniors, friends, and delegates. It's indeed a pleasure and honor to be amongst you on this occasion. This is the second virtual annual conference of KCSI, and as always, is going to be an academic extravaganza. All thanks to the Corona pandemic. KCSI conducted elections online for the second consecutive year for its office bearers. My sincere congratulations to Dr. H.V. Shivaram for his election as Chairman-elect 2022. I also appreciate our election officer, Dr. B.N. Patil, and the team for the smooth conduct of elections. Our scientific committee headed by Dr. Lakshman planned this event meticulously, as always, with utmost care, taking into consideration the quality of academic papers and subjects. Let me take this opportunity to thank all the members of KCSI for giving me an opportunity to serve this esteemed organization. Last 1 year, as you all know, affected our day-to-day life, but KCSI took the decision to have monthly academic meetings in the form of journal club and mortality meetings. These meetings aim to improve the academic standard of our budding surgeons, the postgraduates. Active participation from the students is much desired. Especially, we decided to instill the research angle in the minds of postgraduates for better paper presentations. At the national level also, in the organizing committee of NSCP, we have our 3 faculty members, Dr. Lakshman, Dr. Rajan, and Dr. Rajgopal Shanai, who are very active, and I congratulate them. As our chief guest, Vice Chancellor is here, I would like to make 2 submissions. During our time, means during our studies, undergraduate studies, we had multiple choice questions with the negative corrections. If it is there, it will definitely help our students to do well in All India NEET exams. There used to be 100 questions and only for 25 marks per subject. Hope our Vice Chancellor considers this. To improve the communication skill in local Kannada language, especially for students from different states, needs special curriculum design. This will help both our patients and also students. There were 6 EC meetings during our period, which were deliberated on various issues, and the decisions were unanimous most of the time. The account of our KCSI streamlined and FTs were consolidated under one account. The digitalization of records for more than 50 years is complete now, thanks to our Dr. Gadi Divakar, who did this splendid work. I congratulate and appreciate Dr. Guru Basavana Gaud for making highest number of members to Social Security Scheme this year, which is very well appreciated. I congratulate Dr. Sopimat and Dr. Divakar Gaddi for initiating many ideas, including evidence-based module during their tenure, and I'm happy that the present executive committee continued the good work. At the same time, I am confident that incoming chairman will take activities of KSC-ASI further a step ahead. I personally feel I could not take up the task of framing guidelines for ASI recognition of nursing homes and small hospitals, as NABH accreditation cost is too high, which many of them cannot afford. The research grant initiated by our SSP branch is yet to be utilized by our postgraduates. I request our medical college and DNB teaching faculty to spread the awareness to help these young postgraduates to make proper use of this grant. I thank my secretary Chandru and the treasurer Chandru for all the coordinated effort throughout this year. And also I thank my EC members for the wonderful coordinated work. Dr. Ramkrishna, who has updated the website on time, Dr. Kalaivani for bringing out colorful, useful data in eShastra magazine. Special mention about one person who is there for us every time, like Guru or Maestro. He is our scientific committee chairman, Dr. Lakshman, with his enthusiastic and meticulous job. Thanks to him for taking that extra load. I congratulate the orators of this conference, Dr. Vidyadhar Kinnan, Dr. Gabriel Rodriguez, Dr. Lakshman, Dr. Naz. And I congratulate our senior surgeons who are being felicitated today, Dr. Lakshman, Dr. S.M. Patil, and Dr. Shivkumarappa. I thank all those members who stayed behind limelights, holding the torch of KCSI to burn bright. If I have forgotten to take any names, it's purely unintentional. Thanks to all of them. Sincere thanks to Team Mysuru under the leadership of Dr. Dinesh and Secretary Chandru for managing this online conference with the help of Keystone people. I thank you one and all.
Thank you, sir. I would now like to call upon Dr. Chandrasekhar N. Sir, Treasurer KSASI, to deliver the vote of thanks.
Good evening, everyone. It's my privilege to have been asked to propose the vote of thanks on this inaugural ceremony of 40th Kscacon. On behalf of KSCSI and the organizing committee, extend my warm thanks to our chief guest of today's inaugural function, Dr. M.K. Ramesh, Vice Chancellor, Rajiv Gandhi Health University, for accepting our invitation to inaugurate the state conference in spite of his busy schedule. Thank you very much, sir. I also thank our own ever-charming, young, dynamic personality, now occupying the highest post in the ASI position in the ASI, our national president, Dr. G. Siddesh, for accepting our invitation to be the guest of honor in this inaugural function. Thank you, sir. You have surely added charm to the event. I also thank Dr. Sanjay Kumar Jain, Vice President ASI, Dr. Pratap Sinha Orute, Honorary Secretary ASI, Dr. Banwarlal Yadav, Honorary Treasurer, Dr. Santosh Jan Abraham, Director Academic Council ASI, for accepting our invitation to be the guest in our inaugural function of the state conference. Thanks a lot, sir, for giving us time in your busy schedule. On behalf of the organizing committee, we extend our warm thanks to our chairman of KCSI, Dr. Arvind Patel, for his constant guidance and encouragement to do the conference, to do this virtual conference. Thanks a lot, sir. I also thank our chairman-elect, Dr. B.N. Patil, for all his support that you have given to us. Thank you very much, sir. We, the organizing committee, wholeheartedly thank our dynamic, ever-active scientific committee chairman, Dr. Lakshman K, for all his hard work that he has put in for the success of this conference. Thanks a lot, sir. I also thank Dr. Niranjan, Dr. H.K. Ramkrishna, Dr. Naz Jahan Sheikh for their help in evaluating the papers for posters and paper presentations. We also thank our immediate office bearers, immediate past president, Dr. S.S. Sopimat, and secretary, Dr. Gadi Divakar, for constantly supporting and guiding us in conducting this virtual conference. I also thank all the state and the national EC members for their constant support and guidance. Special thanks to Dr. Dinesh Sachan, Professor and HOD Department of Surgery, Mysore Medical College, for helping us in providing the screen managers and the volunteers. We also thank all the speakers, chairpersons, judges, and the delegates for this state conference. I also thank all the screen managers, volunteers for their valuable support, and you are the real backbone of this virtual conference. We thank Mr. Anand and John from Keystone for their help in setting up the virtual conference for us. Last but not the least, I thank our dynamic secretary, Dr. Kscasicon S, for all the efforts and hard work that he has put in for the success of this conference. To end my vote of thanks speech by thanking all of you once again, this celebration would not have been possible without all your efforts. Thank you one and all.
Dr. Lakshman.
I thank Dr. Chandrasekhar N for doing excellent work, and he has all the way he has come from Tumkur to Mysore for this conference. Thank you, Chandrasekhar.
Dr. Lakshman, I see your hand.
One small request, Chairman sir. The election officer, should he announce the result? I don't know. Should it be today?
It's announced.
Can be our election officer.
Just because we are not talking.
B.N. Patel.
Election, the result announced yesterday only, sir. Out of
you just announce it to the
officially.
We'll congratulate the.
Yeah.
I announced during my talk also.
Okay.
Dr. Shivram got elected.
Congratulations, Shivram.
Yeah, he got around 443 votes, sir, Dr. Shivram. And sir, and Dr. G.B. Bidna got around 252 votes. And chairman elected Dr. Shivram, sir.
Congratulations.
Thank you.
Congratulations.
Thank you. Thank you.
Congratulations, sir. Total number of votes casted. Total number of voters are 695, sir.
Okay, fine. Thank you.
Congratulations, sir, Dr. Shivram.
Thank you, everybody.
Dr. Lakshman, sir.
No, I was just clapping the
Okay.
in favor of the volunteers who have spent a lot of time.
Yeah, absolutely.
A lot of effort. I just want to specially recognize their inputs into this conference. Thank you. Yeah.
Yes.
I know Dinesh has organized already in their one dinner. I think I was supposed to join them. Anyway,
sir,
thank you for all that.
Photos, sir.
Thank you, sir.
Yes, Dinesh, thank you.
Thank you, sir.
Good night, everybody. Is there anything else?
With this, we are.
National anthem is there?
No, sir. Tomorrow, sir. General body.
After general body.
Okay, thank you.
Thank you, one and all.
Thank you, sir.
With this, we are ending.
Thank you and good night.
Good night, my office bearers. Good night, Santosh.
Many thanks for the central office bearers for sparing the time to join us. Thank you very much.
Thank you.
Sparing time.
Thank you, Dr. Jai.
Bye. Good night.
Good night, everyone. Good night.
Shivram, sir, congratulations once again.
Thank you.
Shivram, sir, congratulations.
Congrats.
Thank you, Dr. Orte, Dr. Siddesh, Dr. Jain.
Congratulations, sir.
Banwar. Thank you. Thank you, sir. Thank you, Dr. Santosh.
Good night.
Chandru sir will close.
Yes, sir. Yes, we'll close.
Chandru.
Sir. Chandru sir.
ಇದೀವಲ್ಲ ನಾವು ಮೂವರೇನು B.N. ಪಾಟೀಲ್ ಇದ್ದಾರೆ
B.N. ಪಾಟೀಲ್
ಅದೇ ಸರ್
ಓಕೆ B.N. ಪಾಟೀಲ್
ಹೌದು ಸರ್
ಈಗ ನಾಳೆ ಒಂದು ಇಂಪಾರ್ಟೆಂಟ್ ಅಂದ್ರೆ ಜನರಲ್ ಬಾಡಿ ಇರುತ್ತೆ
ಓಕೆ
ಸೊ ಜನರಲ್ ಬಾಡಿಯಲ್ಲಿ ಕಂಟೆನ್ಷಿಯಸ್ ಇಶ್ಯೂಸ್ ಏನು ಇಲ್ಲ ಬಟ್ ಸ್ಟಿಲ್ ಅದಕ್ಕಿಂತ ಮುಂಚೆ ಪ್ರಾಬಬಲಿ ಒಂದೇ ಒಂದು ಈ ರಿಗಾರ್ಡಿಂಗ್ ಶುಡ್ ವಿ ಹ್ಯಾವ್ ಒನ್ ಅವರ್ ಓನ್ ಇದು ಅಂತ ಕೇಳ್ತಾರೆ ಅಂದ್ರೆ ಆಫೀಸು ವಾಟ್ ಎವರ್ ಇಟ್ ಮೇ ಬಿ ದರ್ ವಿಲ್ ಬಿ ಪ್ಲಸ್ ಅಂಡ್ ಮೈನಸ್ ಸೊ ಫಾರ್ ದಟ್ in fact if at all centrally if it is to be Bangalore and all purchasing a property is ruled out ನನ್ನ ಪ್ರಕಾರ right
it's impossible
if at all the center ಅಂದಾಗ ದಾವಣಗೆರೆ ಬಳ್ಳಾರಿ
or ಹುಬ್ಳಿ
ಅಂದಾಗ
ideally ಹುಬ್ಳಿ ಸರ್
ಬಳ್ಳಾರಿಯಲ್ಲಿ 400 rupees ಸ್ಕ್ವೇರ್ ಫೀಟ್ ಗೆ 15,000 ಸ್ಕ್ವೇರ್ ಫೀಟ್ ವರೆಗೂ ಕೂಡ ಚೇರ್ಮನ್ ಇಂದ ಅಲಾಟ್ಮೆಂಟ್ ತಗೊಳ್ಳೋ ಜವಾಬ್ದಾರಿ ಐ ಕ್ಯಾನ್ ಡೂ ಇಟ್
Okay.
This is
Okay.
only for your information because it cannot happen in one meeting.
Okay.
Sir,
Okay.
one
Okay.
ನಿಮಿಷ sir. We'll ask all the participants to please log out.
Okay.
ಒಂದು ನಿಮಿಷ sir. We'll ask the participants to please log out since there is a discussion for the executive committee.
Sir, GB meeting ನಾಳೆ ಸೇಮ್ ಐದಾ 8:40
ಇಲ್ಲ 8 ನಾಳೆ
8 o'clock.
8 o'clock, sir.
Okay. Okay, sir. Agenda of discussion tomorrow's meeting ಏನ್ sir?
Not ಇದು GP ಅಲ್ಲಿ ಯಾವ ಅಂತ ಮೇಜರ್ ಇಲ್ಲ. Only thing is we need to confirm orators.
Okay.
We need to confirm a symposium.
Okay.
ಬರ್ತೀರಾ ಸರ್ ಈಗ?
Audited statement to be passed.
Okay.
ಇದು ಮಾಡ್ತಿದ್ದೀವಿ ಸರ್.
ಮತ್ತೇನ್ರ ಹ್ಯಾಂಡ್ ಓವರಿಂಗ್ ಚಾರ್ಜ್ ಏನ ಆನ್ಲೈನ್
ಅದೇ ನೀವು ಬಂದ್ರೆ ದಟ್ ಇಸ್ ಆನ್ ಸಂಡೇ.
ಎಲ್ಲೇ?
ನೀವು ಬಳ್ಳಾರಿಗೆ ಬಂದ್ರೆ ಇಲ್ಲೇ
At what time, sir?
ಈವ್ನಿಂಗ್ 8 o'clock ಐತಲ್ಲ.
ಈವ್ನಿಂಗ್ 5 o'clock ಇಂದ ಅಲ್ಲಿ ಇದಕ್ಕೆ ಅಟೆಂಡ್ ಆಗ್ಬಿಟ್ರ ಅಲ್ಲೇ ಕೂಡಿ.
ಇಲ್ಲೇ ಬಂದ್ಬಿಟ್ರೆ ಗಡ್ಡಿಯ ಮನೆಗೆ
ನಾವು ನೀವು ಗಡ್ಡಿ ಅವ್ರು 3 ಕೂಡಿ ಬಿಡಮ್ ಒಂದಂತೆಲೆ ಕಾಮನ್ ಪ್ಲೇಸ್ ಎಲ್ಲಿ. ಓಕೆ. 5 o'clock ಬರ್ಲಿ ಸರ್.
ಬರ್ರಿ.
ಓಕೆ. ಸಂಡೇ ಈವ್ನಿಂಗ್ ಐ ವಿಲ್ ಬಿ ದೇರ್ at 5 o'clock. ಓಕೆ. ಇಲ್ಲಿ 3 o'clock ಬಿಡ್ತೀನಿ. 4:30 ಬಂದ್ ಅಲ್ಲಿ ಮನೆ ಟೀ ಕುಡ್ದು ಅಲ್ಲಿ ನಿಮ್ಮಲ್ಲಿ ಬಂದ್ಬಿಡ್ತೇನೆ. ನೀವ್ ಎಲ್ಲಿ ಇರ್ತೀರಿ ಅಲ್ಲಿ ಬರ್ತೀನಿ. ನಾವು 3 ಒಂದೇ ಅಂತೆಲ್ಲ ಕುಂದ್ರಮ್ಮ. ಓಕೆ. ಮತ್ತೆ ನಾಳೆ GB ಮೀಟಿಂಗ್ ನಾಗ ಏನ್ ನೀವೇ ಮಾತಾಡಿ.
ಈಗ ಇವರೆಲ್ಲರೂ ಲಾಗ್ಔಟ್ ಮಾಡ್ತಾರ.
ಓಕೆ.
Request Saida Tabsum Sashman Mallikarjun please exist.
ಫೋನ್ ಇಟ್ಬಿಟ್ಟು ಬೇರೆ
ಸರ್ ಹೌದು.
ಅಮರೇಶ್ ಇರ್ಲಿ.
ಅಮರೇಶ್ ಸರ್ ಇದಾರೆ. ಬೆಸ್ಟ್ ಪ್ಲೇಸ್ ಸಂಡೇ ಅಲ್ಲೇ ಸರ್ ಗಡ್ಡಿ ಸರ್ ಮನೆಯಲ್ಲಿ ಅಲ್ಲಿ ಟಾಕ್ ನಿಮ್ದಾಗಿತ್ತಲ್ಲ ಸರ್.
ಹೇಳಿ ಚಂದ್ರು. ಎಲ್ಲವೂ ನಮಗೆಲ್ಲ ಕಾಮನ್. ಅದಕ್ಕೆ ಏನ್ ಮಾಡಿ ಒಂದು ಪ್ರಿಂಟೆಡ್ ವರ್ಷನ್ ಇಟ್ಕೊಂಡಿದ್ದೆ. ಇಲ್ಲ ನಡೀತೈತೆ. ನಾನು ಅದಕ್ಕೋಸ್ಕರ ಆಲ್ವೇಸ್ ಐ ಕೀಪ್ ಸ್ಟ್ಯಾಂಡ್ ಬೈ.
ಅಮರೀಶ್ ಸರ್
ಹೇಳಿ ಅಣ್ಣ.
ಇಸಿ ಮೀಟಿಂಗ್ ಏನೇನ್ ಸರ್? ಅರವಿಂದ್ ಸರ್, BN ಪಾಟೀಲ್ ಸರ್ ಹಂಗೆ ಡಿಸ್ಕಸ್ ಮಾಡ್ತಿದ್ರು.
ಓಕೆ. ಇಲ್ಲ ನಾನು ಎಕ್ಸಿಟ್ ಆಗ್ಲಾ
ಸರ್ ಒಂದ್ಸರಿ ಕೇಳಿದ್ರು ನಿಮ್ಗೆ.
ಓಕೆ.
ಅರವಿಂದ್ ಸರ್.
ಓಕೆ.
ಅಲ್ಲ ಒಂದ್ ನಿಮಿಷ ಚಂದ್ರು ನೀ ಇದೆಯಲ್ಲ
ಇದ್ರಲ್ಲಿ ಇಲ್ಲ ಸರ್ ಚಂದ್ರು ಸರ್.
ಚಂದ್ರು ಮತ್ತೆ ಲಾಗಿನ್ ಇರ್ಲಿ ಬಿಡು. ನಾನು ಅದೇ ಏನಿಲ್ಲ, ಐ ಜಸ್ಟ್ ನಾಳೆ ಇದ್ರದ್ದು ಬರ್ಬೋದು, ಯಾವುದು ನಾಳೆ ಡಿಸ್ಕಷನ್ ಅಬೌಟ್ ಅಮೌಂಟ್ ಅಂಡ್ ಇನ್ವೆಸ್ಟ್ಮೆಂಟ್ ಬರ್ಬೋದು. ಬಂದ್ರೆ ಯು ಕ್ಯಾನ್ ಟೇಕ್ ಇಟ್. ಅಂದ್ರೆ ನಾನೇನ್ ಹೇಳ್ತೀನಿ, ನೆಕ್ಸ್ಟ್ ಇನ್ಕಮೆಂಟ್ ಚೇರ್ಮನ್ ಇದನ್ನ ಕಮಿಟಿ ಅಂಡ್ ವಾಟ್ ಎವರ್.
ಓಕೆ,
ಹಲೋ, ನಾನು ಮಾತಾಡ್ತೇನೆ. ಕಮಿಟಿ ಅಂಡ್ ದೆನ್ ಓನ್ಲಿ ಥಿಂಗ್ ಈಸ್ ಇಟ್ಸ್ ಎ ಪ್ರಾಸೆಸ್. ಅಂದ್ರೆ ಒಂದು ಕಮಿಟಿ ಫಾರ್ಮ್ ಮಾಡಬೇಕು, ಕಮಿಟಿಯಿಂದ ರೆಕಮೆಂಡೇಶನ್ ಬರಬೇಕು, ರೆಕಮೆಂಡೇಶನ್ ಇಸಿ ಅಲ್ಲಿ ಡಿಸ್ಕಷನ್ ಆಗ್ಬೇಕು, ಇಸಿ ಇಂದ ಮತ್ತೆ GM ಹೋಗ್ಬೇಕು, ಆಮೇಲೆ ಅದು ಬರ್ಬೇಕು.
Okay.
It's a big process. It cannot happen in one meeting.
We'll put a proposal, sir, to whether ideal place is center of the Karnataka, Davangere, Hubli or Ballari. 3 places. Majority opinion will consider.
Even Davangere kuda okay, but ಏನಂದ್ರೆ Davangere active ಇಲ್ಲ.
ಅಲ್ಲ, Davangere active ಇಲ್ಲ. Best is either Ballari or Hubli.
No problem.
Eradu okay. Majority is opinion. Whoever majority of the people, whatever they decide, will go according that. But land and noda.
Another thing is identify at different places, submit it to the committee, whatever the committee and AGM then.
Okay. What preferably North Karnataka better nodam, sir. Either Hubli, Davangere idu. ಮತ್ತ ಇನ್ನೊಂದು ಆಪ್ಷನ್ ಹಂಗೇನ್ ಸರ್ ಅಂದ್ರೆ ಸಿದ್ದೇಶ್ ಮೈಸೂರು ಒಂದು ಇದು ನೋಡಮ್.
ಮೈಸೂರು ಬಹಳ ಕಾರ್ನರ್ ಆಗುತ್ತೆ,
ಅದು ಪೂರಾ ಎಂಡ್ ಆಗ್ಬಿಡ್ತಾ. ಒಂದೇನಂದ್ರೆ ಐಡಿಯಲ್ ಪ್ಲೇಸ್ ಅಂದ್ರೆ ಒಂದು ಏನಾರ ಎಲ್ಲರೂ ಹೋಗಿ ಆ ಕಡೆ ಮಲ್ಟಿಪಲ್ ಪ್ಲೇಸಸ್ ಗೆ ಇದಕ್ ಹೋಗ್ಬಹುದು ಅಷ್ಟೇ. ದಟ್ ಇಸ್ ದ ಓನ್ಲಿ ಅಡ್ವಾಂಟೇಜ್ ಅಷ್ಟೇ ಮೈಸೂರು. ಹೌದಿಲ್ಲ ಸರ್? ಆದ್ರೂ ಮೆಜಾರಿಟಿ
ಸೆಂಟರ್ ಆಫ್ ದ ಸ್ಟೇಟ್ ಆಲ್ವೇಸ್ ಪ್ರಿಫರ್ಡ್.
ಬೆಟರ್ ಆಲ್ವೇಸ್ ಬೆಟರ್. ಬಳ್ಳಾರಿ ಆರ್ ಹುಬ್ಳಿ. ಓಕೆ. ಮತ್ತ ಅವ್ರು
ಮತ್ತೇನು ಇಂಪಾರ್ಟೆಂಟ್ ಯಾವ ಇಲ್ಲ.
ಓಕೆ. ನಿಮ್ದು ಇದು ಬುಕ್ ಆಫ್ ಅಕೌಂಟ್ಸ್ ಅದೆಲ್ಲ ಇದನ್ನ ಪ್ರೆಸೆಂಟ್ ಮಾಡಿ
ಆಡಿಟೆಡ್ ಕೊಟ್ಟಿದ್ವಿ. ಏನ್ ಖರ್ಚೇ ಜಾಸ್ತಿ ಇಲ್ಲ ಕೋವಿಡ್ ಇದಕ್ಕೆ.
ಅಲ್ಲ, ಮನಿದ್ ಏನ್ ಪ್ರೆಸೆಂಟ್ ಮಾಡಿದ್ರೆ ಸೇಮ್ ಅಮೌಂಟ್ ವಿಲ್ ಬಿ ಕಂಟಿನ್ಯೂಡ್ ಇನ್ ದಟ್.
ಹೌದು, ಆಲ್ವೇಸ್ ಲೈಕ್ ದಟ್.
ಓಕೆ. ಆಮೇಲೆ ಏನ್ ಅಥಾರಿಟಿ ಸೈನಿಂಗ್ ಅಥಾರಿಟಿ ಏನ್ ಚೇಂಜ್ ಆಗ್ತಾನೆ ಸರ್? ಏನಿಲ್ಲ.
ನೆಕ್ಸ್ಟ್ ಈಗ ಸೆಕ್ರೆಟರಿ ಅಂತೂ ಆತ ಇದ್ದಾನೆ.
ಟ್ರೆಜರರ್,
ಸೆಕ್ರೆಟರಿ ಅಂಡ್
Treasurer and secretary same sir.
Treasurer and secretary will be continued for 1 more year.
ನಮಗೆ ಪ್ರಾಬ್ಲಮ್ ಇಲ್ಲ.
ಓನ್ಲಿ ಪ್ರೆಸಿಡೆಂಟ್ ಅಷ್ಟೇ ಚೇಂಜ್ ಅಷ್ಟೇ, ಮತ್ತೇನಿಲ್ಲ. ನಮ್ದೇನ್ ಇರಂಗಿಲ್ಲ ಅಲ್ಲ, ಓನ್ಲಿ ಟ್ರೆಜರರ್ ಇದಲ್ಲ ಸೈನಿಂಗ್ ಅಥಾರಿಟಿ.
ಟ್ರೆಷರ್ ಜೊತೆಗೆ ಐದರ್ ಪ್ರೆಸಿಡೆಂಟ್ ಆರ್ ಸೆಕ್ರೆಟರಿ ಅಂತ ಇರ್ಬೇಕದು.
ಓಕೆ.
ಸೊ ಅವರಿಬ್ರು ಇರೋದ್ರಿಂದ ಪ್ರಾಬ್ಲಮ್ ಇಲ್ಲ.
ಓಕೆ. ಮತ್ತೆ ಎಕ್ಸ್ಪೆಂಡಿಚರ್ಸ್ ಏನಿಲ್ಲಲ್ಲ, ಕೊಡವಂತ ಯಾವ ಇಲ್ಲಲ್ಲ.
ಯಾವ ಇಲ್ಲ.
ಓಕೆ. ಈ ಕಾನ್ಫರೆನ್ಸ್ ಪೇಮೆಂಟ್ ಅದೆಲ್ಲ ಆಗಿತ್ತನ್ ಸರ್?
ಅಂದ್ರೆ ಈಗ ಅವ್ರಿಗೆ ಹೋಗಿರುತ್ತೆ ದುಡ್ಡು, ಅವರೇ ಕೊಡ್ಬೇಕು. ಈಗ
ಅವರೇ ನಮಗ್ ಕೊಡ್ಬೇಕು ವಾಪಸ್.
ನಾವೇ ಕೊಡ್ಬೇಕು. ಅದು ಆನ್ಲೈನ್ ರಿಜಿಸ್ಟ್ರೇಷನ್ ನಮ್ಗೆ ಬರುತ್ತಲ್ಲ ಸರ್?
ಹೌದು.
ಗೇಟ್ವೇ ಇಂದ ನಾವು ಸರ್ ಕೊಡ್ತೀವಿ.
ಓಕೆ.
ಕಂಗ್ರಾಚುಲೇಷನ್ BN Patil sir.
Thank you sir.
Congratulations for Arvind sir also for
sir. ನಿಮ್ಮ ಅರವಿಂದ್ ಪಟೇಲ್ ಅವರು ನಿಮ್ದು ಎಲ್ಲ ಸಪೋರ್ಟ್ ಇರ್ಬೇಕು ಸರ್. ನನ್ನ
ಅಲ್ಲ, whether past chairman or not or whatever it may be, anytime you have got the right to ask anything.
ಅಲ್ಲ, you are always there ಬಿಡ್ರಿ. ನಾಟ್ ಓನ್ಲಿ ಇದ ಪ್ರೆಸಿಡೆಂಟ್ ಅದಿರಿ ಅಂತಾನೆ ಇಲ್ಲ, ಯಾವಾಗ್ಲೂ ಅದಿರಿ ವಿತ್ ಅಸೋಸಿಯೇಷನ್. ಹೌದಾ? ಸ್ವಲ್ಪ ಹೆಲ್ಪ್ ಮಾಡ್ಬೇಕದ. ನೀಡ್ಸ್ ಯುವರ್ ಗೈಡೆನ್ಸ್ ಅಂಡ್ ಅದರ್ ಥಿಂಗ್ಸ್. ಹೌದಾ? ಆಮೇಲೆ ನಮ್ದು ಏನ್ ಇದಿರ್ತನ್ ಸರ್ ಇನಾಗ್ರಲ್ ಏನ್ ಇರಲ್ಲ ಸರ್?
ಇಲ್ಲ,
ಏನಿಲ್ಲಲ್ಲ.
ನೀವು ಅಲ್ಲಲ್ಲ, ಆಕ್ಚುಲಿ ಇಫ್ ಇಟ್ ಈಸ್ ರಿಕ್ವೈರ್ಡ್ ಅಂದ್ರೆ ನಾವು ಫಿಸಿಕಲ್ ಇದ್ದಾಗ ಬಂದಿರ್ತಾರಲ್ಲ ಅಂತ ಒಂದು ಎಕ್ಸಿಕ್ಯೂಟಿವ್ ಕಮಿಟಿ ಮೀಟಿಂಗ್ ಮಾಡ್ತಿದ್ವಿ.
ಓಕೆ.
ಈಗ ಆನ್ಲೈನ್ ಇರೋದ್ರಿಂದ ಅವತ್ತಿನ ದಿವಸ ಮಾಡಲ್ಲ ಅಷ್ಟೇ.
ಓಕೆ. ಆಯ್ತು. ಮತ್ತೇನ ಅಲ್ಲ, ಇದು ಯೂಶುವಲಿ ಫಿಸಿಕಲ್ ಇದ್ದಾಗನ ಇನಾಗ್ರಲ್ ಇದು ಸ್ಪೀಚ್ ಏನ್ ಇರ್ತಾ ಆಫ್ಟರ್ ಟೇಕಿಂಗ್ ಓವರ್ ಇಲ್ಲಲ್ಲ? ಓಕೆ. ಈಸ್ ದೇರ್ ಎನಿ ಬುಕ್ಸ್ ಅಂಡ್ ಇದರ್ ಥಿಂಗ್ ಈಗ ಇದ್ರು ನಮ್ಮ ASI KSC ಕಾನ್ಫರೆನ್ಸ್ ಸ್ಪೀಚ್ ಅವು ಏನ ಬೇಕಾ ನೋಡ್ತಿರ್ಬೇಕಾ? ಏನಿಲ್ಲ, ನಾಟ್ ನೆಸೆಸರಿ.
ಏನ್ ಬೇಡ ಈಗೇನು.
ಅಲ್ಲ, ರೆಡಿಮೇಡ್ ಏನ್ರ ಇವು ಅದಾವ ಬುಕ್ಸ್ ಏನ್ರ? ಮೊದ್ಲ
ಬೈಲಾ ಬುಕ್ ಒಂದ್ ಇರ್ತತೆ, ಅದು ಸೆಕ್ರೆಟರಿ ಅದಾರಲ್ಲ, ಯಾಕೆ ತಲೆ ಕೆಡಿಸ್ತೀರಿ?
ಓಕೆ. ಅಲ್ಲ, ಇವು ಎಲ್ಲ CME ಸರ್ಜಿಕಲ್ CME ಸ್ಪೀಚಸ್ ಏನ್ರ ಅದಾವ? ಏನ್ರ ಜಸ್ಟ್ ಹ್ಯಾವ್ ಎ ಲುಕ್.
ಯಾವಾಗ
ಯಾವಕರ CME ಗೆ ಅದಕ್ಕೆ
ಈಗ ನಿಮ್ಮನ್ನ ಈಗ ಫಿಸಿಕಲ್ ಈಗ ನೆಕ್ಸ್ಟ್ ಆಗ್ತಾವಲ್ಲ, ಕರಿತಾರ ಮತ್ತೆ ಅವರು.
ಓಕೆ. ಅಲ್ಲ ಅದ್ರ ಏನ್ರ ಇದು ಬುಕ್ಸ್ ಏನ್ರ ಅದಾವ ಟು ರೆಫರ್?
ಇಲ್ಲ ಬೇಡ, ಏನಿಲ್ಲ ಅಂತದೇನಿಲ್ಲ.
ಓಕೆ. ಇನ್ಮೇಲೆ ಫಿಸಿಕಲ್ ಆಗುತ್ತೆ ಸರ್, ಮೋಸ್ಟ್ಲಿ ವರ್ಚುವಲ್.
ಅದೇ ಇನ್ಮೇಲೆ ಫಿಸಿಕಲ್ ಆಗುತ್ತೆ, ನೀವು ಹೋಗಿ ಓಡಾಡ್ಬೇಕು ನೀವು.
ಆಯ್ತು, ಗುಲ್ಬರ್ಗ ಅಂಕರ್ ಮೋಸ್ಟ್ಲಿ ಫಿಸಿಕಲ್ ಕಾನ್ಫರೆನ್ಸ್ ಈ ಸಲ ಆಗುತ್ತೆ ಸರ್.
99% ಆಗುತ್ತೆ.
ಸರ್ ಹೇಳ್ಯಾರ ಸರ್, ಸಿದ್ದೇಶ್ ಸರ್ ಇಬ್ರು ಕೂಡ ಹೋಗಮ್ಮ, ಎಲ್ಲಲ್ಲಿ ಹೋಗಮ್ಮ ಅಂತ ಹೇಳಿ.
ಅದೇ ಬರ್ತಾರ
ಅವ್ರು ಬಂದ್ರೆ ಇನ್ನೂ ಚಲೋ ಸರ್. ಅವ್ರಿದ್ರ ನ್ಯಾಷನಲ್ ಪ್ರೆಸಿಡೆಂಟ್ ಆತರ, ನಾವು ಅವ್ರು ಕೂಡ ಹೋಗ್ಕೊಂತ ಹಿಂಗ ನಡೆದು ಹೋಗ್ಬಿಡ್ತಾ. ನಾವ್ ಒಬ್ರೇ ಹೋಗೋದಕ್ಕಿಂತ ಸರ್ ನಾವು ಕೂಡ ಹೋಗೋದ್ ಇನ್ನೂ ಬೆಟರ್. ಮತ್ತೆ ಇಟ್ ಮೇ ನಾಟ್ ಬಿ ಪಾಸಿಬಲ್ ಫಾರ್ ಆಲ್ ಟೈಮ್ ಮೋಸ್ಟ್ಲಿ, ಹೌದಿಲ್ಲ? ಕೆಲವೊಂದು ಇದ್ರಾಗ ಇಬ್ರು ಕೂಡ್ಬಹುದು. ಮತ್ತ ಯಾವಾಗ್ಲೂ ಫ್ರೀ ಇರ್ಬೇಕಲ್ಲ, ಹೌದಿಲ್ಲ? ಬರ್ತೀನಿ ಅಂತ ಹೇಳ್ಯಾರ, ವಿಲ್ ಸಿ. ಇಫ್ ಹಿ ಕಮ್ಸ್ ಅಂದ್ರೆ ಇಟ್ಸ್ ಬೆಟರ್ ಆಲ್ವೇಸ್. ಸರ್ ಇದ್ಬಿಟ್ಟು ಸ್ವಲ್ಪ ಧೈರ್ಯ.
ಹಲೋ.
ಹಾ ಸರ್, ಕ್ಲೋಸ್ ಮಾಡೋಣ ಸರ್.
ಓಕೆ, ಕ್ಲೋಸ್.
ಓಕೆ,
ಥ್ಯಾಂಕ್ ಯು ಸರ್. ಗುಡ್ ನೈಟ್ ಸರ್, BN ಪಾಟೀಲ್ ಸರ್, ಅರವಿಂದ್ ಸರ್.
ನಮಸ್ಕಾರ ರೀ. ನಮಸ್ಕಾರ.
ಗುಡ್ ನೈಟ್ ಸರ್. ಗುಡ್ ನೈಟ್.
ಗುಡ್ ನೈಟ್. ಗುಡ್ ನೈಟ್. ಮತ್ತೆ ಆರಾಮದಿರಲ್ಲ? ಹಲೋ
ಹೇಳಿ ಸರ್.
ಹುಬ್ಳ್ಯಾಗ ಇರ್ತೀರಾ?
ಹುಬ್ಳ್ಯಾಗೆ ಸರ್. ಮತ್ತೆ
ಹೌದಾ? ಓಕೆ ಓಕೆ. ಈ ಸಲ ಬಂದ ಭೇಟಿ ಆಗ್ತೀನಿ.
ಬರ್ರಿ ಸರ್, 1 year ಕೆಲಸ ಮಾಡ್ಬೇಕಲ್ಲ ಚಲೋ.
ಅಲ್ಲ ಆಮೇಲೆ ಈಗ ಇದು ಎಲ್ಲ ಇನ್ಮೇಲೆ ಮೆಸೇಜಸ್ ಕಳಿಸ್ಬೋದಲ್ಲ, KSI ASI KS ಇಂದ?
ಕಳಿಸ್ತಾ ಇದೀವಲ್ಲ ಸರ್, ಕಳಿಸ್ತಾ ಇದೀವಿ.
ಅಲ್ಲಲ್ಲ, ಇನ್ ಎನಿ ಫೆಸ್ಟಿವಲ್ಸ್ ಅದು ಇದು ಫ್ರಮ್ ಮೈ ಸೈಡ್ ಕ್ಯಾನ್ ಐ ಸೆಂಡ್ ಇಟ್? ನೀವು ಕಳಿಸ್ತೀರಿ?
ಕಳ್ಸೋಣ ಸರ್, ಕಳ್ಸೋಣ. ನೋ ಪ್ರಾಬ್ಲಮ್.
ರೆಗ್ಯುಲರ್ ಕಳಿಸ್ರಿ. ಅದ್ ಏನಾರ ಬೇಕಾದ್ರೆ ನನ್ ಪರ್ಸನಲ್ ಇದ್ರೆ ಐ ವಿಲ್ ಪೇ ಫಾರ್ ದಟ್.
ನೋ ಪ್ರಾಬ್ಲಮ್ ಸರ್.
ಪ್ರತಿ ಇದಕ್ಕೂ ಹಬ್ಬಕ್ಕೂ ಅದಕ್ಕೂ ಫೆಸ್ಟಿವಲ್, ಆಮೇಲೆ August 15th ಮತ್ತೆ ಯಾವರ ಫೆಸ್ಟಿವಲ್, ಯುಗಾದಿ, ದಸರಾ, ದೀಪಾವಳಿ ಎಲ್ಲ ಹೋಗ್ಬೇಕು.
ಒಂದ್ಸರಿ ಬಂದ್ರೆ ಸರ್ ಕುಂತ ಎಲ್ಲ ಡಿಸ್ಕಸ್ ಮಾಡಿ.
ಓಕೆ. ಆಮೇಲೆ ಡಾಕ್ಟರ್ಸ್ ಡೇ ಅದು ಇದು ಎಲ್ಲ ಹೇಳ್ಬೇಕು. ರಿಪಬ್ಲಿಕ್ ಡೇ, ಡಾಕ್ಟರ್ಸ್ ಡೇ, ಇಂಡಿಪೆಂಡೆನ್ಸ್ ಡೇ. ಓಕೆ, ವಿಚ್ ಮೆಸೇಜಸ್ ಹೋಗ್ಬೇಕು ನೋಡ್ರಿ ರೆಗ್ಯುಲರ್. ಓಕೆ, ಅದೇನಿದು ಬಂದ ಮಾತಾಡ್ತೀನಿ ನಾನು. ಓಕೆ, ಥ್ಯಾಂಕ್ ಯು. ಗುಡ್ ನೈಟ್.